Good afternoon, everybody. We welcome you to the second day of the pediatric endocrinology update. I'm sure you all would have enriched by the excellent galaxy of speakers and the talks and the quality of the content yesterday. Today, we shall start with the session with the oral and poster presentations. We shall start the poster initially and then go to the oral presentations in the next couple of hours or so. Research presentation is actually the platform where the young residents get a feel of how to present and what is to conduct a research activity in their journey into the medicine in future. So without wasting much time, I shall introduce the judges for today's session. We have Professor Unnikrishnan, who is the known endocrinologist across India and possibly this part of the globe. He is CEO and endocrinologist at the Jalaram Diabetes Institute, Pune, and is awarded Professor Sam GP Moses Oration at RSSD Lucknow. We have Dr. Modi, who is yet to join, who will be joining sometime later, and Professor Jindal, who is also will be joining later. We have Dr. Ameya, who is also going to be there today, and Professor Ganesh, who is consultant endocrinologist at Mangalore Clinic. And we have Dr. Sunil, who is going to join soon. The rules of the presentation are very clear. It is you have to present in 2 minutes, and thereafter the judges will ask you a couple of questions on the case, whatever, and the next presenter will come on as per the sequence which have been submitted. So we shall start the presentation. Since the timelines have to be met, we are going a bit fast, but within the given times. I request the first participant, Dr. Monam Chattopadhyay, to present the case.
A very good afternoon to the respected faculty members. I am Dr. Monam Chattopadhyay, postdoctoral trainee, Department of Endocrinology, NRS Medical College, Kolkata. Today I am going to present a peculiar case of disproportionate short stature with young diabetes. A 17-year-old boy presented with a failure to gain height with lower limb deformity evident since 8 years and recent onset diabetes since last 3 years. He also had a fracture on trivial trauma 5 years back. He is on insulin. There were no history suggestive of muscle or bone pain, weakness of proximal muscle, hair loss, dental abscess, enthesopathy, recurrent attacks of flaccid paralysis, pain abdomen, Cushingoid stigmata, or steroid abuse. Just show the table of oxological survey where we can see the height to be less than third percentile, weight and BMI was less than third percentile as well. Height SDS was severe short stature minus 5.4, weight SDS was minus 3.4, although pubertal status was normal. Now, if we look at the figure 1 showing the patient, we can notice that he had the following rachitic deformities in the form of knock knee, bowing of legs, dental malocclusion, frontal bossing, midfacial crowding, and increased intermalleolar distance. Now, coming to the investigations, we can see that there was hyperglycemia and A1C of 8%, decreased C-peptide, and GAD65 antibody was positive, all indicative of type 1A DM. And if we can see the skiagram, that is figure 2 and 3 of the hand and the knee, you can see the changes like irregular epiphysis, widened growth plate, fraying and cupping of the metaphyseal end, all suggestive of rickets. His chronological age was way more than the bone age and height age, which were 15 and 9 years respectively. Strikingly, the urine pH was alkaline in face of very mild metabolic acidosis in ABG with a normal anion gap. Ultrasound showed bilateral medullary nephrocalcinosis. We further did ammonium chloride challenge, which revealed rickets was due to distal renal tubular acidosis. Now we can see in the case that although type 1 diabetes and distal RT both are essentially related to several autoimmune disorders, their coexistence has been very scarcely documented. Possibly our case represents the third of its kind, and it underscores and affirms the importance to screen for distal renal tubular acidosis in patients with type 1 diabetes presenting with short stature and musculoskeletal deformities. Thank you for your patient hearing. Hello.
Yeah.
What do you think? Which one started first, either RTA or type 1 diabetes? Whether in this patient, so do you think RTA preceded much before type 1 diabetes?
Sir, RTA was the presentation of diabetes was very late. It may be due to the neglect of the patient, but RTA was evident from very tender age, say about 12 to 13 years, because of the deformities came to be evident due to weight bearing and all.
Any study you are aware of regarding bone health in type 1
Yes.
diabetes conducted in India, and any specific investigations you would like to add on to optimize bone health?
Specific investigations, sir, we can do a BMD DEXA scan to check for bone health, but I'm not aware of in case of type 1 young diabetes in long term. And we can go for bone histomorphometric analysis as well, if
Any
it is.
specific reason for that?
Sir, to look for any changes in the, any rachitic changes in of the osteoid matrix, the unmineralized osteoid matrix.
Shall go to the next case because
Thank you, sir.
thank you, Dr. Mona.
Thank you, sir.
Request Dr. Kaushal to present the case.
Dr. Hari, the host has muted me. My video and audio. Audio is on, but video, you cannot start your video because host has disabled it. It's coming like that.
We'll check, sir.
Now
Okay.
you can speak, sir. Now you can speak, sir.
Okay. No, it is not starting. Message, you cannot start your video because host has disabled it. Okay. Okay, please go ahead. Now it is all right.
Good afternoon, faculties. Today I'll be presenting a case of resistant pigmentation. So we had a 14-year-old girl. Please scroll down. So we had a 14-year-old girl presented to us with a complaint of generalized hyperpigmentation of the skin and oral mucosa, and it all started when she was around 4 years of age. And there was a history of recurrent infection around the same time the hyperpigmentation appeared. And after 6 months of hyperpigmentation, pediatrician sent random serum cortisol, and it turned out to be 0.3 microgram per deciliter. But at that time, her electrolytes were normal, sodium being 140 and potassium being 3.5 milliequivalent per liter. So she was started on oral hydrocortisone replacement therapy at 12 milligram per meter square, and the patient was quite compliant with the treatment. But her mother complained that hyperpigmentation is not improving. So again, later on in 2011 and 15, her ACTH level were repeated, and surprisingly, it came out to be more than 2000 picogram per ml. After that, she came to us in 2019. On a detailed history, she was a product of consanguineous marriage. The non-compliance was again ruled out. Her BP was 110/70, and her electrolytes were normal again. So we repeated her ACTH again, and it came out to be again more than 2000 picogram per ml. So in view of normal electrolytes at the time of diagnosis, persistent hyperpigmentation, and yes, sir, because of the high ACTH level, in between supraphysiological dose of hydrocortisone was also tried, that is 20 milligram per meter square for a year long, but still there was no response in the hyperpigmentation. So in view of normal electrolytes at the time of diagnosis and persistent hyperpigmentation and supraphysiological doses of hydrocortisone, we suspected a diagnosis of familial glucocorticoid deficiency, and we sent a genetic analysis, and it came out to be positive for a thyroredoxin reductase type 2 gene. Here we can see a girl before diagnosis at around 3 years of age. Second peak is at the time of diagnosis around 4 years of age, and this is a current recent peak of 2019, and we can see there is no improvement in the hyperpigmentation. This gene mutation is recently described in 2014 in one article in JCEM, and this could be probably the first reported mutation from the India. There is associated delayed puberty in such patient, and our patient had the same complaint. She attained her menarche at the age of 12 years, but her puberty came at around 13 years of age. And there was a scanty pubic hair, and there are still no axillary hair. So there is an association with the FGD. And this novel mutation throws a light on the redox pathway of steroidogenesis. There is a known mutation at the receptor level, but there is a defect in the steroidogenic pathway due to excessive oxidative stress. So, yeah, that's all from my side. Thank you.
So, doctor, could you share with us what is the long-term outcome of these patients, and also why is there a discordance between the pubarchy and the menarche in this, or hypothesize reasons for that?
Yes, sir. Sir, in a long-term outcome also, sir, even with the high dose of steroid, there can't be improvement in the pigmentation because of the ACTH resistance, and patient will be pigmented for a lifelong. The discordance is there due to, sir, because the ovarian steroidogenesis will be normal and pituitary gonadal excess will be normal. So patient will attain menarche, but adrenal steroids won't be there. So there is a delayed pubarchy in such patient. Because of the ACTH resistance, adrenal steroidogenesis won't be normal.
Did you consider CAH due to 11-beta hydroxylase deficiency, since the potassium was on the lower limit of normal at the time of diagnosis? Because in adrenal insufficiency, you expect always the potassium to be on the higher side. Here, potassium was 3.5.
Yes,
so
sir,
the
but,
11-beta
sir,
hydroxylase, what was the blood pressure?
Yes, sir. Sir, it was initially diagnosed at 4 years of age. Sir, she came very late to us. But on finding documents, sir, there was no any history of hypertension during the follow-up also. And at the time of diagnosis also, sir, there was no history of hypertension. Sir, exact blood pressure I don't remember. But
17 hydroxyprogesterone level was done. Was it done?
No, sir, that was not done at that time of diagnosis, sir. Sir, there was no history of salt fasting crisis also, and the mineral cortical axis was normal. And the pediatrician did not order it.
Thank you, Dr. Kaushal. We shall move to the next case, Dr. Harshita Reddy.
Good afternoon, everybody. Today I'll be presenting a case about a young girl who was 9 years old who presented with a CNS germ cell tumor. The girl was brought by her mother to our OPD around 6 months back with history of easy fatigability and weight loss of around 3 kgs in the last 20 days. She was evaluated elsewhere and was found to have low TSH and increased T4, and a technician scan was done, which showed a picture suggestive of thyroiditis. However, on probing further, mother gave a history that the child had polyuria, polydipsia, salt craving since 1 to 2 months. So on examination, the child was conscious and oriented. Her pulse rate was 86 per minute and her BP was normal. Her height and weight were in the 50th centile and Tanner staging was prepubertal. She had no cranial nerve deficits, and by confrontation, visual field testing was normal and fundus was also normal. Down, please. In view of a history of polyuria, polydipsia, salt craving, a pituitary hormonal workup was done, which showed a low 8 AM cortisol, which was around 0.6, an inappropriately low ACTH, and an FSH and LH, which were prepubertal, and again a low TSH with a high T4, with a slightly raised serum prolactin and a low urine osmolality around 100 milliosmoles. Given this clinical picture, an MRI pituitary was done, which showed a suprasellar mass of around 3.5 into 3.5 into 3.3 centimeters, and anterior pituitary gland was actually visualized separately. This was reported to be possibly craniopharyngioma or an optic chiasmal glioma. However, since the child had biochemical thyrotoxicosis, the possibility of a beta HCG secreting CNS tumor was suspected, and the beta HCG was done, which was actually very high, around 17,000 IU per ml. Her AFP was normal. Hence, a diagnosis of choriocarcinoma was made, and further workup for metastasis was negative. The child was also started on hydrocortisone replacement and desmopressin nasal spray prior to starting her on chemotherapy. At the end of the first cycle of chemotherapy, she became euthyroid, and as of now, she has completed 5 cycles of chemotherapy. She's asymptomatic, and beta HCG done at follow-up has right now dropped to 16 IU per international units. And she is euthyroid. However, she's still being continued on hydrocortisone replacement. This case highlights the unusual presentation of a CNS germ cell tumor as paraneoplastic thyrotoxicosis in a young girl, and it highlights the need for comprehensive history taking and detailed evaluation. Thank you.
I had actually two comments to be made. One is the growth of the girl was completely normal, and your technetium scan revealed thyroiditis. Can you tell me the difference between hyperthyroidism and thyrotoxicosis?
Thyrotoxicosis, the cause can be anywhere. It can be either the thyroid gland or outside the thyroid gland. Either it could be central causes, whereas the hyperthyroidism is a problem per se in the thyroid gland. Thyrotoxicosis secondary to a thyroid disease.
So what was there here?
So,
what was the case here?
Sir, actually, the Graves' disease was suspected in this child because she presented with that history and those investigations. However, technetium scan ruled out Graves' disease. Given the other history also along with this thyroiditis, we felt that it could be less likely, and that is the reason why we went with further hormonal workups.
Was the MRI repeated?
Sir, it is we are planning to repeat the MRI in another 2 weeks after she completes all the 6 cycles of chemotherapy. She is right now on the 6th cycle now. Her beta HCG has come down, sir. Actually, at 3 weeks it was 660. Now it is 16.
Only chemotherapy is
Yes,
planned.
sir.
If suppose
Yes,
suppose if the tumor is intact, are you planning for radiotherapy or only chemotherapy?
Sir, actually, with cisplatin and etoposide, the oncology team feels that the tumor is might highly be responsive to chemotherapy in this current scenario. The possibility of the child going to radiotherapy is less likely.
Thank you, Dr. Arshita. We move to the next case by Dr. Madhusmita Sahu.
Good afternoon, esteemed professors. I'm going to present a case report, which is a rare case of neurotuberculosis presenting as panhypopituitarism. So this patient presented to us at 11 years, 9 months of age, a female child who presented to us with polyuria, polydipsia, headache and weight loss since last 6 months. On examination, her vitals were normal without any postural drop. At presentation, her height and weight were both below 3rd centile, and pubertal status was A1, P1, P3. We did documented the polyuria and went ahead with other biochemical parameters which showed to be normal. So were the thyroid function tests. On other hormonal parameters, her 8M cortisols was low, which was 5 microgram per DL, with a low IGF-1, which was less than the age of value. The water deprivation test was done, which was suggestive of central type of diabetes insipidus. At that time, the ophthalmological evaluations and the perimetry were fairly normal. The MRI of pituitary hypothalamus was suggestive of a supracellular mass, which was around 1.1 into 1.7 into 2 centimeter. And we sent the patient for biopsy, and the biopsy from the hypothalamic mass was suggestive of tuberculosis. She was then started with ATT. However, there was poor compliance for the treatment and follow-up in the intensive phase of ATT, and just before 2 months, she again presented to us, but this time with polyphagia and a weight gain. This time also her height was below 3rd centile, but the weight has increased to 75th to 90th centile. On examinations, she was hypertensive and dysglycemic, and there was new onset central type of hypothyroidism. Perimetry at this time was suggestive of bilateral temporal field defect, and sure enough, the repeat MRI was suggestive of increase in the size of the mass. So we adjusted her ATT and we replaced the hormones, and she's on follow-up. Can we scroll down? So this is how the patient presented to us in the first visit, and this was a presentation in the subsequent visit. This was the perimetry in the first visit, and showing the perimetry in the second visit. And in the second visit, this is the MRI finding, which was suggestive of increase in size of the mass. Can you scroll down, please? So basically, tuberculosis of CNS is very rare, and our knowledge about tuberculosis involving the pituitary and hypothalamus is still rare and through some case reports only. Our case suggests that even if there is absence of any primary focus of tuberculosis as in our patient, and the MRI which doesn't suggest any features of tuberculosis, then also we have to have a high degree of suspicion in country like India, and a biopsy should be planned as early as possible, because as soon as we treat these patients, that is the most important physician control factor to avoid the further neurological sequelae. Thank you.
Thank you. I just wanted to know whether any non-invasive modality you could have used other than a biopsy, any literature search you did, any modification of MRI that could have been helped.
So we did MRI, T1, T2, and contrast enhanced, but it was not suggestive of any perilesional edema, or there was not any other signs of MRI features like any bone involvement or any basal exudates. They were not suggestive. It was just like a iso to hyper echoic lesion in the T1 sequencer.
Read about MR spectroscopy later on.
Okay, sir. Thank you, sir.
Thank you, Dr. Madhusmita. We move to the next case by Dr. Avasti.
Good afternoon, everyone. I am presenting a case of adrenoleukodystrophy, a forgotten diagnosis in children with primary adrenal insufficiency. Our case was a 5-year-old boy who presented to us with history of increased pigmentation, which was gradually progressive over a course of 1 year. There was no history of crisis. There was no history of muscle weakness, visual, hearing, or behavioral abnormalities. He was born out of a non-consanguineous marriage at term without any postnatal complications and had normal developmental milestones. There was history of similar complaints on his elder sibling who had a more florid presentation and presented with impaired hearing, diminution of vision, behavioral abnormalities. He sadly became bedbound and expired at 8 years of age. On examination, our patient had oxology within normal limits, a blood pressure of 94 over 60 millimeters of mercury with no postural drop. There was hyperpigmentation over the circumoral area, hands, feet, and the oral mucosa. There was no mucocutaneous candidiasis. Based on this, our differentials included primary adrenal insufficiency due to either tuberculosis, X-linked adrenoleukodystrophy, or familial glucocorticoid deficiency. Now, based on the lab parameters, it revealed hyperkalemia, high ACTH, and plasma renin activity. Then we did tests for tuberculosis, which came back negative. Based on the presence of high plasma renin activity and hyperkalemia, familial glucocorticoid deficiency was ruled out. On getting a detailed pedigree analysis, there were other male children in this particular family which were also involved. We got an MRI done which did not show any significant white matter changes. We got genetic study done and plasma very long chain fatty acids were evaluated, which tested positive for X-linked adrenoleukodystrophy with isolated adrenal insufficiency. We started this patient on hydrocortisone replacement and dietary modification. Therefore, this diagnosis should be considered in mind with a strong family history of adrenal insufficiency. Thank you. Hello.
Any questions from the judges? Thank you, Dr. Avasti. We move to the next case by Dr. Rukma.
Am I audible?
Yes.
Good afternoon, respected judges and audience members. I'm Dr. Rukma Narkar from SCP Medical College, and today I will be presenting a rare case of congenital hypothyroidism presenting in adulthood. As we know that congenital hypothyroidism is the most common congenital endocrine disorder and is one of the most common preventable causes of mental of delayed of neurodisability. And globally, its overall incidence ranges from 1 in 3,000 to 1 in 4,000. Now, as we know that most of the congenital hypothyroidism are asymptomatic at birth, they are often progressive and progressive with progressive as we know that currently routine newborn screening is not yet available in our country. Now coming to the case report. So a 24-year-old female presented to the gynecology department with the chief complaint of menorrhagia since 2 years. On inquiry, she gave history of attaining a late menarche at the age of 19 years, followed by oligomenoric cycles. She was further referred to endocrine department for evaluation of short stature and delayed pubertal development. There was also a history of noticing poor gain in height as compared to the peers, delayed development of secondary sexual characters, constipation, delayed mentation, and poor scholastic performance. However, there was no history of any neonatal jaundice or umbilical hernia. On examination, she had coarse facial features, a depressed nasal bridge, an open anterior fontanelle, a delayed dentition with dental crowding, a dull-looking appearance, and thick, dry skin. On examination, her anthropometric parameters were as follows. Her height was decreased and below the third centile at minus 7.1 SDs below the mean. The weight was at 25 kgs at minus 3.6 SDs below the mean. And the height age was less than the weight age.
3 months compulsory district residence
The height age was at 6 years with a weight age which is more than the height age, suggesting an endocrine disorder which is at 8 years. The bone age was found to be delayed at 12 years by Grulich-Pyle method for a chronological age of 24 years. And the Tanner's pubertal staging was also delayed for age, which was a pubic hair stage 1 and breast stage 3. On biochemical evaluation, it was suggestive of primary hypothyroidism and severe anemia. Can you scroll down, please? On radiological evaluation, we also found delayed epiphyseal fusion at the femur. The bone age was delayed, and there was dental crowding on skull X-ray with an expanded cella. Can you please scroll down? As the figure shows, as I'd mentioned above, the facial features, the dental crowding, a delayed bone age with a delayed fusion of the femoral epiphysis. So as we know that, can you scroll up, please? So as we know that menorrhagia is not a common presenting symptom for congenital hypothyroidism, although it may be common in adult hypothyroidism. But since our patient had a markedly delayed age of 24 years of presentation at the time of presentation, so she presented with menorrhagia, and the cause was most likely to be thyroid hypoplasia as seen by the ultrasound. And I would like to conclude by saying that up until a routine newborn screening program is available in our country, it is very important for education of the healthcare providers and physicians for a timely referral, because treatment of congenital hypothyroidism is one of the most common preventable causes of neurodisability. Thank you.
Is it
Hello?
possible that the
Yes,
hypothyroidism developed during juvenile age rather than congenital?
Sir, we thought of congenital because of on palpation there was an open anterior fontanelle. So we thought that because of that it could have started earlier, and because of delayed detection she could have presented late, and the bone age was markedly delayed at 12 years.
Okay.
So that was what
Intelligence-wise?
led us. Intelligence-wise, the IQ was below normal, sir. And the social quotient was also.
Can I ask one question?
Yes, sir. Yes, sir.
IQ was below average. That is not a specific answer. Why? Because in congenital hypothyroidism, to the extent that if she is presenting at 24 years of age,
Yes.
then her mental subnormality will be very, very significant. You just cannot pass it that IQ.
Sir,
And That may go with juvenile hypothyroidism rather than congenital hypothyroidism.
Yes, sir. Sir, one thing is the amount of residual thyroid function that is there. So, if the residual thyroid function was could have led to such a late delayed presentation that she could have pulled on so far.
Thank you, Dr. Rukma. We will go
Thank
to
you.
the next case. Another case of congenital hypo again by Dr. Krishna Mori.
Namaste and good afternoon, respected faculties. I am Dr. Krishna Mori from Sri Ramchandra Medical College, Chennai. Today I'll present on congenital hypothyroidism due to an isolated TSH hormone deficiency, a report of a novel mutation in a TSH beta gene from South India. As my previous speaker told, hypothyroidism, the most common cause being the primary hypothyroidism. However, around 10 to 15% of the cases may be central hypothyroidism, and out of that, multiple pituitary hormone deficiency is more common. However, isolated TSH deficiency has been reported to be as common as around 1 in 30,000 to 1 in 50,000 cases. Coming to our case was a currently our patient is a 21-year-old girl who was the first born child out of non-consanguineous marriage, full term with normal vaginal delivery, with a birth weight of 2.8 kgs without any perinatal untoward event. Postnatally, she had a prolonged unconjugated hyperbilirubinemia. At that time, she was screened for hypothyroidism on the 11th day of the birth. TSH was, can you go to the table, please? Yeah, the TSH was undetectable at that time with a total T4 of 1.1 microgram per DL, and the knee röntgogram showed an absent femoral epiphysis. At that time, the patient was labeled as congenital hypothyroidism and was started with 10 microgram per kg per day of levothyroxine. Around till 8 years of age, a patient had normal growth with normal milestones, with normal motor, neurocognitive, and speech development with a good scholastic performance. At the age of 8 years, the treatment was stopped by the mother, and she developed with the florid features of hypothyroidism. At that time, we reevaluated her for the hormonal insufficiency. And as we can see, again, the TSH was undetectable with a free T4 of 0.4 nanogram per DL. Cortisol, prolactin, and IGF-1, that is the other pituitary hormones, were normal. So we considered it to be a possible central hypothyroidism. And the patient was again restarted on the therapy. We also considered it to be either secondary versus tertiary hypothyroidism. Ideally, a TRH stimulation test was required, but we were not able to do it because unavailability of the resources. And also the undetectable TSH was seen more often in secondary rather than tertiary hypothyroidism. We went for a genetic analysis. The most common genes associated being the TRHR, TSH beta, IRS4, IGSF1, and TBL1X. Our patient had a deletion of, genetic mutation in 108, 109 sequence in exon 2 of TSH beta gene, which led to the change from alanine to leucine, which in turn led to a frameshift mutation with a premature stop codon, and which in turn led to a decrease in the amino acid chain of the TSH by 65 amino acid, which in turn led to the loss of the tertiary structure. The patient was continued and followed up till the age of the 21 years, when we saw her around 4 months back, and she had a normal thelage at the age of 9.5 years, menarche at 11 years. She is currently scholastically doing well and pursuing her BA. To summarize, the index child was fortunate to have been diagnosed with congenital hypothyroidism early and was treated for this rare disorder. The newborn screening in India is still not a norm, and mostly it is widely, wherever it is used, it is the TSH based screening algorithm which is used, wherein the central causes may be lost. And our child was diagnosed to have a novel mutation in the TSH beta gene, which has yet to be reported from India. Thank you.
Can I?
Yes, sir.
Yes.
Yes, sir.
Yes, we reported similar case, and it was worked up. And that time genetic analysis was difficult in India. So
Yes,
through German, first report was from Germany. So
Yes,
through that lady only we got genetic analysis done, and we had published that case. So it is not first report from India.
Sir,
Second
actually,
thing is that before working up, you must get MRI done, and you should have mentioned if it is done, because without structural lesion of pituitary, you should not think of this genetic mutation.
yes, sir. MRI, I have written in, I mean, it was done, sir. It is normal, sir. And I mean, this mutation in this particular mutation is novel. That is what we are trying to convey, sir. We are not saying that it is the first one from India, sir. I definitely agree,
Okay.
sir. Sir,
Okay.
yes, sir. And
Thank
we
you, Dr.
also got,
Krishna.
yes, sir.
We
Thank you.
move to the next. I think Dr. Arijit is not there in the list. The next one. So we move to Professor Himanshu Acharya with two case reports of Kalman syndrome.
Good afternoon. There's a mistake actually. It's not professor. I'm senior resident in Tamil Medical College. So I'll be presenting two families of Kalman syndrome, a case series of 5 patients. Can the screen, can the, okay, yeah, thank you. And this is the wrong poster. This is for Himanshu Sharma.
Go back. It has to be, yeah.
Himanshu Acharya is the,
correct, correct.
Yeah. So I'll be presenting a case series of 5 patients of Kalman syndrome belonging to 2 families. We all know that Kalman syndrome is the most common cause of isolated hypogonadotrophic hypogonadism. There have been multiple genes associated with Kalman syndrome. All 3 modes of inheritance have been known. Here we have a case report, case series of 5 patients belonging to 2 families. So first family, 3 brothers belonging to same family, they presented at the age of 18, 22 and 26 with small size phallus and absence of secondary sexual characters. They were born out of second degree consanguineous marriage, and there was no family history of similar complaints in any other cousins or in previous generation. Elder brother had a history of operated right undescended testes at the age of 15. Clinical features of all 3 brothers included unicoid body proportions, prepubertal voice, anosmia, and all of them had bimanual synkinesia. They have had prepubertal genitalia. LH, FSH, and testosterone were done, which are shown in the table. Can you just scroll down? MRI pituitary was done for all 3 brothers, and all of them showed non-visualization of olfactory bulb and cell site bilaterally. Ultrasound abdomen was done. Two out of 3 brothers had shown a non-visualization of right kidney. All 3 brothers were started on depot testosterone. After that, they developed secondary sexual characters. Coming to these are the pictures of the 3 brothers. Coming to the second family, can you scroll up a little bit? Yeah. Second family, the one who presented was the elder brother, 40-year-old male. He presented with primary infertility. He was married for 2 years and he was not, he was having primary infertility. And on probing, he told that he is having inability to pursue sperm. And on asking family history, he also revealed that a younger brother of his also had complaints of hyposmia. They were both of them were born out of second degree consanguineous marriage. Clinical features of both the brothers included unicoid body habitus, hyposmia, small phallus with SPL of 6 cm, testicular volume was 4 to 5 cc. They didn't have any synkinesia. They had low LH and testosterone. MRI of the both brothers had hypoplastic pituitary with hypoplasia of olfactory bulb. Younger brother was started on testosterone. He developed secondary sexual characters. Elder brother was started on HCG injection. He took it for 4 months. After that, he discontinued the injection in view of he could not afford the injection basically, and he hasn't come for follow-up for past 9 to 10 months. So coming to the discussion part, During embryogenesis, immature gonadotropin hormone, gonadotropin cells migrate from olfactory epithelium into the olfactory bulb, then finally into the hypothalamus. Kalman syndrome results from defective migration of gonadotropin neurons. Most common defective gene associated with Kalman is Cal1 gene, which is present on chromosome XP22. X-linked Kalman has multiple phenotypic variants because of wide expression of anosmin. In our first family, two of brothers had renal agenesis, which is usually seen in X-linked Kalman. So basically, the take-home message of this is we have to, in case of hypogonadotrophic hypogonadism, we have to take detailed history and examination should be done carefully. And probably, if patients are affordable, genetic analysis should be done. Thank you.
I think thank you for the good case. I just have one question. In the patient who you started HCG, do you believe that finances not being a constraint, HCG would have been sufficient to give enough testosterone?
Sir, in this patient, yes, sir, LH is low. Enough supplements of the HCG should increase testosterone. If it is not increasing, then we may have to start on HMGs.
Any clues from the patient's baseline testicular volume you would like to rethink?
Yes, sir. He had both had 4 to 5 ml. Trial of testosterone would be better, sir. Sorry, trial of HCG would be better. Like it's
You
not
don't think any role
pre-pubertal.
of FSH is there?
Sir?
You don't think any role of FSH?
Yeah.
Okay.
Do you think
Hello, Dr.
man,
Himanshu. He was suggesting about the role of FSH actually. You are taking only the HCG and LH. Okay, anyway, we'll move to the next case. I request all the participants to be very brief. We have to cover more and we have to finish on time. Next is by Dr. Lohit.
Good afternoon, sir. Myself, Dr. Lohit. I'm a senior assistant in Department of Endocrinology from Ramaya Medical College. I'll be presenting two cases of varied presentation of proximal renal tubular acidosis. So renal tubular acidosis refers to a group of disorders characterized by a defective renal acid-base regulation. It may be classified as distal, proximal, and hyperkalemic RTA. So one more is the mixed RTA. So here we report two cases of proximal RTA. First case is the 10-year child who presented to the neurologist with features suggestive of myopathy. And also there was history of failure to thrive, pain in the both lower limbs, difficulty in walking, polyuria and polydipsia. Similar history was also found in the elder sister. So on examination, the child was poorly built and nourished. Height and weight was below the 3rd percentile. There was wasting of both lower limbs. Power in the lower limbs was 3/5 and upper limb was 4/5. So on investigations, there was a hypokalemia. Serum phosphorus was low. It was 0.61 milligram per deciliter. Calcium was corrected. Calcium was normal. pH was normal. Serum bicarbonate was 12, and alkaline phosphatase was 1176, and urinary pH was 5. We did a 24 unit calcium, serum creatinine, TSH, which was normal. So hence a diagnosis of proximal RTA was made. So the patient was started on Joule solution, potassium citrate, calcium, and activated vitamin D. So within a span of 3 to 6 months, the patient started improving, and there was the increase in the height velocity and also increase in the lower limb power. In the USG, we did it showed a nephrocalcinosis, although it is a feature of distal RTA. So here it's proximal RTA. We made a diagnosis of medullary sponge kidney disease. So in the second case, a 4.5-year girl presented with a failure to thrive and features suggestive of rickets, like going of both lower limbs and difficulty in walking since the age of 2 years. She was born out of a second-degree consanguineous marriage. On examination, height and weight were below 3rd percentile. There was rachitic grossery, widening of the wrist, genu-valgum, and power in the lower limbs were 3/5. She was seen by a general practitioner where she was prescribed a calcium and vitamin D, but there was no improvement. So when she presented us, we did an investigation which showed hypokalemia, low serum phosphorus, corrected calcium and pH was normal. Serum bicarbonate was low, that's 13.04. Urinary pH was 5.1. And 24 urinary calcium and serum creatinine was normal. So diagnosis of proximal RTA was made. And also the urine analysis showed albuminuria and glucoseuria. Hence a diagnosis of Fanconi's was made in this patient. So after the patient was started on phosphate, activated vitamin D and potassium citrate supplements. In the follow-up, the patient started improvement in the lower limb, and patient was able to walk. Um, so down. So the patients with proximal RTA are being to refer to neurologist or pediatrics for failure to thrive or myopathy. So the direct reference to endocrinologist or nephrologist is less. So these two cases give us insight about the varied presentation of patient with the proximal RTA. So to conclude, RTA is an easily treatable condition and should be suspected in any child who present with failure to thrive and proximal myopathy. Thank you.
What was the cause of proximal RTA in first case? Did you try to find out the etiological cause of proximal RTA in the first case?
No, sir, could be genetics, sir, because I did not do a genetics as there was history in the elder sister also, sir.
Okay. You are planning to do genetic workup or financial constraints?
Thank you, Dr. Lohit. We move to the next
There
case
is
by
financial
Dr.
constraints
Jeevan.
because the elder sister actually died, sir, after that, sir.
Good afternoon, respected judges. Myself, Dr. Jeevan Pradhan from SCB Medical College. I am going to present today a rare case of mucopolysaccharidosis, which was masquerading as rickets. So we know that mucopolysaccharidosis is a hereditary disorder where there is a mutation of gene in the lysosomal enzymes which are responsible for degradation of GAGs in the cells. So there will be multi-organ dysfunction in those patients. In our case, a 7-year-old boy presented with bowing of both legs associated with progressive difficulty in walking since the early childhood. And he was being treated for the last 2 years before presenting to us with multiple doses of oral vitamin D and calcium, thinking it is as a case of rickets. On presentation to us, his height was severely short stature with minus 5.27 st, and weight was 10 kilo with minus 4.4 standard deviations, and his upper segment to lower segment ratio was 1.22, which was disproportionate with short limbs. And on detailed physical examination, he had depressed nasal bridge, bulging forehead, short neck, pectus carinatum, rickety rosary, widening of bilateral disc, genu valgum with an intermalleolar distance of 14 centimeter, but there was no double malleoli, and other system examination was normal. And with this, we went ahead and did skeletal survey with X-ray, which showed thickened calvaria with J-shaped sella, flattening and broad anterior ribs, anterior inferior beaking of the thoracolumbar vertebral bodies, widening of metaphyseal ends of all long bones with epiphyseal stippling, and pointing of all the proximal ends of metacarpals, and increased joint space in distal radius and slanting of distal ends. These all features were suggesting a diagnosis of MPS. And with biochemical evaluation, we found that CBC, LFT, RFT all were normal. Thyroid function was normal. Urine pH was normal, and but the serum calcium was at higher normal range, and vitamin D was approaching toxicity levels due to continuous and over enthusiastic supplementation, most probably. And with this, we went ahead to confirm our diagnosis with urinary GAGs, which was found to be elevated. And then we stopped the supplementation of vitamin D and calcium. And for to find out for the complications of MPS, we went ahead and did 2D echo, which was normal. Pure tone audiometry was normal. Ophthalmological evaluation didn't show any corneal clouding or corneal opacities, or and there. But on MRI spine, there was atlantoaxial subluxation with marked cord compression, and the intelligence was just to be normal. So can we move down? Okay.
So with these findings, the diagnosis of MPS was made, and genetic nature of the disease was explained to the parents, and he was advised for further follow-up to manage the complications, and was referred to neurosurgery for stabilization of the atlantaxial subluxation. And with these clinical features of skeletal dysplasia suggestive of MPS, and without any cardiac involvement, corneal clouding, or no preserved intelligence, the patient may be a case of type 4 MPS or type 2 MPS, but we could not confirm the subtype, because subtyping could have helped in specific subtypes with where hematopoietic stem cell transplantation is available. So basically, follow-up and prevention of complication and adequate management of complications is the best route of management in these patients. So any patient who presents with features of rickets, and we are suspecting a vitamin D resistant kind of rickets, we should go for a detailed skeletal survey and should have a high index of suspicion for mucopolysaccharidosis, so that the patient can be diagnosed early, and the complications can be prevented, so we can have a better survival benefit. Thank you for the patient listen.
Just one question: what parameter in your calcium metabolism parameters will clearly tell you whether this is rickets or not? And unfortunately, if your child gets COVID, will he get a severe COVID or will he get a mild wala COVID?
So, phosphate, serum phosphate level.
Will you like to change your answer?
So,
we move to the next case. Thank you, Dr. Jeevan.
Thank you.
We now request Dr. Himanshu to present his case.
Good afternoon, dear sir and madam, and my dear colleagues. I am Dr. Himanshu Sharma from SMS Medical College, and today I will be sharing a rare case of a Robinow syndrome. As we all know, dysmorphism forms the central vista when we are looking for a syndromic causes of short stature. So Robinow syndrome is a very rare genetic syndrome with around only 100 cases that have been reported. The distinct features that include is a mesomelik brachymelia, genital and vertebral abnormalities, and a characteristic facial features. So here we have a case that is a 5-year-old child who was brought to us with a complaint of poor height growth, and with a small phallus size. The younger sibling had overtaken in height, and the patient's parents also noticed that he is having bowing of the upper limbs, which was increasing with time. There is a history of MTP of a similar child at 20 weeks. I don't know how the diagnosis was made, as the document was not available with us. On examination, there was severe short stature with a height of minus 5.1 SDS and a characteristic facial features. Can you scroll down, please? So we have a patient who has having broad forehead, hypertelorism, prominent eyes, with retrogonathism and long philtrum. Now, this is known as a characteristic fetal features of the Robinow syndrome. Also, the patient has a microphallus with a size of 1.7 centimeters and a glandular hypospadias. The patient also had camptomelia and brachymelia. With this picture in mind, we had a few differential diagnoses. Went ahead with the investigation. The blood investigations were not much helpful. The patient did not have any growth hormone deficiency. The GH was stimulated to 14.7. Can you scroll down, please? Thank you. Can you show the X-rays, please? Down. So we went ahead with the radiological investigations, which showed some striking findings such as hemivertebra, fused ribs, and vertebrae vertebra. There was also camptomelia and brachymelia and a radial head dislocation. This confirmed the diagnosis of Robinow syndrome, as these are characteristic findings of this and present in almost 100% of the patients. And we suspect a recessive cause, as the recessive findings are much more common. So in discussion, we have a rare genetic syndrome with characteristic clinical findings, and these findings can help us in diagnosing of syndrome. Now, the rare problem with rare genetic syndromes is that you have to go for a detailed evaluation of the minor anomalies also. And these present a management and a diagnostic dilemma for the patient. The careful diagnosis of these patients would add to our knowledge of their syndromes. This patient was initiated on testosterone 25 mg for 3 months. There was a modest increase of around 0.5 centimeters of annualized and is still awaiting genetic confirmation. Thank you.
How were the developmental milestones of this child?
Even the IQ was below 9 or 78. The developmental milestones were perfectly normal.
The language also?
Pardon? Hello?
How is the long-term prognosis?
The long-term prognosis is actually good in the dominant form, but in the recessive form, 10% do develop cardiovascular abnormalities, and these patients usually die within the first year of life. So even a prevalence of 1:5 lakh may be much less because these patients are never diagnosed. The reproductive prognosis is also well.
Thank you, Dr. Himanshu. We move to the next by Dr. Ashok. Dr. Ashok, are you there? Okay, we move to the next, Dr. Nadima. Dr. Nadima Rafiq. Okay. Since she's also not there, we move to the next one, Dr. Abhishek Prakash. Yeah, we have Dr. Abhishek. Go ahead.
So am I audible?
Yeah, please go ahead.
So good afternoon, respected judges. I am Dr. Abhishek from Safdarjung Hospital, and I'm going to present this rare case of persistent craniopharyngeal canal who presented to us with panhypopituitarism with delayed puberty, anosmia, and short stature. We have this. Can you please scroll down? So we have this case of a 21-year-old male who had presented to us with absent sense of smell for the last 10 years, along with absence of secondary sexual characters and poor gain in height, which he had noticed for the last 7 years. Upon inquiring, he also gave symptoms suggestive of diabetes insipidus. In examination, he had severe short stature. There were no midline defects, neither there were any history of mirror movements. He had cherubic faces with a high-pitched voice. The tennis staging was prepubertal, and he had unicaudal body proportions also. In systemic examination, it was unremarkable except for absent olfaction, which was noted bilaterally. Please scroll down. So we proceeded with the routine biochemical investigations, which were all normal. A bit down, which were all normal. The hormonal profile of the patient revealed low LH, FSH, serum cortisol, as well as IGF with intact thyroid functions. The bone age of the patient was delayed. So after priming, we proceeded to a GH stimulation test with clonidine, which was suggestive of a growth hormone deficiency. So for evaluation of polyuria, it revealed hypotonic urine with raised serum osmolarity, suggestive of central diabetes insipidus. So in view of the panhypopituitarism, we further proceeded with the imaging of the brain. Please scroll down. And upon imaging of the brain, to our surprise, we found a very large bony defect that was present in the floor of sella. And through this defect, there was herniation of meninges containing CSF up till the nasopharynx. Also, we found a soft tissue mass at the base of the cephalocele, which was most likely to be a teratoma. The other structures could not be visualized, and in this patient, corpus callosum was also absent except the gene. So can you scroll up a bit? So we managed the patient medically with tablet a bit up with tablet hydrocortisone and tablet desmopressin melt, and we started him with injection testosterone also. So after doing medical, after we started him on medical management, the surgical definitive surgery is planned, which is the reduction of the mass by the transnasal transspinal approach. So finally, coming to discussion. So this is a very rare congenital anomaly of the pituitary, which is most likely results from an incomplete closure of the Rathke's pouch. So based on the size of the defect and the contents of the cephalocele, it is divided into 3 types. So among the defects, the type 3C defect, which contains both cephalocele and the tumor, it is the most common, and this was seen in our case. It is also associated with anterior pituitary hormone deficiency. However, till date, adrenal insufficiency has not been reported, but it was present in our case. So the importance of identifying at the earliest is to medically manage the evolving hypopituitarism and to initiate appropriate surgical management whenever it's required for the definitive thing. So thank you, sir.
So Dr. Abhishek, what do you
Yes,
think
sir.
are the indications for surgical intervention in this particular case?
So if the patient is having, because the mass is herniated till the nasopharynx, so many patients come with complaints of nasal polyps, and they may complain, they may present as recurrent meningitis also. So if the patient is having recurrent meningitis or having some problem in nasopharyngeal obstruction, then we can go for it. And prophylactically also we can do the surgery so that the patient may not develop such complications.
Do you think hypopituitarism will improve after the surgery because the compressive effect is gone? So will the pituitary function come back?
So in majority of case series, the pituitary mass has been compressed so much, so the recovery post surgery has not been great. But it is just for prevention of the complications of future. That for that we have to go for surgery. Recovery is very little, sir. It's a rare thing, sir.
Thank you, Dr. Abhishek. Due to some technical glitches, we had to miss 2 people. They are again back, I guess. They are ready. So we go to Dr. Ashok now. Case series of Van Wyk Grumbach.
Hello, sir. Will you please share my screen? Hello, technical team. Good afternoon, respected professors and seniors. I am Dr. Ashok Venkatarsu, presenting a common disease, uncommon presentation, a case series on Van Wyk Grumbach syndrome. Van Wyk Grumbach syndrome is characterized by juvenile hypothyroidism presenting with isosexual precocious puberty, with a delayed bone age and cysts in the ovary. And hypothyroidism is known for florid features, but presenting with this kind of rare syndrome is uncommon. We are presenting case series on this. So here we are reporting 4 cases, 3 girls, 1 boy. Their age group was in between 5.75 years to 7 years. All 3 girls were presented with bleeding per vagina and breast development. However, their pubic hair development was not proportional. Their ultrasonographic and pelvic examination revealed that multiple cysts in the ovary and enlarged uterus. 6-year-old boy in this series presented with the enlargement of both testes with little development of the pubic hair and poor height gain. His ultrasonographic examination revealed that scrotum and testes showed that there was uniform enlargement of both testes, no focal lesion. All cases were having height less than 3rd centile, and their weight centile were in between 50 to 75th centile. Scroll down. And these cases were having significant bone delay in the bone age. It is more than 2 years, and they were started upon the levothyroxine treatment as per the guidelines. During their follow-up, after attaining the youth state, they have improvement from the presented symptoms. Here, the first 3 cases are girls, and 4th case was a boy. Here we can see the especially the gonadotrophins. The FSH is raised out of proportional to LH. In a central precocious puberty, LH will be raised more than the FSH. And scroll down. scroll down. These are the two growth charts. First growth chart was the girls growth chart. We have given the three growth lines, blue and yellow and green. They have, after attaining the euthyroidism, they have started growing very well, and they have catched up the significant growth. And boy also, he has reached 50th centile in the height. Earlier he was less than 3rd centile. So profound hypothyroidism at a juvenile age, they can present with the precocious puberty. Generally, the dictum of precocious puberty is that they will have the accelerated bone age with the accelerated height. Here, any case presenting with a delayed bone age with precocious puberty and short stature, we should suspect for juvenile hypothyroidism. Presenting as a Van Wyck-Grumbach syndrome, and treatment with the levothyroxine therapy in these cases is a rewarding one. Thank you.
Usually breast development will not be to the extent of B3 or B4 in majority of the Van Wyck or hypothyroidism presenting as precocious puberty. Do you have any explanation, Ashok, for the breast development B4 in your two cases?
Yes, sir. One of the girl was having weight more than 50th centile, and probably the long-standing hypothyroidism with elevated estradiol that might have resulted in B4 kind of development, sir. I do totally agree with you, sir. It is not that common finding. Yes, sir.
Yeah, thank you.
Okay, thank you, Dr. Ashok.
Thank you,
we
sir.
go to
Thank you,
Dr.
sir.
Nadima.
Good afternoon, sir. Hello. Hello, are you able to hear me? Sir, are you able to hear me?
Yes, we can hear you.
Hello. Sir, are you able to hear me?
We can hear you. Go ahead.
Okay, thank you, sir. Myself, Dr. Nadima. I'm going to present, good afternoon, everybody. Good afternoon, everybody. I'm going to present the poster topic, socio-demographic correlation with overweight and obesity among school-going children of North India. As we all know, nutrition and epidemiological transition over the past 3 decades has resulted in weight changes, and there has been dramatic rise in the childhood obesity, and this has been one of the adverse outcome of it. So our aim, the aim of our study was to assess the prevalence and socio-demographic correlates of overweight and obesity among school-going children in the age group of 6 to 14 years in rural and urban Jammu. The method that we take, it was a cross-sectional community-based study that was conducted in the school-going children of both the gender and in both rural areas as well as urban areas. After explaining the purpose of study, students were interviewed by the investigator and needful information regarding the socio-demographic variables were collected. The various variables that we collected were among the socio-demographic variables were age, gender, residential area, type of school, type of family, education of parents, mother's occupation, family size, and birth order were analyzed for their relationship with overweight and obesity. Also, anthropometric assessment was done. BMI percentile was obtained from WHO age and gender specific BMI charts. Then coming to the results, out of the 230 students or children that we studied, out of those almost 106 were 107 were from urban and 123 were from rural areas. And out of these, the prevalence of overweight and obesity that we came across was
Maybe it's good to present again because, doctor, please start presenting again because they were showing some other screen.
Okay, sorry, sir. Okay, I'll present again. Okay, good afternoon, everybody. Myself, Dr. Nadima, I'm going to present the poster presentation, the topic of which is socio-demographic correlation with overweight and obesity among school-going children of North India. As we all know that nutritional and epidemiological transition over the past 3 decades has resulted in weight changes, and there has been a dramatic rise in childhood obesity, which has been an adverse outcome of this. The aim of our study was to assess the prevalence and also the socio-demographic correlates of the obesity among school children in the age of 6 to 14 years in rural and urban areas of the Jammu. The material method that we used was a cross-sectional study and community-based study in which the school-going children of both the gender were selected in the age of 6 to 14 years and in both the rural and urban areas of Jammu. After
Yes, I think we seem to have lost the link with her. Is it audible for anybody?
We are hearing you, sir. I think we should go to the next person, then we can come
We
back.
shall go to the next one because there seems to be some connectivity issues with her. We go to the next one, that is Dr. Srinivas, adrenal incidentaloma.
मैं शेयर कर रहा हूँ.
Good afternoon. Am I audible?
Yeah, please go ahead.
Good afternoon, everyone. I am Dr. Sushil from Guwahati Medical College. I am going to present a case of adrenal mass of rare etiology. A 13-year-old girl was referred from the periphery with an incidentally detected right adrenal mass. Her history revealed recurrent jaundice for last 4 years and recurrent dull aching diffuse abdominal pain for 3 months, which was moderate to severe in intensity. And the other positive history finding was blood transfusion that was given 3 years ago, and she did not attain menarche yet. Come down, please. On examination, the positive findings were postural drop in blood pressure, pallor, icterus, and generalized pigmentation. Her anthropometry was normal. Her SMR was P1 and B2, and axillary hair was absent. And per abdomen, there was hepatomegaly with a liver span of about 15 centimeters, and a separate non-tender mass was palpable in right lumbar region. And there was a systolic flow murmur on cardiovascular examination. Coming to the investigations, the routine blood investigations revealed hemolytic anemia, that is with raised reticulocyte count along with increased unconjugated bilirubin. And the peripheral blood smear showed sickle cells and Howell-Jolly bodies. And the HB electrophoresis confirmed sickle cell disease. The hormonal evaluation revealed low basal and stimulated cortisol with raised ACTH levels and also undetectable DHEAS. And her PAC and PRA were normal. Her gonadotropins and estradiol levels were suggestive of puberty. Come down, please. And the imaging showed a large right suprarenal mass of about 8 into 10 centimeters size with variable intensities on T1 and T2 without any invasion, and the spleen was not seen. Ultrasound guided FNAC was done, which showed extramedullary hematopoiesis. And the mass was excised and patient was started on hydrocortisone supplementation. The histopathology confirmed extramedullary hematopoiesis. Actually, it has shown an extranumerary spleen that was fused to adrenal gland with marked expansion of red pulp and features of extramedullary hematopoiesis. So the final impression is sickle cell disease with extramedullary hematopoiesis, primary adrenal insufficiency, which was relatively mineralocorticoid sparing at that particular point of time, and probably due to sickle cell disease itself. The underlying pathophysiology for sickle cell disease presenting as primary adrenal insufficiency could be due to recurrent vaso-occlusive events or the interplay between iron overload, low-grade inflammation, and oxidative stress. And similar case reports have been reported, that is with sickle cell disease or other hemoglobinopathies like hereditary spherocytosis. That's all. Thank you.
Oh, shit.
If there are no questions, we shall move to the next presentation by Dr. Sahu.
Hello.
Yeah, you're audible. Please go ahead.
Yes, sir. Good afternoon, judges. I am Dr. Devdarshini Sahu from MKCG Medical College. I'll be presenting down, please. I'll be presenting a rare case of noble mutation with androgen insensitivity syndrome. So androgen insensitivity syndrome is the X-linked disorder caused by mutation of gene encoding androgen receptor located on XQ arm. According to the degree of androgen resistance, the clinical manifestation ranges from normal male to phenotypically normal female. Till now, only 500 pathogenic mutation causing androgen insensitive syndrome have been reported. So I'll be presenting a case which is a 14-year-old patient complaining of voice change for last 2.5 years with primary amenorrhea and poor development of breast presented to our outpatient department. There is no history of maternal virilization or any drug intake by the mother during pregnancy. Patient had no history of salt wasting crisis. During adolescence, patient developed axillary and pubic hair along with clitoral enlargement. She was the first child out of consanguineous parents with 2 more siblings. One is 11-year-old who is reared as female and another is 6.5-year-old who is reared as male. Patient did not receive any medication till presentation. Her anthropometry findings were normal. On examination, mustache were present along with frontal and temporal recession of hair. External genitalia was consistent with female phenotype except for clitoromegaly. Tanner staging was B to P4 with presence of axillary hair. Bilateral gonads could be well palpated in inguinal area. She had 2 openings with posterior labial fusion being present. The EMS score was 2. The blood pressure of the patient was 110 by 70 millimeter of mercury, which was between 58 to 75 centile, and all other systemic examination were within normal limits. Lab investigation, the electrolyte was normal. The LH, FSH, and testosterone level were high. The testosterone and dihydrotestosterone ratio was 1.8:1. The testosterone by androstenedione ratio was 1.28:1. The 8 AM cortisol was normal. The karyotyping of patient was done and it was XY. Pelvic ultrasonography was showing well-defined solid homogeneous structures in bilateral inguinal region, suggestive of testis. Uterus and ovaries were not visualized. We are not having a genetic lab in our setup, so we requested CMC Vellore genetic lab, and they agreed to do it on a research basis as the patient was poor and was not able to afford. So, and here the patient had a heterozygous androgen receptor gene mutation. They identified 2 mutations. One was known pathogenic mutation and another was a novel pathogenic mutation. And so patient is reared as female till now. Down please. And after discussing with the parents, they want to continue with the female phenotype. So bilateral gonadectomy was done for the patient, and now the patient was put on estrogen supplementation, and her breast development was till B3, and now we have added progesterone supplementation for further development of breast. On the very so this is a picture which is on the right side showing the patient with mustache development and clitoromegaly to a more phallus-like structures, and on the left we are having his sibling who is 11-year-old female, and she is also diagnosed to have the similar kind of androgen insensitivity syndrome with a similar noble mutation. Thank you, sir.
Are you planning to continue estrogen plus progesterone continuously, or you are going to change?
No, sir. Actually, for we continued on. We started with estrogen 0.5 milligram estradiol valerate, and then we gradually increased the dose to 2 milligram. Then also her breast was developed till B3. Now we have added so that B up till B4 to B5. So we have now given her progesterone, sir. And no need of cyclical treatment because she is not having uterus, sir. So only for purpose of breast development, we have given her progesterone.
So how long you wish to continue that?
Sir, we'll continue that till the breast size goes up to B4 or B5, sir. At least B4, sir.
Okay. Thank you, Dr. Sahu. We move to the next presentation by Dr. Nitin Reddy.
Hello. Yes. Good afternoon, sir. I'm Dr. Nitin Reddy. Today I present a case of 46XX DSD due to POR deficiency. POR stands for cytochrome P450 oxidoreductase. Deficiency of this enzyme was previously thought to be a rare one, but of late there is an increase in the incidence of POR deficiency due to the increase in the awareness about this enzyme. There are around 300 case reports which are published till now in the index journals since its first discovery in 1985. So there are POR deficiency. POR is actually a cofactor for multiple enzymes in the body. Apart from the steroidogenic pathway enzymes, that is CYP 17, 19, and 21, there are other enzymes which are also associated with POR deficiency. This is because the characteristic skeletal phenotype, that is anti-Bixler phenotype, is a feature of POR deficiency, which is because of the 14 alpha demethylase enzyme defect. POR is also a cofactor for this specific enzyme. Presence of this phenotype in the background of genital ambiguity will make the diagnosis of POR deficiency simple. But the problem arises when this skeletal phenotype is not present in a child presenting with genital ambiguity. I present a case of 4-day-old female child who was being reared as a female. She is the second of the non-identical twins born after the second-degree consanguineous marriage. This child was brought by parents for the evaluation of abnormal genitalia. On examination, this child has essentially normal blood pressure, length, and weight, but there is no characteristic skeletal deformity in the form of anti-Bixler phenotype. On genital examination, there is Prader 3 genital ambiguity in the form of clitoromegaly, which is shown in the image by the side, and clitoromegaly fused labioscrotal fusion, and there is a single urogenital opening. Upon investigating this child, the plasma sugars and the electrolytes are all within normal limits. Ultrasound pelvis showed normal Mullerian structures and absent Wolffian structures. Phenotyping came as 46XX. In the initial baseline cortisol and 17-OHP evaluation, cortisol came as low and 17-OHP came as high. So we presumed it was due to the 21-alpha hydroxylase because it is the most common 46XX DSD. So we initiated this child on both mineralocorticoid as well as glucocorticoid treatment. But the surprise came in the form of an initial genetic study which was negative for 21-alpha hydroxylase. That is when we have again reevaluated this child and did the other androgens. Testosterone surprisingly came very low and dihydrotestosterone came as high. Along with that, DHEAS is also very low. So we have thought that this could be because of POR deficiency, and this time we sent the genetic analysis for the whole genome sequencing, and the report came as POR deficiency with a defect at homozygous defect leading to the conversion of arginine to histidine at codon 457. And upon seeing this genetic report, we went back to the history and asked mother about the triple test. Surprisingly, the triple test serum estriol levels came very low. This is because of the aromatase deficiency, which is also a part of the POR deficiency. We have now decided to stop the fludrocortisone because POR deficiency generally doesn't present with mineralocorticoid excess. So we continued only the hydrocortisone replacement. All this can be explained because of the backdoor pathway which happens in the, scroll down please, which happens in the fetal. This is because of the formation of dihydrotestosterone, which is the potent testosterone, not from the precursors androstenedione and testosterone, but from allopregnanolone, androsterone, and androstenediol. So in this child, finally we conclude this case by saying that if at all there is skeletal deformity in the background of ambiguous genitalia, we can diagnose POR deficiency easily. But if there is no such skeletal deformity, suspect POR deficiency in all those cases which have marginally high 17-OHP associated with low testosterone and high DHT levels. And finally, in this child, we are expecting hypertension and delayed puberty because backdoor pathway generally is active only in the fetal life to the maximum up to the 2 to 3 months of life. And there is a predominant 17-alpha hydroxylase and 20-lyase enzyme deficiency in the as the age progresses. So we are expecting delayed puberty in this child, and we are planning to initiate this child on steroid treatment at the time of adolescent age. Thank you, sir.
Do you think the cortisol is reliable in the first 3-4 months of life?
No, sir. Especially with the background history of low birth weight, the cortisol is not relevant, and even 17 OHP is not reliable. So that is the reason why in this specific child we have waited for about 2 to 2.5 weeks after birth.
Thank you, Dr. Nitin. We go to Dr. Rahul. The remaining presentations we will do on a different link. Dr. Rahul, please.
Hello, am I audible, sir?
Yeah, please go ahead.
Good afternoon, all respected faculty. I am Dr. Rahul Chowda from VMMC and Safdarjung Hospital, New Delhi. I am presenting a case of hypophosphatemic rickets with a rare underlying etiology of tan disease. Phosphopenic rickets is usually diagnosed after a high index of clinical suspicion and when rickets persist despite adequate calcium and vitamin D replacement. Down, please. My case, a 13-year-old boy presented to us with history of progressive knock knees since 1.5 years of age and inability to gain height for past 6 to 7 years. Down, please. Child was evaluated outside during childhood and managed as nutritional rickets, but there was no improvement in symptoms. Bilateral supracondylar osteotomy was also done for knock knees. On inquiring, there was no history of bone pain, fracture, proximal myopathy. His family, birth and developmental history was also uneventful. Down, please. On examination, child was short with height of 133 centimeter and a height SDS of -2.82. Dentition was appropriate and he had entered into puberty. The other positive findings were bilateral rachitic rosary, widening of bilateral wrist, bilateral knock knees with secondary deformity at hip and pelvic position. On evaluation, investigation side, please. On evaluation, he was down, please. No, up. Investigation side, please. Up. Yes. On evaluation, he was found to have hypophosphatemia, raised alkaline phosphatase. Down, please. Yes. Hypercalciuria, phosphaturia, and renal calculi. Down, please. Further investigation for identifying a cause of PTH independent renal phosphate wasting revealed normal FGF 23, high 125 dihydroxy vitamin D, and significant increase of beta 2 microglobulin. As our patient had hypophosphatemia, down please on discussion part. Our patient had hypophosphatemia, low molecular weight proteinuria, hypercalciuria, and nephrolithiasis. On the basis of these findings, he was diagnosed as a case of Dan disease, and child was started on low salt diet with thiazides and elemental phosphorus supplementation. On follow-up, there was improvement in biochemical and clinical parameters as well as imaging parameters also. So I want to conclude that Dan disease is a rare X-linked recessive proximal tubulopathy, and the prevalence is unknown, is mostly reported in 250 families only. And the management of Dan disease is mainly supportive, and it involves integration of multiple therapies like to prevent hypercalciuria, to prevent nephrocalcinosis, and to prevent other bony deformities. The prognosis is good, but 30 to 80% of cases developed renal failure by the 3rd to 5th decade. Thank you, sir.
What are the strategies to prevent renal failure in such patients? What we can do to prevent renal failure?
Yes, sir. At present, sir, there is no specific therapy, but renal failure is mostly related to multiple episodes of nephrolithiasis or nephrocalcinosis. So the general measures we are applying for nephrolithiasis or calcinosis, like high fluid intake, high citrate diet, all these can be given in this patient, sir.
Thank you, Dr. Rahul.
Thank you, sir.
The rest of the 6 presentations will be conducted in a different link. I'm sure you would have received. Now we move to the oral presentations. They carry the essence of any actually
conference because it allows the young speakers to present on an international stage. So I would like to introduce the judges for this particular session. Can we have the intro slides, please? So Professor S.V. Madhu, we all know him as the immediate past president of the Endocrine Society of India. He's a well-known person, and he is the past president of DIPSI as well, a past president of RSSD as well, and he has been actively involved in diabetes and endocrine research. There are very few words that there are too many words to dare to praise Dr. S.V. Madhu, but I think we have very limited time to tell so many things about him. So next person is Dr. Shashank Joshi. He's a very, very prolific orator. We have heard him since like when we were very young students. He's now honored by the government of India by bestowing on him the Padma Shri. He has been the president of Endocrine Society of India. He has been a prolific writer of articles in diabetes and endocrinology. More than 600 research publications are there, such as diabetes, obesity, thyroid, osteoporosis, and growth. He's the editor of Practical Medicine and he's the editor emeritus of Journal of Association of Physicians of India. He's the president of Indian Academy of Diabetes and Associations of Physicians in India as well. Dr. D. Vijay Shekhar Reddy, he is the honorary consultant endocrinologist at Yashoda Hospital, but mainly we know him as the professor of endocrinology in the Gandhi Medical College or Gandhi Hospital in Secunderabad and the Kaloji Narayana Rao University of Health Sciences. Several publications in international journals. He has been a very impressive speaker from the city of Hyderabad. He's the national faculty for PHF5 and he's the member of Dissertation and Research Committee of Gandhi Medical College from 2015. Dr. N.K. Agarwal, he's professor and ex-head. He's the Department of Endocrinology and Metabolism, Institute of Medical Science from the Banaras Hindu University in Varanasi. He has been the coordinator of the 8th refresher course in medical sciences. And he's been the UGC Human Resource Development Center at BHU Varanasi. He's a member of DRC, DPC, PPC, Faculty Meeting of Institute Indian Academic Council of BHU, and published more than 91 paper publications and has greater than 816 citations to his name. So with that, I think I will hand over the session to Dr. Hari, who will like to introduce the speakers.
Thank you, Dr. Santosh. Thank you, sir. We welcome all the judges for this oral presentation. The participants have 8 minutes to present and 2 minutes for question answer session. Wasting much time, I will request the first participant, Dr. Tausif, to start the presentation. Can we have the slides of Dr. Tausif?
Dr. Tausif, is he unmuted at the moment?
Good afternoon.
Can we go to the next presentation if there is a delay?
Probably you can go to the next one if there is a delay.
Yeah, the second presentation is by Dr. Nadima. Dr. Nadima, please.
Hello, can you hear me?
Yes.
Yeah, you're audible.
Can I start? Excuse me, it is not getting connected. I just.
There is still some connectivity issue. We move to the third, the Dr. Vaibhav.
Yes, sir, I am there, sir.
Yeah, okay. Dr. Vaibhav, we'll start with you then. Since your connectivity appears better, then we'll go for the others.
Sir, are my slides visible?
They're coming.
They're getting loaded.
Yeah. Am I audible?
Yeah, you're audible, but just check your slides.
Yeah.
You have started sharing, but you've not selected your presentation, I think. Need to select that, put it on screen show. Yeah.
Visible?
Yeah, please go ahead, Dr. Vaibhav.
Sir, sir, can I start, sir?
Yeah, please.
Good afternoon, respected faculties and respected judges. Myself, Dr. Vaibhav Pathak, I am Senior Resident DM Training in SCB Medical College, Cuttack. My topic for presentation is insulin resistance in type 1 diabetes mellitus patients, that's children and adolescents, and its correlation with various metabolic parameters. And that is the double trouble in type 1 diabetes mellitus patient. Next, please. Regarding type 1 diabetes mellitus and insulin resistance, there is a concept of double diabetes, especially in patients who have a positive family history of type 2 diabetes mellitus. And in type 1 diabetes patients, there is coexistence of autoimmune insulin deficiency, and simultaneously there is inherited that is because of the family history, or acquired insulin resistance, which may be because of the environmental factor or lifestyle factors. And that concept has been proposed as a concept of double diabetes, and implications of this coexistence of both the insulin deficiency in type 1 diabetes as well as insulin resistance in type 1 diabetes could be that these patients who have both the things, they can have higher risk of developing diabetic complications. And by assessing insulin resistance in these type 1 diabetes patients, we can identify who are at higher risk of subsequent small and large vessel complications. Next, please. So as I said, the usefulness in clinical practice of this study would be that by assessing insulin resistance in these patients, and this can be an independent predictor of cardiovascular risk factors and also the microvascular complications in patients with type 1 diabetes. As we know with the type 2 diabetes, that insulin resistance is a risk factor for various complications. So risk factors can be identified earlier, and these patients who have added insulin resistance, they can be targeted for their risk factors management aggressively. And as we know that atherosclerosis begins in the childhood only, so by targeting these population, we can manage the risk factor aggressively from the beginning, from the childhood and adolescent period only. Next slide, please. So the aim of an objective of my study was to study the insulin resistance in patients with type 1 diabetes and children and adolescents, and its correlation with the various metabolic parameters and complications. Next, please. The method and material of my study was that total 61 patients who attended the endocrinology OPD of our medical college between age 5 to 6 years of age were recruited. It was a cross-sectional data collection, and inclusion criteria was all patients with type 1 diabetes in the age group of 5 to 16 years who attended at least 6 months of medical follow-up at our hospital, and they should not have any history of thyroid disease or adrenal dysfunctions which could have interfered with the calculation of insulin resistance. So that's why we excluded them, and no history of any previous liver, renal or cardiovascular diseases. And exclusion criteria was if the patient has a previous history of diabetic ketoacidosis during the preceding 3 months, they were excluded. Next, please. So baseline, all clinical parameters were measured, anthropometry data was collected, and routine biochemical parameters was also measured in these patients. And EGDR, that is estimated glucose disposable rate, was calculated by using this formula. And EGDR, that is the estimated glucose disposable rate, is a formula which has been validated in type 1 diabetes patients. And as we know that insulin sensitivity is in ideal setting would be calculated by hyperinsulinemic euglycemic clamp, and this EGDR formula for calculation of insulin resistance in type 1 diabetes has been validated by hyperinsulinemic euglycemic clamp. So this formula was used for calculation of estimated glucose disposable rate, and later on statistical analysis was done by using IBM statistics SPSS version 20. Next, please. These are the baseline characteristics of my study population, in which we can see that the age group was around 14 years of age, and majority of them were during their pubertal period. Of them, male and female was almost equal, slightly towards higher side of the female. Duration of diabetes was 5.5 years with standard with plus minus 2 years, and around 20% of the patient has family history positive, and around 16% of the patient were overweight in this study population. Regarding HbA1c, we can see that majority of the patient had poor glycemic control, and other lipid parameters, that triglyceride was when we see for the cutoff for the age for adolescent and children, it is 130 should be a normal in adolescent, but it was slightly towards the higher side. Similarly, for the HDL also, it was slightly towards the lower side, and insulin dose was also towards the higher side, with the insulin requirement being more than 1 units per kg per day in our patient population. Next, please. Regarding complication screening, it was screened as baseline also, and previous records of preceding 6 months was also looked into, and we could see that around 24% of the patient had total microvascular complications, and out of them, majority have had microalbuminuria, that is moderate increase of albumin creatinine ratio more than 30 milligrams per gram of creatinine, and only around 5% of them had retinopathy. Next, please. Next, please. Yes. Now, regarding the calculation of estimated glucose disposable rate, insulin glucose disposable rate was calculated by the formula as I showed previously, and it was divided into 3 tercile, that is low, medium, and high. And meaning by this low patient has the patient who is having low EGDR, they are having high insulin resistance, and patient who are having into the high tercile range of EGDR, they are having less insulin resistance, meaning by more insulin sensitive. And EGDR ranged from 5.6 to 12.44 milligrams per kg per minute in our population. Next, please. So now coming to the important parts of my study, that was the correlation of the various parameters of parameters in EGDR. And you could see that all parameters, that is the waist circumference, weight, BMI, HbA1c, and microvascular complication and neuropathy, they all correlated negatively with the EGDR, meaning by if the patient has higher waist circumference, they would have lower GDR, means high insulin resistance. Even patient has higher weight, high weight as per their centiles, because we are looking at a pediatric population, they had low EGDR. Even patient who has high BMI, they had low EGDR. Patient who has higher rates of complications, they were into the lower terciles of the EGDR. And regarding the individual complications, only neuropathy was statistically significantly correlated. Other parameters like albuminuria, retinopathy, and for insulin dose, it did not correlate significantly with the EGDR. Next, please. Regarding the association of EGDR with the various complications, this we can see that for all microvascular complications combined, the odds ratio was 0.17 with a confidence interval being less than 1, meaning by around patient who has high EGDR, they had around 83% less chances of developing a microvascular complication. And for neuropathy also, our confidence interval was less than 1, which was statistically significant. So in neuropathy, high EGDR means patient having high insulin sensitivity was protective factor for patient having neuropathy. We can see it other way around also, that patient who has low EGDR, they had high chances of developing microvascular complication, and those patient who has low EDR, they had also high chances of developing neuropathy complication. And importantly, as I said in the beginning of double diabetes concept, in our data, it did not correlate with the family history. So probably in our cohort, the environmental factor, lifestyle factors are contributing to the incidence of insulin resistance in these patients. Next, please. EGDR, it is a validated method for studying insulin resistance in type 1, but it has few caveats with it, which I'll be telling. And few studies, there are studies which have shown to be that EGDR, which is used for calculation of insulin resistance, it has correlated significantly with the microvascular and macrovascular complications of type 1 diabetes in adult patient, but very few studies has been done in children and adolescents. And data, as I showed in my result slide, that EGDR correlated significantly. That patient who has low EGDR, they are higher chances of developing microvascular complication. And in our cohort, no patient had any microvascular disease. And in Epstein et al., which was published in Diabetes Care, they have shown that this was done in the adult patient. They have shown that the EGDR correlated significantly, and the patient who had lowest EGDR, they had higher odds ratio of developing diabetes complication. And our study also showed the similar trend, albeit in children and adolescents. Next, please. So few limitations of and strength of my study. It is first of its kind to look into the insulin resistance in children and adolescents in our population. But few limitations of my study being, it was a cross-sectional data. Patients, ideal would have been the patients could have been followed up and then looked up into the EGDR, whether it is falling, it is going up. And puberty could have been a confounding factor into my data, because a majority, the mean age was 13 years around. So majority of them were during the peripubertal period. So this could have influenced the poor glycemic control, which was seen in the HbA1c, and also the insulin resistance. And complications of all the patients, few were recorded at the collection of the data, and few were also collected from the preceding six months data. So these are the limitations of my study. Next, please. Next, please. So I conclude by saying that low EGDR can be an useful parameter which can be looked into the clinical practice for picking up patients early who can have insulin resistance, and these patients who are having double-edged sword of insulin deficiency as well as insulin resistance, and they can have early onset and rapid progression of microvascular as well as macrovascular complication. But there is a problem with EGDR, because there is no predefined cutoff that this patient has this much EGDR, so this is low, this is high. But ideal would be to look into our population, a prospective study which would define a threshold for cutoffs to define patient having insulin resistance or not. Next, please. Thank you.
Do we have any questions from the judges, please?
Yeah, can I ask a couple of questions?
Yes, sir. Yes, sir. Please.
Okay. The first question is, many people with high glycemia would have a glucotoxicity and insulin resistance secondary to that, which is reversible. That is one question. So how do you account for this? And in terms of the complications that you're trying to correlate, number one. Number two, how did you define your type 1 diabetic patients? What was the basis of defining them as type 1? Many of them could have been type 2, just the family history absence, or what was it? That's the second thing. Third question also, please. The microvascular complications, you said that correlates very well with insulin resistance parameter that you measured. Mostly it is seen that it's the glycemia which correlates with microvascular complication. Insulin resistance per se tends to correlate more with macrovascular complications. What are your comments on these three?
Sir, regarding sir HbA1c and sir poor glycemic parameters, poor glycemic control contributing to the sir insulin resistance and glucotoxicity per se, sir. In EGDR formula, sir, they have taken account of HbA1c, sir, and the validation studies, they have said that HbA1c and poor control of HbA1c could itself lead to decreased glucose disposal, sir. So that could also be an individual contributor to the insulin resistance, sir. And sir, regarding sir,
so the correlation with the maybe more because of higher glycemia in them, isn't it?
Yes, sir. It could contribute, sir. Sir, yes, sir. It could contribute, sir. But they have taken, sir, two other parameters in the formula: waist circumference and hypertension, sir, which can also contribute to the sir decreased disposable rate, that is increased insulin resistance, sir. And sir, regarding sir diagnosis of type 1 diabetes, sir, the patients who were on our follow-up hospital, sir, majority of them had antibody screening done, but few patients who do not have any family history, who do not have any, they were, and those who required insulin from the beginning, sir, they were also included, sir. I would not say, sir, all of them had antibody profile, sir, majority of them had antibody profile, which was done for the diagnosis of type 1 diabetes, sir. And sir, the third question, sir, regarding the insulin resistance and sir, microvascular complications, sir. Although sir, insulin resistance has been shown to more predictive of macrovascular complications, sir, but for neuropathy complications and also for nephropathy, diabetic kidney disease, sir, insulin resistance, it does contribute to the pathogenesis, sir.
Okay.
Thank you, Dr. Vaibhav. We move to the next presentation by Dr. Tausif, the spectrum of DSDA single center experience. Dr. Tausif, please just put the PowerPoint on slideshow and then start off.
Am I audible?
Yeah, you're audible.
Good afternoon. Good afternoon, judges, their colleagues and friends. I, Dr. Tausif Nabi, thank Endocrine Update for giving me the opportunity to present the paper on characteristic etiology of disorders of sex development. As we know, DSD are congenital disorders characterized by atypical chromosomal gonadal or phenotypic sex. The incidence of DSD ranges from 1:4,500 to 1:50,100 per live birth, although it varies from geographical region from with respect to consanguinity and with respect to the type of the DSD. Infant born with ambiguous or abnormal genitalia may have indeterminate phenotypic sex. The birth of a child with DSD is a social and medical emergency, as some patients may present with adrenal life-threatening adrenal crisis, as in patients with CAH. The aim of the study was to see the clinical characteristics and the biochemical workup of these DSD patients at a tertiary unit and endocrine department. This was a hospital-based single center retrospective study. We recruited 73 cases of DSD who were evaluated and managed at our center over 10 years. The eligibility criteria included all the patients of DSD having overt genital ambiguity, genitalia with clitoromegaly, posterior labial fusion or inguinal or labial mass, or the patients having family history of DSD and genital or karyotype discordance. We excluded patients whose baseline investigations were missing or were having incomplete hormonal evaluation. The study was approved by the Institutional Ethical Committee. We took the detailed history, physical examination, laboratory and biochemical workup was done. History regarding age of presentation, sex of rearing, family history of any SIB death, consanguinity, ambiguous genitalia in the family, and the features of patient presenting with ulcerative crisis was noted. Physical examination focused on the presence of hyperpigmentation, blood pressure and anthropometry were done. Detailed local genital examination was done. We calculated their paired staging and external masculization score. Baseline investigations were done. All the patients underwent karyotyping. In case of patients with 46XY DSD, HCG stimulation was done as per the standard protocol. After on the fourth day, we collected their serum testo, dihydrotesto, and aldosterone dione. Two or more than twofold increase in testo was considered as a normal response for testosterone, that is functional testes. Testo to dihydrotesto of more than 20 was suggestive of 5-alpha reductase type 2 deficiency. For 17 beta HSD3 deficiency, a ratio of testo to aldosterone dione less than 0.8 in presence of low and high gonadotropins was suggestive of 17 beta HSD3 deficiency. PAS was diagnosed based on presence of genital ambiguity and high basal gonadotropins and testosterone. In all patients of 46XX DSD, we did baseline or random cortisol, 17 OHP, testo, and gonadotropins. CH was diagnosed if stimulated or unstimulated. 17 OHP was more than 100 nanograms per ml after giving synecting 250 micrograms and taking sample after 60 minutes. For localization of gonads, UAG or MRI was done. Coming to the results, we can see the various etiologies of DSD. Sex chromosomal DSD was present in around 20% of cases, 46XX DSD in 40%, and 46XY DSD in 40% of patients. In the sex chromosomal DSD, Klinefelter's and Turner syndrome were present in 7 patients each, while mixed gonadal dysgenesis was present in 1 patient. 46XX in 46XX DSD, CH was the most common, present in around 83% of patients, followed by gonadal dysgenesis, Mullerian agenesis, and ovotesticular DSD in 1 patient. While with respect to 46XY DSD, 5-alpha reductase type 2 deficiency was the most common, present in around 58% of patients, followed by CAIS, 17-beta HSG3 deficiency, PAIS, and vanishing testes syndrome. With respect to sex chromosomal DSD, the 7 patients of Turner syndrome presented at the age of puberty with primary amenorrhea, 3 patients present with short stature, and 1 patient was referred from previous stigmata of Turner syndrome. While patients of Klinefelter's syndrome presented with primary infertility and azoospermia during adulthood, while 1 patient of this Klinefelter's had history of undergoing unilateral orchidopexy in the childhood. 1 patient of mixed gonadal dysgenesis who was reared as male presented at age of 14 years with perineal hypospadias, micropenis, and bifid empty scrotum, and karyotype was typical of mixed gonadal dysgenesis, and MRI revealed uterus and testes. In case of 46XX DSD, CH was the most common, present in around 83% of patients. 66.6 patients had simple virilizing CH. The age of presentation varied from birth to 28 years. This patient of 28 years who was reared as a male presented to the urology department with intermittent cyclical hematuria. Actually, what he was having cyclic periods. He underwent UAG and it revealed he had uterus. So this was a disaster to the family that they came to know at the age of 20 years, he is actually not a male, he is a female. But their patients preferred to be reared as a male. So he underwent a hysterectomy and he was given testosterone replacement. While 33.3 patients had salt wasting crisis and they presented between 1 to 5 weeks of age, as we can see, 42% of CAH patients from our cohort, they were genetically female but were reared as male. Over 2 CAH patients had 17-beta hydroxylase deficiency. They present with genital ambiguity and hypertension and hypokalemia. In one of the patients, even we did 17-beta hydroxylase level after ACTH and it was high. 1 patient had ovotesticular DSD. He was reared as male, present at 3 months of age with asymmetrical laboscrotal fold. He had bilateral palpable gonads in this laboscrotal fold. Histopathology revealed that he had ovotestes on the left side and had rudimentary male and female gonads. With respect to 46XY DSD, 5-alpha reductase was most common. They presented at the infancy, penoscrotal perineal hypospadias was present. They had bifid scrotum or micropenis. History of consanguinity was present in around 53% of patients. CAS
Tosif, you have to hurry up.
CAS was diagnosed in 6 patients. They had all had female external genitalia and palpable gonads in the inguinal region. While 2 patients of 17-beta HSG3 deficiency both presented at puberty. 1 was reared as male, present at 14 years with bifid scrotum and hypospadias, and HCG stimulation test of testo to endosterone ratio suggested 17-beta HSG3 deficiency. While other patient was reared as female and they presented at 13 years with progressive virilization, which typically occurs with this DSD. PAS was diagnosed in one patient who presented at puberty with bilateral gynecomastia. One patient had vanishing testicular syndrome, who was unambiguous male genitalia, non-palpable gonads, undetectable testo and AMH and MRI revealed no gonads. This is the table showing the comparison of the various studies of DSD with regards to India and other countries like Pakistan, Germany, and Australia. We can see in our patients, there were 73% of patients which were recruited over 10 years. There is a study, Walia R from PGI Chandigarh. There is Shiraza, that is again from our center, but it is from the pediatric department. There is Manzoor J, which is from Pakistan. There is Haldar A, Dr. Haldar A, which is from IGPGI. There is Al Aga, which is from Saudi Arabia and Australia, and other study is from Germany. What we can remarkably see in our cases, in our study, 5-alpha reductase was very high in our study. Although the reasons could be postulated that the ratio which we have used in our study is we have taken the testo to DST ratio more than 20, while the study from PGI Chandigarh had taken ratio more than 30. And in our study, around 53% of 5-alpha reductase patients had consanguinity. Maybe this may be a factor, or there may be a geographic or ethnic variation. So we need to look into the genetics of it, why there was a slightly preponderance of 5-alpha reductase. Although study from our center Shiraza, there was only 10% of 5-alpha reductase, but they usually recruited patients from in 0 to 19 years of age. Maybe the department which is dealing with these DSD patients.
Dr. Tausif, you have to wind up. It is beyond 10 minutes now.
So to conclude, in our study, equal number of patients had 46XY and 46XX DSD. Like rest of the world, 5-alpha reductase is the most common cause of 46XY DSD, while CH is the most common cause of 46XX DSD. Classification and management of ambiguous genitalia at birth remains a challenge for the all professionals. Detailed history and physical examination complemented with laboratory workup is required. Delayed diagnosis and delayed referral are the common features in these patients. We need to have national and international registries which may help provide better understanding of the incidence and the clinical course of such disorders. And we need to sanitize the public regarding the DSD so that we can have early referral and management of these patients, as the social stigma is highly associated with it. Thank you.
Any quick questions,
Any
please?
questions?
None from my side.
None from my side also. Is this from Mulana?
Actually, this study is from Sher Kashmir Institute of Medical Science, where I did my DM.
Okay.
Thank you, Dr. Tausif. We go to the next one, Dr. Nadima. Dr. Nadima Rafiq.
Yeah, 1 second. Are you able to see the slides?
Yeah. Dr. Nadima, I request you to be very brief, 7 to 8 minutes for presentation. Please go ahead.
Good afternoon, sir. Am I audible? Hello,
Yeah.
Good afternoon, sir. Okay, so myself, Dr. Nadima, I'm going to good afternoon, sir. I'm going to present the oral presentation of energy expenditure and its relationship with BMI among children. As we all know that physical activity is a key determinant of the energy expenditure and is the basic to energy balance and weight control. As per WHO recommendation for the age group of 5 to 17 years, there should be at least 60 minutes of moderate to vigorous intensity physical activity daily. The school-based students' health survey in India, it reported that overall 23% of sedentary behavior is found in school children. Growing burden of overweight and obesity, along with its serious health complications that include the non-communicable diseases, is increasing in children because of the low level of energy expenditure in the form of physical inactivity. High BMI in childhood is associated with significantly because of the reduction in quality of life and a wide range of serious health complications, as we all know, like cardiovascular diseases, respiratory diseases, and also diabetes. It is primarily due to the changes in the social and the physical environment over the past 3 decades, which have adversely influenced children's eating and activity behavior, including the attitude and the behavior of their parents. The aim and objective of our study was to assess the level of energy expenditure and its relationship with BMI among children. The design of the study was that it was a prospective cross-sectional study which was conducted for a period of 1 year. Children of both gender of in the age group of 6 to 14 years from both rural and urban areas in the area of Jammu were selected. 6 high schools, each from rural as well as from urban areas, were selected randomly using simple random sampling procedure. Then the study was approved by Institution of Ethical Committee. Informed consent was obtained from all. This is the total students were 230 that were sample size was 230, 123 from rural and from urban 107. So the zones that were from the rural, the zone was Miran Sahab, and from the urban it was the Jammu main Jammu. So total number of the high schools that were selected were 12. Then how we designed the study, it was the energy expenditure levels were assessed by using a modified global physical activity questionnaire version 2, and then it was expressed in the metabolic equivalence, that is MET minutes per week. And this was classified into vigorous, moderate, and low physical activity as per WHO recommendation for physical activity. Physical activity was defined as vigorous if the student had at least 7 days of any of the combination of activities accumulating at least 3360 MET minutes per week. And the domains of these MET minutes were physical activity during the work, that means when the student was at work, physical activity when he was in the recreational place, and physical activity during the travel. So these were the 3 domains that were actually studied. Moderate physical activity was if he met the MET minutes of 1680 to 3359 MET minutes per week, and low if the student did not met both of these conditions. The maximum number of children studied were in the age group of 12 to 14 years with slight preponderance in males, that is 47% versus 38% females. Higher proportion of sample compromise of children from the rural areas. This is the table which shows the energy expenditure expressed in MET minutes per week in different domains, and its classification as vigorous, moderate, and low as per the WHO recommendation, along with its sedentary behavior on an average day. According to the physical act, as I defined what the vigorous and already explained what the vigorous and the moderate means. Then next. Am I audible? Sir, am I audible?
Yeah, you're audible. Yeah, you're audible.
Next slide, please.
Anand, please move the slide.
Dr. Nadima, the slides are being shared from your end only.
Not happening.
There may be a small button in the left end of the screen. In the left corner of the screen, there will be some play button will be there. Just press on that. Yes.
The relationship of the BMI with the physical activity and the sedentary behavior. So both the overweight and obese, almost 31% had the low physical activity, and 68% had the moderate and vigorous activity. Similarly, in the sedentary behavior, and it was associated with the BMI was associated with the physical activity. So about 1/3 of those among the overweight and obese were engaged in low physical activity. Those engaged in low physical activity were 6 times at higher risk. The association of overweight and obesity with physical activity came to be highly significant. 90% among overweight and obese children were having sedentary behavior and were 2.2 times at higher risk. However, the association of overweight and obesity with sedentary behavior was not found to be statistically significant. We conclude the study with that low level of energy expenditure and to some extent sedentary behavior also contributes significantly to obesity in children. Therefore, it is the need of the hour to create an environment for the adoption of healthy lifestyle, including physical activity, which should be prompted at all levels. WHO support policies and programs for the adoption of the healthy lifestyle through changes in the environmental behavior and education. So low level of energy expenditure contributes significantly to childhood obesity. Adoption of a healthy lifestyle is the key message. Thank you.
What is new that you have found? Because we are all aware that low levels of energy expenditure and sedentary behavior contributes to obesity in childhood as well. So what is the new thing that you have found from your study?
The new thing, it's actually we wanted to compare the study with the other studies that we're already having, and we wanted to see the physical activity with the growing knowledge of the people. Has there been any change in the physical activities that the students are going through in the school or during the travel to the school or during recreational activities? Has there occurred any modification in that, or is it same? And effect of the social media, like for example the sedentary lifestyle and the amount of the time given to the media, the TV time, and all the, have they increased, or with the knowledge, with the increase in knowledge, has it increased, or it's just the same? Like the parents are getting educated, but they are not applying their education to their children.
Thank you.
In terms of the physical activity, like they are not increasing the physical activity of the children, although they are, all of us are knowledgeable that we should do physical activities, but that's not practically we are doing. And also similarly, the healthy behaviors at the school, whether it is healthy behavior at the school, are they getting proper activity in the school or not? Or for example, the travel time, whether most of the parents, they wanted that the children should go by walking, like they should go by walking to school, so that at least they can increase their activity through that. But most of the parents, they want that their children should be, at least they should go by buses or.
Dr. Nadima, thank you. We move to the next presentation. Dr. Sandeep, I request you to be very brief. We have to finish in time. Thank you.
Good afternoon, sir. I'm audible and visible, sir?
Yeah, please go ahead.
Good afternoon, sirs. I would be presenting a case series of neonatal and infant hypoglycemia. My case number 1 is a 14-month-old male child who presented with recurrent vomiting and seizures. Mother gave a characteristic history that child used to look sweaty at the night and used to wake up hungry. And this used to happen in episodes of after about 2 to 3 hours after meal in the night. There was no history suggestive of any systemic involvement or systemic ailments. And the child was born at 40 weeks to a non-diabetic mother. It was a normal vaginal delivery. Mother did not take any drugs during the pregnancy. Birth weight was normal. Immediate postnatal period was uneventful, and child had been exclusively breastfed since day 1. The child was a product of non-consanguineous marriage, and the family history was non-contributory, and there were no metabolic disorders in the family. The birth weight was 3.6 kilograms, present weight is 11 kgs, length was 57 centimeter, occipitofrontal circumference was 38 centimeter. On clinical examination, child had excessive cry, was afebrile, was hemodynamically stable, and had no evidence of respiratory distress. Child had a pallor. There was no evidence of dehydration. Child had no icterus cyanosis. There were no cleft lip or palate, and no dysmorphic features were appreciated. No specific odor or any signs of insulin resistance were appreciated on clinical examination, and external genitalia was normal. Further systemic examination was done, and it was essentially normal. Abdominal examination did not reveal any hepatosplenomegaly. This is a chart which showed during the initial days when child had multiple episodes of hypoglycemia. Routine hematological and biochemical investigations were done for the child, and they were normal, including liver function test. Urine ketones were negative. Ultrasonography was normal. There was no evidence of hypertrophic pyloric stenosis. 2D echocardiography was normal with no cardiomegaly or hypertrophy. Fundus examination and EEG were normal. Further endocrine investigations were done, which revealed raised insulin and C-peptide level. Levels are shown in this slide as highlighted. Other axes were normal. Blood ketones were 0.1 millimoles per liter, which were low. Serum lactate and ammonias were normal. Under a strict supervision, a diagnostic fast was done for the child, and at a level of at the blood glucose level of 22 milligram per deciliter, corresponding insulin was 20.42 micro international unit per liter, and child had a very good response to injection glucagon, and glucose increased from 22 to 87 milligram per deciliter. Further, with this background, the abdominal imaging in the form of MRI was done, and which revealed a 4 millimeter focal area of altered signal intensity in the head of pancreas with no guide towards anywhere. Hence, the Dopa PET scan was done for the child, which revealed the diffuse tracer uptake in the pancreas and no focal lesion. Next generation sequencing with specific to hyperinsulinemic genes was done, and which did not reveal any pathological variants. Hence, the diagnosis of persistent hyperinsulinemic hypoglycemia of infancy was made in this child, and the entity was earlier known to be a nesidioblastosis. Child was initially managed with dextrose infusions, slowly weaned off to the oral feeds, and the child was started on tablet digoxide. And presently, child is on 13 milligram per kg per day. Due to non-availability of digoxide, child was shifted to octreotide during lockdown, but child had a suboptimal response. Presently, child has a good is euglycemic with digoxide, but child has started having the side effects like in the form of hypertrichosis, as shown in this latest image of this child. Counseling of the parents has been done with respect to surgery, but even the treating team as well as the parents are cautious because with respect to radical surgery and its repercussion in the young child. My case number 2 is a 14-month male child who at birth was detected to have recurrent episodes of hypoglycemia, omphalocele, macroglossia. The child was product of non-consanguineous marriage. It was a spontaneous conception, and child was large for gestational age at birth. There was no significant family history, and mother was non-diabetic. On clinical examination, child had macroglossia, external air pits and earlobe groups were appreciated. Child had asymmetric enlargement of the right side of the body, right upper and lower limb. There were no cleft palate or any other dysmorphic feature. And abdominal examination revealed hepatosplenomegaly and well-healed scar of the omphalocele surgery. Other systemic examination were essentially normal. These are the images of the child. Number 1 image, we can appreciate macroglossia. In the number 2 middle image, we can appreciate earlobe groups in the child. And in the number 3 image, we can see the healed scar of the omphalocele in the child, as well as we can appreciate the isolated ipsilateral isolated enlargement of the right upper and lower right side of the body in this patient. The endocrine investigation revealed raised insulin and C-peptide. Other endocrine axes were normal. Baseline serum alpha-fetoprotein was done for the child, which were normal. And ultrasonography revealed the hepatosplenomegaly. 2D echocardiography was normal. And hence, with this clinical information, the diagnosis of Beck-with-Wiedemann syndrome was made in this child. Initially managed with dextrose infusion, slowly switched to the oral feeds. And with the oral feeds, only child has been euglycemic without any requirement of the treatment. Omphalocele surgery has been done for this child. Prostatectomy has been advised. Child has been put on follow-up with ultrasound every 3 months and alpha-fetoprotein every 6 weeks in the view of increased incidence of the malignancies in these children, which generally occur before the 10 years of age. My case number 3 is 1 month male child who presented with recurrent episodes of symptomatic hypoglycemia. Child was noticed to be lethargic and sick looking when was detected to have hypoglycemia. There was no history suggestive of any systemic involvement or any focal deficit. The consent of use of pictures is not given in this case by the parents. The child was born at 34 weeks and 4 days of gestation, and by LSCS, indication was intrauterine growth retardation. Mother had a PIH and deranged liver functions and thrombocytopenia during pregnancy, which is seen with the specific to the diagnosis of this case. Birth weight of the child was 1.5 kilograms. Family history was non-contributory. Mother did not have any diabetes, and although mother was given steroids at 32 weeks of gestation for the lung maturity. Further investigations were done for this child, and it revealed, the endocrine investigation revealed hypoglycemia, low insulin, low ketones, and high ammonia levels. Other investigations and endocrine axes were normal. 2D echocardiography was normal. Ultrasound did not reveal any organomegaly. With these 4 characteristics clinical finding, we homed on to the diagnosis of fatty acid oxidation defect, and tandem mass spectroscopy was ordered for this patient in a dried blood sample, which confirmed elevated C16 acyl carnitine. Hence, the child was started with medium chain triglyceride in the form of coconut oil, 5 drops in every feed, and child had dramatic response and remained euglycemic thereafter. The clinical exome sequencing was done, and the fatty acid oxidation defect was confirmed for this child, and trifunctional protein deficiency was revealed. Hence, this child was given the label of trifunctional protein deficiency. Child was discharged, was advised to avoid prolonged fasting, was not to do strenuous exercises or exposure to extremes of climate. Long chain fatty acid restricted diet was advised to the child. MCT oil in the form of coconut oil we advised to the child was continued in the dose of 5 drops in each feed to restrict the calorie intake to 25%. My case number 4 is a 12 hours old baby, a second of the twin, detected hypoglycemia and developed seizure thereafter, was born by LSC as a 34 weeks, 1 day gestation. Immediate postnatal period was uneventful. Mother, although was a hypothyroid, well controlled with thyroxine replacement. And child developed hypoglycemia starting from 3 hours of the night. At blood glucose level of 39 milligram per deciliter, insulin and C-peptide was elevated. Child went on to require increased doses of glucose infusion from 3 hours to 58 hours. Dose was increased to 12 milligram per kg per minute. But surprisingly, child on day 7 the sugars of the child started normalizing, and child remained euglycemic with normal feeds. Infection was ruled out with the follow-up of the child, and procalcitonin was also negative. The routine hematological investigations were normal. Calcium, magnesium was low in the setting of normal PTH in this child, and which was normalized after the supplementation. Urine ketones were negative in this child. Insulin was elevated, and other endocrine excesses were normal. Hence, the diagnosis of transitional hyperinsulinemic hypoglycemia of infancy was made in this child. Child was given the frequent feeds. Normal feed was advised to the child. He remained euglycemic. Initial calcium, vitamin D, magnesium was replaced, and which has been normal throughout with the follow-up with this child. So just to summarize, I have 4 cases here, and each had its own peculiarities. All were the male, and all were symptomatic. So basically, what helped in clinching the diagnosis were doing the clinical examination, the testing for insulin, C-peptide, and ketones. So Becker with Wiedemann had a characteristic in the setting of high insulin and non-ketotic hypoglycemia. They were a characteristics defect which helped in diagnosing the case. In the case of long chain fatty acid oxidation defect, the child had low insulin, non-ketotic hypoglycemia, and raised ammonia levels were seen in this child. Sorry. So raised ammonia level was seen in the child, and the diagnosis were confirmed by the advanced tests like nuclear imaging, clinical genetic testing, tandem mass spectroscopy, and in the transient hypoglycemia simply by the clinical response. Appropriate treatment was advised to them, and the response prognosis is good in the case number 2 and case number 4. Beckwith Wiedemann has a good response. They go on to grow till adulthood and even transitional hypoglycemia. Case number 1 and case number 3 has a poor prognosis, and continuous supervision and follow-up has to be done in these children. The take-home messages from this presentation was to have a recap of spectrum of neonatal and infant hypoglycemia, and to stress upon the importance of characteristic clinical finding and importance of insulin, C-peptide, and ketones in simplifying the algorithm. With this, I come to the end of my case series. Thank you, sir.
Thank you.
Thank you, sir. We move to the next presentation by Dr. Priyadarshini. Dr. Priyadarshini, please.
Sir, is my screen visible, sir?
Yeah, you're audible. Your slides are there on. You can start.
Dr. Priyadarshini, can you please share the screen again if you're sharing, or else I'll do it.
Is it visible, ma'am? No?
No.
Please share your screen.
No, ma'am?
No, Dr. Priyadarshini, I'll do it. You just...
1 second, ma'am. 1 second, ma'am.
Dr. Suna, you can share this.
Yeah, Dr. Priyadarshini, I'm going to do it. You just tell me when to do next. Okay, thank you.
Yeah, please start. We are running out of time.
Okay, sir. Sir, I'm not able to see the screen. One second. Okay, sir. Good evening, judges. I'm Dr. Priyadarshini. Last but not the least, I'm here to present my study on clitoral dimensions in female neonates, a normative study from South India. Assessment of genitalia is an important part of neonatal examination. Virilization in a female neonate usually denotes a serious condition like congenital adrenal hyperplasia, as our previous speaker also told, Dr. Tausib Nasib. Congenital adrenal hyperplasia is the most common cause of 46XX DST. It requires immediate diagnosis and treatment. Although ambiguous genitalia is easy enough to identify, it is important to be able to identify clitoromegaly as a lesser degrees of virilization. Though staging of clitoromegaly has been discussed by Prader, it was a subjective staging and with lacunae. So why do we need normative data on clitoral dimensions? Identification of clitoromegaly also depends on accurate measurement, and it is possible only if normative data and cutoffs are available. Data on clitoral measurements is very limited with only one study from India, that is Kolkata. Regional, racial, and ethnic differences in both phallic proportions and to a lesser extent in clitoral dimensions have been reported. This table shows the regional differences in mean clitoral length in various studies in North America, Turkey, Nigeria, Kumasi, Korea, Japan, India, etc. So, as we all know, the causes of enlarged clitoris are like fetal causes like congenital adrenal hyperplasia, etc. Maternal causes like increased androgen protection, drug-induced like synthetic progestogen intake, and syndromes like Beckwith-Wiedemann syndromes, etc. We aimed in our study to generate a normative data on clitoral dimensions like clitoral length, width, clitoral index, and anogenital distance and anogenital ratio in South Indian neonates. We also aimed to correlate the clitoral dimensions, anogenital distance, and the anogenital ratio with the anthropometric parameters like head circumference, length, and birth weight of the baby, and with the gestational age and maternal comorbidities. Our other objective was also to compare the clitoral length obtained in our study with the other studies from other regions. It is a hospital-based cross-sectional study where we included 277 hemodynamically stable term and preterm neonates, irrespective of their gestational age and birth weight, with no ambiguous genitalia or vulval mass. They should belong to South Indian states, and we included those parents who gave consent. After the institutional review board clearance and informed written consent by the parents, where relevant details were entered in a semi-structured proforma like this under strict aseptic precautions with the infant's knees and hips flexed like a frog position. Measurements were taken using a plastic digital vernier caliper. So we measured clitoral length, clitoral width, anogenital distance, which includes both anofasciate distance and the anoclitoral distance. Anofasciate distance is the distance between the center of the anus and the and this fasciae, and the anoclitoral distance is between the center of the anus and the base of the clitoris. So we also calculated clitoral index as the product of clitoral length and clitoral width. We did a statistical analysis, and the results are like among 277 babies, 82.7% per term and 17.3% per preterm. And these were the measurements. Mean clitoral length was 6.6 plus or minus 1.7 millimeter. Mean clitoral width was 6.7 plus or minus 1 millimeter. Clitoral index was 44.5 plus or minus 15.5 millimeter square. Anofasciate distance was 11.8 plus or minus 1.8 millimeter. Anoclitoral distance was 30.4 plus or minus 3.4 millimeter. And last, the anogenital ratio was 0.4 plus or minus 0.05. And the respective ranges were also calculated. We also derived 3rd, 50th, and 97th centiles for these mean clitoral length and mean clitoral width. And more than 97th centile can be considered as clitoromegaly. Here, 97th centile for mean clitoral length was 9.98 millimeter, and for clitoral width, it was 8.45 millimeter. And comparing the term versus preterm, mean clitoral length, mean clitoral width, and the clitoral index did not vary significantly. It was not different between term and preterm statistically, but anofasciate distance, anoclitoral distance was lesser in preterm as expected. anogenital ratio was significantly higher in preterms. On naked eye examination, we expected that the most babies would have their clitoris covered, except in cases of clitoromegaly or preterm infants. But we found that clitoris was visible in 203 out of 229 term babies and 47 out of 48 term babies. Although this was statistically significant, it did not support our theory that visible clitoris suggests clitoromegaly, especially in term neonates. We had a term baby whose mother had a drug intake of progesterone, which was dihydrogesterone, during pregnancy, and this baby had a mean clitoral length of 10.3 millimeter, mean clitoral width of 8.45 millimeter, anophaseal distance of 14.1 millimeter, and anogenital ratio of 0.48. So we analyzed the maternal risk factors like gestational. 20.2% mothers had gestational diabetes mellitus, 13.3% had hypertensive disorders, 27% had hypothyroidism, 5% mothers were on steroid therapy. Steroids include betamethasone, hydrocortisone, and prednisolone. The most common steroid used was betamethasone, the most common reason being antenatal steroids for lung maturity. The hormonal problems include PCOS and progesterone intake. We found that the mean clitoral length was not affected by any of those maternal risk factors. Mean clitoral width was higher in babies of mothers who were on antenatal steroids. However, the anogenital ratio was higher in those babies who had gestational diabetes mellitus, polycystic ovarian syndrome, progesterone intake, and antenatal steroids. This anogenital ratio is considered as a marker of virilization. So these are the various studies done and the comparison between mean clitoral length and mean clitoral width with our studies. So with this, I show that the Nigerian study reported the highest mean clitoral length of 7.7 millimeter, and the Indian study from Kolkata reported the mean clitoral length of 3.1 millimeter. Our study reported a mean clitoral length of 6.6 millimeter, which was similar to the Israeli Bedouins. And mean clitoral width, our study reported the highest mean clitoral width. All other studies were lesser than this. Anogenital ratio, our study reported an anogenital ratio of 0.4, which was slightly lesser than the Southwest Nigerian study and slightly higher than the California study by Caligre et al. Mean clitoral length had a moderate positive correlation with the mean clitoral width. We did not find any correlation of mean clitoral length or width with gestational age, head circumference, length, or birth weight. Conclusion: there was no correlation between mean clitoral length or width with any of the anthropometric measurements or gestational age. Preterm babies had a higher mean clitoral length and mean clitoral width. Maternal factors like gestational diabetes mellitus, PCOS, antenatal steroids, and progesterone may affect clitoral dimensions in the neonatal period. Newborn screenings reports of all these neonates were normal. 17 OHP reports were normal. So this study has obtained South Indian normative data for genital measurements in female neonates whose values were similar to those from Israel. So I conclude by saying that there is a need to generate country-specific or region-specific normative data for clitoral dimensions. Here, a 97th centile cutoff of 9.98 millimeter for clitoral length and 8.45 millimeter for clitoral width may be a good reference point to prompt investigations for clitoromegaly. So normal values for neonatal clitoral measurements generated can serve as a regional reference standards. It may help the pediatrician or neonatologist to accurately diagnose clitoromegaly and underlying etiology and so avoid unnecessary hormonal evaluations. I thank all kind hearts who has been part of a study and thank the Endo Update team for giving me this wonderful opportunity. Thank you, sir. Thank you, ma'am.
I have two very small, quick questions. One, why do you think is the difference in the clitoral length between the study in Kolkata and yours? Number one. Secondly, when you're generating normative data, would you think that all the conditions in the mother, like PCOS or GDM, should have been excluded because this is a normative study?
The Kolkata, the first question, sir, the Kolkata study, they didn't include all those progesterone. They didn't compare any intake of progesterone thing or steroids, any influence of maternal risk factors basically. So maybe the influence of which we had a higher mean clitoral length than them. Then, sir.
The same thing, the second question comes out of this only. Do we need to exclude all the conditions which modify or which have an effect on clitoral length before we generate normative data?
We basically excluded the ambiguous genitalia babies, sir, like apparent ambiguous genitalia or any vulval masses. But we wanted to compare the other maternal risk factors, so we did not exclude those mothers who were on drugs or those mothers who were on gestation with gestational diabetes mellitus, etc. Sir.
Thank you.
Thank you, sir.
Thank you, Dr. Priyadarshini. Thank you all the judges for actively conducting the session, and thank you all the presenters for an excellent case series and case reports and original studies. We hope to have many of them in the forthcoming SECon, which is coming few months away. With this, we come to the end of the oral and poster sessions. I hand over the mic to Professor Rakesh, who is the organizing chairperson of the PDENDO update for the start of the scientific session of day 2. Over to you, sir.
Thank you, Dr. Hari. I thank you and Dr. Santosh for conducting the posters and the oral presentations, and all the judges who have joined in, Dr. S.V. Madhu and Dr. Neeraj Agarwal for joining in, and Dr. D.V.S. Reddy and Dr. Shashank Joshi also for joining in and judging the posters. I would now welcome all the delegates, all the participants who have joined in, and all the chairpersons and all the panelists who have joined in, and we will move on to the sessions. And the first session, I would invite our rapporteur Prem Narayan, Dr. Prem Narayan, to take over and conduct the proceedings.
Hello, good evening, sir, and good evening, one and all. At the outset, I thank Rakesh Sagai sir and Sri Nagesh sir for giving me this opportunity to coordinate this session. And so we are having a good or exciting sessions of Endocrinology update, which started the day 1 yesterday. We had very good discussion on the growth, and then we had the diabetes in young, and also essential endocrinology. So it was all, I mean, we are all the stalwarts under one roof, and the national and international faculty. So it was an exciting session all in the day 1. And now today we had the poster discussions and the oral presentations. Next, so today the international faculty presentations start with the session 5, that is on adrenal and puberty. So this is we start with this day, and we have the chairpersons for the day. I mean, again, two stalwarts in this field from the Indian endocrinology. First, I would like to welcome Professor Mala Dharmalingam, Madam. Madam is a professor and head of the department at the MS Ramaiah Medical College, Bangalore. He is director of the Bangalore Endocrinology and Diabetes Research Center. Innumerous number of publications with 127 original research publications in international and national journal. Also, Madam has been the vice president of the Endocrine Society of India in the tenure of 2011. Madam has a lot of awards. You can see 10 awards and 13 orations. Madam is also the ethics committee of ICMR. So welcome, Madam. And so next we have another stalwart from the Indian endocrinology, that is Professor Nilanjan Sen Gupta, sir. So he's a professor and head at the Department of Endocrinology at NRS Medical College, Calcutta. So he's also the vice president of the Diabetic Association of India, West Bengal. So he's also the assistant general secretary at the Endocrine Society of Bengal, national advisory board member, and also secretary board of studies in endocrinology and West Bengal University Sciences, and so has more than 75 publications in national and international journals. So I welcome both these stalwarts to the chair this session, and also to introduce the speakers for the day. Welcome once again, Mala Madam and Nilanjan Sen Gupta, sir. Over to you, sir.
Thank you, Prem. Am I audible and visible?
Yes, sir.
Yeah. So we have an exciting session as described by Prem. To start with, it's my pleasant duty to introduce a stalwart in global endocrinology, Professor George P. Crosses, who is among one of the 250 most prominent clinical investigators across all disciplines in the world. And according to ISI, he is the highest cited pediatrician and endocrinologist in the world. And the rare syndrome of primary generalized glucocorticoid resistance, which he will be going to talk about now, also bears his name, and he is based at Athens, Greece. So over to you, sir, for to take us through the disease that you have only described.
I don't know if you can hear me.
Yeah.
Yes, sir.
Let me open the talk. As an older man, I'm not very familiar with a lot of the digital stuff.
So you can go to the PowerPoint icon and the below.
You can see it. All right. Can you see my PowerPoint now?
No, you'll have to maximize that. You'll have to go to the PowerPoint.
Okay.
Open it. Yeah, it's opening actually. Your PowerPoint is opening.
Okay, good, good.
Yeah, we can see it now.
See it. Okay.
Just make it screenshot then.
Let me increase the screen.
The downside, the third one. The right corner down.
This is view.
Yes,
sir. Yes, sir.
On the top, you can use the slideshow one, sir.
Yeah.
On the top, you have the slideshow option.
Do you see it now?
Yeah, we can see that, but you can make it slideshow option above or below, either way.
Yeah.
Okay.
Yeah. Full screen.
Full screen slideshow.
All right.
Yeah, the one
just
right.
the arrow is just the next one on the top.
So we're in the first slide. The title is Crusoe syndrome.
Yeah, absolutely.
All right. Okay, great. The Nobel Prize in 1950 was given to three scientists, Edward Kendall, Thaddeus Reichstein, and the physician Philip Hens from the Mayo Clinic for the discovery and use of cortisone, which is a metabolite of cortisol, by these three scientists. The first study that was done was treatment of rheumatoid arthritis, which was described as miraculous. Now, this lecture has four brief parts. Number one, I'll say a few words about the new biology and the complexity, because if you want to understand glucocorticoids, you have to understand complexity. Second, I'll say a few words about the molecular actions of glucocorticoids, and that's where the syndromes of glucocorticoid resistance and hypersensitivity belong. Then about pervasiveness of glucocorticoid actions and expanding clinical implications. A few words about complexity. We are all assembled complex systems, multiple units, genes, molecules, cells, modules, networks, systems, programs, and glucocorticoids are involved in two major systems and programs of the human body. One is the stress system, and the other is the immune system. They play tremendous roles. Why are we so complex, humans? Well, first of all, we have very complex cells. That's basically what I'm going to say. 42,000 genes, over 1 million regulatory regions in our genome. And in addition to genetics, now we have the so-called epigenetics. Complexity has gone up in logarithmic sizes. Now, a few words about the molecular actions of glucocorticoids. As you know, glucocorticoids are the end product of the hypothalamic pituitary adrenal axis on the left. CRH, with the help of AVP, causes secretion of ACTH, which causes secretion of cortisol. The HPA axis is connected directly with the arousal system, the locus coeruleus, and the autonomic nervous system. So when we're stressed, if we measure hormones in the periphery, we'll find increased cortisol, increased norepinephrine and epinephrine, as well as interleukin-6, which is secreted by the Kaffer cells primarily in the liver in response to norepinephrine and epinephrine through beta-adrenergic receptors. And also these neurons secrete immune CRH, which is basically a degranulator of mast cells. So every time you're stressed, all of these hormones are secreted and mast cells are degranulating everywhere there are mast cells. And that's supposed to help us deal with stress. Now, glucocorticoids are steroids. In other words, they're lipids. They cross the membrane very easily. They go and bind to the glucocorticoid receptor, which is kept in a good state, binding state, because it's bound to heat shock proteins and the FKBPs. Then, once the glucocorticoid attaches to the receptor is released from this conglomerates there, and through the nuclear pores goes inside the cell. And you need ATP for that. Now, inside the cell, it can act as a dimer or heteromer. As a dimer, it can activate the so-called glucocorticoid response elements, which can be positive or negative. And as a monomer, can interact with other transcription factors, such as NF-kappa B, for example, to influence their actions. Once it's bound to the GREs, the glucocorticoid receptor is attracting little machines, molecular machines, and I will focus on the middle one here, the coactivator complex, which is attracted to the receptor and comes and binds to the RNA polymerase II to alter the rate of transcription of genes. It can be positive or negative. Now, in addition to this coactivator complex, there is another complex called co-repressor complex. And through that complex, the glucocorticoid receptor can suppress a number of genes once it's activated. Now, the glucocorticoid receptor, the human one, it's on chromosome 5. It's a series of exons. It's 10 exons. By alternative splicing, we produce two forms of the receptor. The glucocorticoid receptor alpha, which is active, and the glucocorticoid receptor beta, which is inactive. And in fact, if you have a GR alpha and GR beta heterodimer, this heterodimer is not as active as a GR alpha homodimer. On the other hand, the GR beta homodimer not only is inactive, but it can influence another set of genes that are not influenced normally by the glucocorticoid receptor alpha. So the receptor eventually has three functional domains: the immunogenic domain, the DNA binding domain, and the ligand binding domain. And the problems that we have anywhere in the receptor can give us either a underfunctional receptor or a hyperfunctional receptor. And in addition to those functions, domains, the glucocorticoid receptor has a part that binds to the heat shock protein, a part that's responsible for dimerization, two parts that's responsible for nuclear translocation, and two parts that are responsible for transactivation of the dimer. In other words, to be able to transactivate genes. Now, to make things a little more complex, eventually, we ended up with 8 forms of GR alpha with different N-terminal domains, and 8 forms of GR beta. And each of these forms, isoforms, has different activity alone or in combination with others. And this, I put this down to help you understand that glucocorticoids are not a simple hormone, okay? In every cell, there is tremendous mathematical chains. And the end result, which is the glucocorticoid action, is a product of very complex probability mathematics. Now, in addition to these isoforms, there are many interactions between the receptors and molecules outside and inside the cell. I will try to make things as concrete and easy as possible. In the Oracle of Delphi, there is an inscription which says, everything in moderation, miten agan. And basically what it says is that many functions, especially homeostatic functions in the body, operate well in the middle. That's what we call eustasis or homeostasis. But if it's too much, it's a problem. If it's too little, it's a problem. So we have deficiency and excess. And the glucocorticoids as hormones are a typical example of that. Glucocorticoids must be somewhere in the middle. Too much is Cushing's, too little is Addison's. Now, what happens when you have glucocorticoid excess, which corresponds to glucocorticoid hypersensitivity? From the central nervous system, we have insomnia, anxiety, depression, defective cognition. From the liver, increased gluconeogenesis, liposynthesis, insulin resistance, fat, accumulation of visceral fat, muscles, insulin resistance, blood vessels, hypertension, bone, stunted growth, etc. The opposite happens in glucocorticoid deficiency, which of course corresponds to glucocorticoid resistance. So here, like in Addison's, we have fatigue, somnolence, malaise, defective cognition, hypoglycemia, increased insulin sensitivity, loss of weight, increased insulin sensitivity at the level of the muscles, and hypotension. And here are three possible states. The normal state's in the middle. This is the HV axis. The glucocorticoid hypersensitivity is on the left. What you expect there is decreased cortisol concentration. Why? Because of increased cortisol feedback at the level of the hypothalamus and the pituitary. In contrast, in glucocorticoid resistance, because there is defective glucocorticoid signaling at the level of hypothalamus and the pituitary, we have hypersecretion of glucocorticoids. And in order for the organism to maintain the hypersecretion, it hyperproduces CRH and vasopressin. It hyperproduces androgens, ACTH, of course, and through ACTH, androgens and glucocorticoids and mineralocorticoids. And that's where the problems are, okay? So in glucocorticoid hypersensitivity, the problems are associated with low cortisol and high effects of cortisol. In resistance, we're having high cortisol and decreased effects of cortisol. Okay, this is now 1980, and we brought two patients from Holland to the NIH when I was then, a father and a son. The father had tremendously high levels of cortisol. In other words, urinary free cortisol was about 2,000. In the son, it was about 200. The father had hypertension. He had early puberty, and he was relatively short. The son was tall, no hypertension, generally asymptomatic. So we hypothesized at the time that this must be a homozygous, the father and the son a heterozygous. And we did a very extensive work, actually. I went to Holland and sampled a very large family pedigree on both sides. In the back, it's me. You can see I was much younger. And here is Professor Lynn Laurie, with whom we did that work at the time at NIH. Now, let's see what are the clinical manifestations of glucocorticoid resistance. Okay, number one, apparently normal glucocorticoid function in most cases. So most patients are asymptomatic. Also, however, we can also see chronic fatigue, perhaps as glucocorticoid deficiency of the muscles and the CNS. And in children, hypoglycemia. Now, we have mineralocorticoid excess, with the most severe being hypertension and hypokalemic alkalosis, like the propositus of the family I showed you before, the father, and also androgen excess. And androgen excess presents as ambiguous genitalia at birth, clitoromegaly, premature adrenarche, and gonadotropin independent precocious puberty. Why is that? All of this is a product of excessive androgen production by the adrenal zona, either the fetal zone or the adrenal zona reticularis. In women, we have acne, hirsutism, male pattern hair loss, menstrual irregularities, organ ovulation, and hypofertility. They very much look like what we call polycystic ovary syndrome. In other words, a physician would see such a patient, let's say a young woman who is hypofertile, the first thing they will think, because of the symptomatology, is polycystic ovary syndrome. Now, in males, early in life, we can get acne and hirsutism. However, we also have oligospermia, presence of adrenal rest in the testes, and hypofertility. Of course, this is a problem that can be overcome by selecting spermatozoa and inject it into an ovule. However, it's good to know because it's possible that the patient presents a young man, 30 years old, with pain in the testicles. They go to a urologist. The urologist says it's seminoma, and they remove the testes. No, it's not seminoma. It's a very benign condition, not a tumor. It's adrenal rest, which can go away by treatment with dexamethasone for a couple of months. Now, how do we make the diagnosis of glucocorticoid resistance? First of all, clearly they don't have clinical features of Cushing syndrome. Despite the high cortisols, they have no Cushing's. Second, they have normal or elevated ACTH. Normal because there is a resetting of the axis, right? The adrenals become bigger, so they need less ACTH for the stimulation of cortisol production. They have elevated cortisol concentrations anywhere you look. You have increased 24-hour urinary free cortisol excretion all the way from twice normal to 13, 40 times normal. They have normal circadian and stress-induced pattern of cortisol and ACTH. So if you measure morning and evening, you're going to find a circadian rhythm. However, in the evening, it's going to be lower than in the morning. You have a resistance of the AHP axis to dexamethasone. So in that sense, they behave like Cushing's disease. In other words, with a low dose, the 2 milligram a day, they don't suppress. With a high dose of 8 milligrams a day, they usually suppress. Now, tests that we do in vitro, one is thymidine incorporation to show that white cells from the patient have increased resistance to dexamethasone. The whole dose response curve is shifted. And second, we can have dexamethasone binding assays where we find either decreased concentration or decreased affinity. That's how we started this work with binding studies. And finally, you can sequence the receptor and find out what the defect is. Here are the defects, molecular defects in the genome of patients with familial or sporadic glucocorticoid resistance. They can be anywhere, as you can see. Usually they are in the ligand binding domain on this side, but they can also be in the DNA binding domain, and they can be in the immunogenic domain, especially close to the sites that are important for transactivation. These are sites that bind to the so-called coactivators of the glucocorticoid receptor, and which then together influence gene activity. Now, we have this kind of mutants as I said, everywhere. We've studied them, and they all compromise glucocorticoid function. And here you see an example of dose response curves. Okay, here is no receptor. Here's a normal receptor alpha. And these are receptors now that have defects on the molecules. And all of these receptors have compromised activity and number. And what you see here is the dose response curve to dexamethasone. Now, in addition to glucocorticoid resistance, we have the reverse syndrome, glucocorticoid hypersensitivity. What do we expect to find there? We expect to find glucocorticoid function, excessive function, with Cushing syndrome manifestations such as obesity, metabolic syndrome, etc., but decreased or low normal HP axis activity. And we looked for many years for something like that. And eventually, a woman from Latin America came to the NIH, and we examined her. She was this type. She looked like having Cushing's, but with low normal HP axis activity. We sequenced her receptor, and you can see here this mutation, okay? This mutation is here in the so-called aminoterminal domain, and it affects the transaccelerational activity of the receptor, and the end result is to have increased activity. Therefore, there is this syndrome. Most people don't look for it, but once in a while, you'll have it in your practice, like you're gonna have glucocorticoid resistance. And here are the studies that we did on this patient. Here's the normal, right? Excuse me, here's the normal. And here's a patient with the activating mutation, right? You can see that there's more of an effect in response to the same doses of dexamethasone. Now I'm going to show you another interesting case. There have been around 6 around the world. It's a form of acquired Cushing's syndrome, and it's transient. It lasts months. Usually you have a normal child or adult, doesn't matter, who develops clearly Cushingnoid features, like this little girl. You can see here, buffalo hump, everything fits Cushing's. We measure cortisol. Cortisol is very low. We look at the receptor. The glucocorticoid receptor is normal. So the question is, what's going on? So the thing we did is we did total transcriptomics of in the white cells of this little girl, and we found something strange, but it makes sense now. We found that the majority of the genes that were affected, which were either upregulated or downregulated, had something to do with viral infections, including effects on NF-kappa B target genes. We didn't find the defect. This little girl, in about 4 or 5 months from the onset, started losing weight and going back to normal. The Cushing was gone. And most likely, we believe that there is a virus which can influence the sensitivity of our tissues to cortisol. And I'm going to show you at the end of this little lecture something that we found with the HIV-1 infection. So there are many molecular modulators of the stress response, and something we need to test is FKBP5. The reason we need to test it is because it's known to influence the activity of the glucocorticoid receptor. It's a part of a feedback system, very important part. And we believe that the virus, if they don't change the interactions of the receptor with other molecules, they may change interactions with FK-kappa-B. And we did it in this child. There was no problem, but I think it's a good candidate. And then we looked at the literature, and apparently there are polymorphisms on this NF-kappa B, which are associated with either excessive or normal cortisol response to CRH or to stress. So this particular molecule is involved. We don't know yet how, but it is involved. Now, the other thing you need to know is that when we're thinking of glucocorticoid resistance or hypersensitivity, we're thinking of the human as a whole, but it's not true. Every cell is different, every tissue is different. So we believe that it's possible that somebody has glucocorticoid hypersensitivity at the level of the feedback up in the HV axis, but not in the periphery, or the opposite. You have a resistance at the level of the axis, but not in the periphery. In both cases, you can produce pathology, significant pathology. Based on this very early slide that you see here, people looked by doing knock-ins and knockouts of glucocorticoid receptor in mice. And indeed, you can basically produce all kinds of symptoms and signs in a mouse by just altering the glucocorticoid receptor in one or more tissues. Now, because we were interested in the glucocorticoid receptor, we decided to cut it into fragments and to look at the binding of these fragments to possible molecules in the cell. And here we found about 120 molecules that bind to the glucocorticoid receptor. But here are some of them. And I'm going to show you some that are, we believe, important for the lecture today. One is the clock. Glucocorticoid receptor interacts with the clock transcription factor. And second, with this long non-coding RNA, which is called Gas5. And third, with the protein of the HIV virus, which is called VPR. Okay? So the receptor has multiple functions, multiple interactions, and therefore can influence many, many effects in the human body. And this is a summary of what we found. The signaling system of the receptor interacts with genes for growth factors or small G protein system, TNF-alpha and FAS, circadian rhythm, energy nutrient stress system like AMP kinase, viral systems, not only HIV-1, but also the adenovirus, and G protein coupled receptors, especially the trimeric G protein system. So the complexity increases a lot. One of the things I want to tell you, which is important for my next lecture, is interaction with the clock transcription factor. As you know, we have a circadian clock, which is important for coordinating our activities day and night. Day, we do some stuff, we work. Night, we relax and we sleep. There is a clock in every cell that we have in our body. But there is one clock particularly, which is in the suprahypothalamic nucleus, which coordinates all the other clocks. So basically, it's the brain that gives the order of how the clock works day and night. Now, about 10% of the mammalian transcriptome oscillates with the circadian rhythm, and the clock system controls genes, downstream output genes are involved. So, another complexity. We wanted to see whether there is any similarity between the actions of the clock and the actions of the glucocorticoid receptor. And the answer is yes. I don't have time to explain, but here is the interaction of the clock. That's how it works. The various genes, there is a molecular clock, transcriptional clock that goes around 24 hours. On the right, you see the system, the circadian system. Here you see the clock as it in the cell. Here's the auxiliary loop. And finally, the coordination with other systems. So one of the first studies we did was to show that the transcription factor clock BMAL1 regulated the transcriptional activity of the glucocorticoid receptor. And it did that through acetylation. Why? Because it seems that the clock is a histone acetyltransferase like the coactivators of the glucocorticoid receptor. There is a homology there. And that means that during the day, during the night, the receptor is not acetylated and it's very active, whereas during the day, the receptor is acetylated by the clock and it's inactive. So, and actually the acetylations occur right here at the hinge region right next to the DNA binding domain. And therefore, we not only have a circadian rhythm of cortisol that we all know very well, we also have a circadian rhythm of sensitivity to cortisol in our tissues everywhere. And here is the normal cortisol rhythm that you see here, high in the morning, low in the evening. Here you see the response, the cortisol rhythm of somebody who is chronically stressed. There is a flattening with increased levels in the evening. We did all of this in human studies to make sure that what we found in vitro was true in vivo. True, during the day, the receptor is acetylated. During the night, is less acetylated. It worked out all the genes that are responsible, both the transactivating genes and the transrepressor genes. And eventually, we ended up, let me show you, with this thought and then these results. We realized that all animal models and rare human patients who have loss of circadian rhythm have manifestations of glucocorticoid excess. And eventually the result is this phenomenon is due to the fact that once you flatten the rhythm, you're going to have increased glucocorticoid actions in the evening hours and night hours, and the end result will be to become cusinoid and obese. Now, glucocorticoids reset the slave clocks, which are in the periphery of the body, but not the master clock. Why? Because the suprachiasmatic nucleus has no glucocorticoid receptors. That's the only part of the human body that has no glucocorticoid receptors. Therefore, whenever we have perturbation of either the clock system or the HP axis, the results are similar. We get obesity, metabolic syndrome, immune dysfunction, as if due to hyperactive cell system, with suppression of the inflammatory reaction and a shift from Th1 to Th2. What are these states? Chronic stress with evening cortisol elevations, endogenous or exogenous Cushing syndrome, my next lecture, trans-time zone travel, and night shift work. All of these result in obesity, metabolic syndrome, and these kind of problems. So here's cortisol, here is GR acetylation, here is sensitivity of tissues to cortisol, here is stress, and here is shift. Okay, all of this, you end up with glucocorticoid function, glucocorticoid hypersensitivity, and problems of accelerated aging. Let me just say a few words about the growth arrest specific 5, Gas5 non-coding RNA, just to show you the importance of such molecules in regulating metabolism. This Gas5 is about 600 bases long RNA. It is not expressed into protein, and it has 2 GREs. You see here, you have this GRE and that GRE. And we found that this GRE is active. In other words, it binds glucocorticoid receptor. And not only it's active, it prevents the activity of the glucocorticoid receptor. That's what you see here. This is normal, right? No, I'm sorry, this is binding. So Gas5 is binding better than the DNA binding domain, than the GRE, to the glucocorticoid receptor. It's a very strong binding factor of the glucocorticoid receptor. And what it does is by keeping it outside the nucleus, it prevents a glucocorticoid activity. When do these kind of molecules go up? They go up when the cell is starved. So starvation leads to overproduction of GAS5, and the end result is glucocorticoid resistance. That's the one that's active. Okay, that's how it binds the glucocorticoid receptor. And the end result is to protect the cells from the catabolic actions of cortisol. Just a few words. Glucocorticoids are pervasive. They influence more than 20% of the glucocorticoid of the genome. 20% of the genome. 1 in 5 genes is affected either positively or negatively by glucocorticoids. And here I show you what happens in immune functions and how they're affected by glucocorticoids. Yellow is negative, red is positive. So you can see the complexity of functions. And finally, I'll finish with the expanding clinical implications. I'll tell you that in addition to the glucocorticoid resistance syndrome that I described, we also have glucocorticoid resistance in bronchial asthma, in rheumatoid arthritis, systemic lupus erythematosus, and ulcerative colitis, in acute respiratory distress syndrome and sepsis, like COVID-19 disease now, serious disease, depression, hypersensitivity. We have generalized glucocorticoid hypersensitivity syndrome, what I showed you, transient glucocorticoid hypersensitivity syndrome, visceral type obesity related dyslipidemia, insulin resistance, carbohydrate intolerance, hypertension, and age-related insulin resistance lipodystrophy syndrome. If you look at the normal population, you'll find the ones that have polymorphisms that cause the resistance live longer and they're leaner, whereas the ones that have polymorphisms that increase the resistance, the hypersensitive, they have more metabolic syndrome and insulin resistance rather than insulin sensitivity. The immune system interactions are extremely important. Glucocorticoids are key in blocking the actions of NF-kappa B. Let me go far. This is a study we did with the respiratory distress syndrome. Glucocorticoids do bind to the glucocorticoid receptor if you give them at moderate amounts and decrease the production of TNF-alpha, IL-1 beta, and IL-6, and also decrease the amount of glucocorticoid receptor in the nucleus. And here are the results with the AIDS virus. The AIDS expresses the AIDS virus 2 proteins, VPR and TAT, which you see here. And both of these together increase sensitivity of tissues to glucocorticoid. That's part of the immune dysfunction that these patients have early in their life. And here's an example of a patient with HIV lipodystrophy dependent syndrome. And you can clearly see that he has some features of glucocorticoid syndrome, and that's due to the hypersensitivity because of the glucocorticoid receptor. So allow me to stop here because I think I took too much of your time. Thank you very much.
Thank you. Do I take the questions now, or would be taking at the end of the panel discussion? I think that would be more appropriate.
Whatever you think, we can do it later.
Yeah, right. So I think now I request Dr. Mala Dharmalingam to conduct the rest part of the session.
Thank you, Professor Crosos, for that excellent lecture, and taking us through the receptor and the clinical implications of the changes that happen. And next we have a very interesting and again a very important topic, which is the precocious puberty. And to talk about this, we have none other than Dr. Peter Lee. And to introduce Dr. Peter Lee, he is the professor of pediatric endocrinology and he's a consultant at Penn State Milton S. Hershey Hospital, Medical Center, and Lehigh Valley Hospital in Philadelphia. He's past president Lawson Wilkins Pediatric Endocrine Society up till 1999. And he's author of multiple international guidelines on puberty and DSD. He's author of textbook chapters on puberty and DSD and has about 317 publications to his credit. So over to Professor Peter Lee to take us through another important topic of precocious puberty.
Thank you. Are you going to download my PowerPoint, or can you talk me through downloading it?
Dr. Prem, what would be the best thing?
Yeah, actually we can, Dr. Sona, can you just upload this? Dr. Sona?
And then you get me control to advance the
Yeah,
slides?
sure. Just a minute, sir.
Dr. Prem, I don't have his presentation.
Doctor, could you try it from your end?
Yes.
Development, and you see in the title we've emphasized individualizing the characteristics of patients even within those categories, and with an attempt to take what's called here a holistic approach, considering the emotional and social aspects of each individual and their families, and when necessary, the spiritual, religious aspects. Can we move then? Next slide. Go on to the next one, which is an outline of what we'll talk about, talking about normal puberty, various aspects, and then precocious puberty and the variants thereof, with emphasizing toward the latter part of the talk, central precocious puberty. But in the meantime, attempt to give an overview of various forms of early pubertal development. And so the next slide shows us a schematic of, keep going, I'm sorry, one more. Keep going, I thought those were taken out of there. So puberty is a multifaceted process which involves development of secondary sexual characteristics, accelerated growth rate, and that varies depending upon when pubertal onset is, as you can see by the graph in the upper right portion of the slide. There's behavioral aspects which are related to maturation of the central nervous system that occurs during the years of puberty. And puberty is progressive, both a normal puberty or central precocious puberty. And in the bottom portion of the slide, you can see that this process involves release of GnRH, or the old term LHRH, from the hypothalamus in an episodic fashion, and the obligatory episodic release of LH and FSH from the pituitary, stimulating gonadal function. This obligatory episodic release of LH and FSH by the pituitary is the basis for the ability to shut down this system with GnRH analogs by having high levels of GnRH, and we'll come back to that. Next slide. And so puberty can happen whenever a child is exposed to sex steroids. And as we've already implied, this may be because of increase of GnRH at the level of the hypothalamus. It may be at the level of the pituitary, although that is uncommon unless there's known process that's destroyed or is destroying the pituitary. The response to gonadotrophins, whether they're pituitary gonadotrophins or gonadotrophins ectopically from tumors, is to stimulate the ovaries and the testes, which stimulate responsive tissue. Even sex steroids, either from tumors or other sources, including exogenous, can cause pubertal change, such as the pubic hair and breast development you see in this photo. Next slide, please. And so again, the axis results from the activation of this axis, and this is the same process that happens with the onset of central precocious puberty, which is a matter of timing. Next slide. And so with the onset of puberty, there is the episodic release, as you can see here in the lower right-hand side of the figure, more dramatic for LH than FSH. And in fact, assessing LH secretion is more important in assessing pubertal development than FSH, with, of course, some exceptions. Next slide addresses the fact that it isn't clear what triggers the onset of puberty, but again, it's from the central nervous system, involves the neurotransmitters from the brain, resulting in this episodic release involving kisspeptin, etc. And so the next slide shows you, for informational purposes, the variety of gene activation that are involved in the onset of puberty. This is not complete. And on the next slide, you can see there are also monogenic causes of puberty rather than a relative imbalance, if you will, in which there's a gain of function of mutations involving kisspeptin, or loss of function mutations in the MKRN3 gene, or the DLK1 gene also is involved in these rare causes of central precocious puberty. More commonly, next slide, are the risk factors involved in central precocious puberty. Because if there has been an insult to the central nervous system, either acquired or as a result of congenital malformations, there's an increase in the risk of developing central precocious puberty. Of course, there are some syndromes that are also associated with central precocious puberty. There's the adoption phenomena, when there's suddenly emotional and physical support that leads to central precocious puberty. Overall, a family history of central precocious puberty in an individual that presents with that complaint is relatively rare, as you see. I need to talk briefly, next slide, about the age of onset of puberty in females. The first physical evidence of puberty in females is breast development. And to ascertain that that truly is breast development, there needs to be palpation as well as inspection, because it's estradiol that stimulates the pubertal growth spurt at the onset of puberty. Although it's usually not documented, females are already in an accelerated linear growth rate. The other aspect that we need to talk about that receives a lot of attention, at least here in the United States, is that there's racial ethnic differences in the age of onset of puberty. And so if you could see the lower range on the left for the data that are available that I'm aware of in the United States, the white and Asian population, the lower limit is right around 8 years of age, although it's significantly lower than that in the Black population and the Hispanic population. And the next slide points this out a little more. So onset of breast development you see in a Black girl that's 7.5 may indeed not represent a central precocious puberty. You can see there's differences in the early onset of the menarche, but not as dramatic as that. Another, bring up the, click again and bring up the other slide of this slide, which basically says what we have just said. Another issue, which is a big issue in the United States and some parts of the world, I'm not sure how much in India, is shown on the next slide, in which there is a documented earlier onset or presence of breast development. And this has been documented several decades ago. And this continues to be true. And so if you look at the age 8 cutoff, for example, the development of breast development during age 8 and the Caucasian graph, you see that more than 10% have breast development, but more concerning is that 5% have breast development during between 7 and 8 years of age. I would submit that this does not mean that puberty is occurring earlier, because none of these studies, as you see in yellow at the bottom of the slide, have had documentation of increase in gonadotrophin levels, nor indeed documentation of the progression of this breast development. And so this early non-progressive breast development that we see so common in the United States does not mean central precocious puberty. It may be related to increased body mass. It may be related to other estrogenic type substances, but it doesn't necessarily mean earlier puberty. And another factor is shown on the next slide, which I would say speaks against earlier onset of puberty, because from these same data, the age of menarche is the same. And so I cannot perceive a biological phenomena that's accelerated in starting, but prolonged in progression. And so this is a whole basis, I would say, for making the case that the cutoff for precocious puberty should not be lowered, and patients present, for example, a Caucasian girl presenting at 7.5 years of age with precocious puberty, one should consider whether or not to treat that individual. A little bit more in normal, and the next slide shows the progression of pubertal development. for boys and girls based on, and we'll later show you, remind you of the Tanner stages. But you can see that regardless of when puberty begins, puberty progresses very much in a predictable sequence. And notice that the maximum growth rate in males occurs later during puberty. And we'll come back to that with a growth chart as well. There is also included on this slide the samples of testicular volumes to emphasize the fact that the onset of puberty, as you can see in the upper right, testis growth is the first evidence of puberty, and obviously that is not going to be recognized unless there's a physical exam. So coming back to the physical exam and breast development on the next slide, there is what in the United States is sometimes referred to as a donut sign, because if a female looks as if she has pubertal development and one palpates directly over the nipple and the areola, and there's a hole there, or the tissue's less dense there than the periphery around it, that suggests that what you're seeing is adipose tissue, not breast tissue, and that this indeed is not breast development, because one should palpate a firmer disc located under the nipple and the areola if there's really breast development. So emphasizing the role of the physical exam, both in terms of breast development in girls and testicular volume in males. Of course, in relation to testicular volume, one can learn a great deal about whether the testes are prepubertal size or pubertal size. That suggests those states. If one testis is larger than the other, it suggests perhaps a history of the insult on one side, or rarely a Leydig cell tumor on the other side. And remember, evidence of puberty, particularly precocious puberty, is shown by increased growth rate. Listed here are also androgen-stimulated changes and estrogen-stimulated changes. The androgen-stimulated changes, some of those, as you know, occur in females as well as males. And if they're androgen-stimulated changes only, they do not indicate precocious puberty in terms of gonadal ovarian function. And the next slide comes back and emphasizes the time of the growth spurt being earlier on average in females and males. And also keep going, click more. I thought I'd taken these gradual out to help enhance moving through this, but here we are. So it's worth pointing out that with puberty, there's an accelerated growth spurt, and above the growth rate during childhood of 5 to 6 centimeters a year. It's also worth mentioning height predictions that are used sometimes too specifically, because the height predictions based on bone age in the typical Grulich Pyle atlas are based on a normal growth and based on what percentage of growth is complete for an individual that has a bone age either within a year or advanced more than a year or a year less. And so those height predictions are not accurate for individuals with precocious puberty, because think about it, an individual that has a bone age that's advanced a year and a half will have the same high prediction as an individual that has a bone age that's advanced 5 years, and that doesn't make sense. Coming back to the androgen component on the next slide. There is the fact in the lower font that the adrenal glands produce increased androgens. At the time of the onset of puberty, actually hormonally well before the onset of puberty. And even though these are weak androgens, they do stimulate changes, as you can see, like sexual hair acne and body odor. These are gonadotrophin independent changes. There is some evidence that these may be the first evidence of metabolic syndrome or hyperandrogenism. But the key point in relation to assessing puberty is if you only have sexual hair and not breast development, that does not mean that there's gonadarchy or the ovaries have begun to function in a pubertal fashion. Okay, with that as the background, let's look at categories quickly of central precocious puberty. Next slide. There's the category of premature thelarchy, in which indeed there's breast development, but it does not progress as with puberty. The phenomena I just talked about is premature adrenarche leading to premature pubarche. And if the early sexual hair is a consequence of adrenal androgens, that is a benign process, although it needs to be followed to make sure that it's not more than that. And so the major categories of precocious puberty, and we're talking about progressive puberty whose names have changed over time, and listed here, the current terminology commonly used is peripheral precocious puberty for those entities that are distinct from central precocious puberty, which is puberty driven by the central nervous system. I'll just talk briefly about peripheral precocious puberty. On the next slide, you can see that this is resulting from any hormone excess not as part of the hypothalamic pituitary gonadal axis. These are rare. There are gonadotrophin secreting tumors. There are sex steroids secreting tumors, and there are genetic mutations. I guess the most well-known is the McCune-Albright syndrome, which is a post-zygotic mutation. There's some examples of males on the next slide with central precocious puberty, and obviously this is different from central precocious puberty. Example A, there was unilateral testicular involvement with dramatic genital growth in this boy who was 7 years of age at the time. There is the LH receptor activating mutation, example B, with male-limited gonadotrophin puberty. You can see that this boy has a testicular enlargement, which may lead to confusion with the diagnosis of central precocious puberty. And then there is the congenital adrenal hyperplasia, where initially anyway, the androgen is coming from the adrenal glands, and so the sexual hair and phallic size is disproportionately large, and the testes are small, indicating that this is not a central precocious puberty. Okay. Let's move on then to the criteria for the diagnosis of central precocious puberty. We've already talked about the early age of onset. We've talked about the accelerated growth rate, alluded to bone age, and because of the increased androgens, bone age disproportionately advances, and if robust and result in an adult height shorter than it would be otherwise. To diagnose central precocious puberty, it's important to document LH. Remember, we emphasized the fact that LH is more important. This often can be done using third generation assays without a GnRH stimulation test, however. The cutoffs indicating puberty need to depend on the assay that one is talking about. Next slide. We talked about the age of onset. The precocious puberty is much more common among females than males. And the other difference is among the females, there is not a demonstrable underlying pathology nearly as often as in males. Precocious puberty can develop secondary to chronic sex steroid exposure, which happens in individuals with adrenal hyperplasia if they're not well suppressed. There are rarely reversible lesions that have been demonstrated when there's a CNS abscess or increased intracranial pressure where puberty has regressed. We talked about monogenic mutation and CNS abnormalities. Next slide. These are the general cutoff criteria but they need to be qualified based on the racial ethnic group one is talking about. History and physical examination, next slide. Of course, there is the importance of documenting the growth rate and if precocious puberty has occurred and has not been treated, one would expect crossing of percentiles when one plots growth rate. Physical findings, we've already talked about these, so we can move. Next slide. The Tanner stage, remember the importance of palpation. If one can just visualize the vaginal mucosa without putting any object between the labia, if the mucosa is estrogenized, it should be pink. We talked about testicular growth as documenting precocious puberty, so testes that are more than 2.5 centimeters in the long axis, and one has to measure carefully, or a volume greater than 4 cc's suggests that puberty has happened. And so, clinical presentation, next. Early onset and progression, increased growth rate, and advanced skeletal age. Next slide. I think we can go ahead. We've mentioned this. We can come back if you have any questions. LH levels, again, based on whatever assay one's using. One needs particularly to be careful to use sensitive estradiol and testosterone assays to differentiate between prepubertal and pubertal. We have talked about the need for a bone age X-ray. If there's any question about the central nervous system, one needs to consider doing an MRI. This is certainly indicated in males and females. Let's go ahead to the next slide. Talks about MRI. and to determine whether there are lesions in the central nervous system. And as I was alluding to, it's most unlikely to have a finding on MRI that would make a difference in treatment for females that are older than 6, but that's a controversy as to whether all patients should have it. Next slide is the pelvic ultrasound, and one can gain information from the pelvic ultrasound similar to what one can gain by a testicular examination, because if the ovaries are consistent symmetrically, reasonably symmetrically increased in size, that is consistent with precocious puberty. If they can be seen and demonstrated to be prepubertal in size, that is not consistent with precocious puberty. On the other hand, the size of the uterus is evidence of estrogen stimulation, and so one that is not necessarily indicative of central precocious puberty, because one needs to keep in mind that there are other sources of estrogen. And so next, the consequences of central precocious puberty we've alluded to. The untimely maturation, a disconnect between physical maturity and psychological sexual maturity, the difficulty in communication with others, whether they're adults or peers, and the issue of being tall during childhood and compromised height as adults. And you see in yellow below, it's important to counsel the patient and the parents to understand all of these phenomena. And if the patient has idiopathic central precocious puberty, I think it's even worth emphasizing the fact that they do not have a disease. They have kind of a timing defect, and they shouldn't consider themselves to be abnormal. So a couple more points about assessment. Next slide. One needs to verify the rapidity of progression, consider the age of onset. Again, a disclaimer about pubic hair. And then if it's decided appropriate to turn off puberty for a period of time, this can be done, as you can see on the next slide, with GnRH analogs. You've seen this figure before from the next slide, without the down regulation that occurs when one floods the system with GnRH, and that's what the analogs do. It's not metabolized rapidly as normal GnRH is. So whether or not to treat, next slide. One should discuss this with parents and the patient as much as he or she can interact, and how much their development is impacting their relationship to their age peers, what their growth potential is, and of course, considering the underlying pathology. A child's understanding of the situation should be discussed, and if treated or whether to treat, one should address issues of readiness for puberty. Next slide, we have not mentioned target height. In the States anyway, target height and predicted height are used a great deal. And the important point in that is the target height being supposedly the genetic expected adult height based on heights of parents. But it's obvious that all male children from a certain set of parents will not be the same height. And so one needs to consider the very broad range of target height when determining whether or not to treat or the efficacy of treatment. And even more so, and I mentioned this earlier, the predicted adult height is designed for individuals that have bone ages that are within 2 standard deviations. And so that also must be used with caution. So in summary, next slide, categories of precocious puberty. We talked about central precocious puberty, peripheral, the partial forms, premature adrenarche. And next slide. Onset is designated by increase in testicular volume and breast stage with progression. There's no single marker of progression, and so one needs to obtain information over a period of time. If retrospectively that's available, that's good. There are racial differences that need to be kept into mind. And GnRH analog treatment has been used now for 3 decades and is efficacious and considered very safe. And so the next slide, which I think is the last slide, considering the holistic components, we talked about physical, we need to always keep in mind the emotional and social, if needed, the spiritual position of the parents, and underlying it all, need to educate and fully inform parents. So thank you very much. I'm glad to discuss anything that anyone is interested in.
Thank you, Professor Lee, for the very nice review. And now we are open for the panel discussion. So I request the 2 panelists, Dr. Nalini Shah and Dr. Parag Shah, to please join us.
Madam, we have one more session.
We have another session,
yes.
yeah.
Yes,
yeah.
ma'am. After that, we'll have the panel discussion, ma'am.
I think we have Cushing syndrome again, by another very difficult area for the endocrinologists, diagnosing, localizing, and at times treating glucocorticoid excess. To take us through, we have again Dr. George Croesus to take us through Cushing syndrome.
Professor George Croesus. Can you start sharing the slides? Professor George? I think you have to unmute.
Yeah, I think you have to unmute yourself.
No. Thank you.
Can you see my lecture yet?
Not yet.
Okay.
Yeah, it's coming.
Yeah.
Yeah.
Great. So my second lecture is on Cushing syndrome and as it contrasts with generally hypercortisolism. A few things about history. This is the first time that the adrenals are mentioned in a book, and that's from 1563, the volume by Eustachio, who first described the adrenal glands. Before that, they were not known. And here is Harvey Cushing. a neurosurgeon who made major contributions to pituitary science. And here is the book by Harvey Cushing, Pituitary Body and Its Disorders. And here is the first patient with Cushing's disease ever reported. As you can see, she has the moon phases, full supraclavicular foci, and in fact, she's quite short. She started having the syndrome at about the age of 12 or 14, and she was diagnosed much later. And you can see her here. Very, very typical Cushing's disease. So other milestones in this area are the description of the adrenals and of them being essential for life by Brown-Séquard. Kendall Reichstein-Hens, who discovered cortisone and showed that it has anti-inflammatory uses, and the Nobel Prize for cortisone in 1952, the three scientists, and they're all here. A few words again about glucocorticoids. Cushing's is nothing else but glucocorticoid excess. And here you see the cortisol, a lipid, crossing into the cell, binding to the glucocorticoid receptor, then the receptor enters through the nucleus, through the nuclear membrane, the so-called nuclear pores, and acting either as a dimer on GREs, glucocorticoid response elements in the genome, or to influence the activity of other transcription factors by binding to them and either not allowing them to bind to their response elements or neutralize them even if they bound to the response elements. Three domains of the glucocorticoid receptor, the immunogenic, the DNA binding, and the ligand binding domain, and the other underfunctions. I think I've said all this. Now, Cushing syndrome is common because it's iatrogenic, okay? So exogenous Cushing syndrome, we have millions. Endogenous Cushing syndrome is rare. And the best number we have is 1 to 5 cases per million population per year, with about 10% of them being at the pediatric age range. All right. And here is the list of Cushing syndrome. 85% of the cases are ACTH dependent. 15% of the cases are ACTH independent. Here we have pituitary disease, ectopic ACTH, and ectopic CRH. So the majority of patients have pituitary Cushing's disease. Adrenal independent, we have adrenal adenomas, carcinomas, macronodular adrenal disease, or PPNAD, or carnate complex, which is rare. Massive macronodular adrenal disease with promiscuous receptors, also rare. Adrenocortical hyperplasia and adenomas, rare. And transitional states, which is somebody who's Cushing's disease. It's left untreated. The adrenals develop nodules that are semi-autonomous. We remove the tumor of the pituitary, and the patient is not cured for about 2 or 3 months, and then all of a sudden they have adrenal insufficiency and they go to the emergency room. So these are semi-autonomous secondary cortisol secreting nodules of the adrenal cortex in response to chronic ACTH hyperstimulation. Here you see the 3 layers of the adrenal gland. Outside is the zona glomerulosa, secretes aldosterone. In the middle, zona fasciculata, it secretes cortisol. And inside, close to the adrenal medulla, is the zona radicularis that secretes androgens. So what are the clinical changes we expect in Cushing syndrome? Well, we have changes that refer to excess glucocorticoids, excess mineralocorticoids, and excess adrenal androgens. So in Cushing's, we can have all 3 of these manifestations. Let's go to excess glucocorticoids. As I said before, cortisol is a product of the stress system, a very important end product. The stress system is activated whenever we have stress. CRH, AVP on one side, locus coeruleus norepinephrine on the other. Here are the multiple negative feedback effects on the HPA axis. Here is the HPA axis as we know it today. We know that the amygdala also secretes CRH. So whenever we're anxious, fearful, or angry, amygdala CRH will activate the stress system. And vice versa, the stress system activates the amygdala, important in Cushing's syndrome. And then in the periphery, we have cortisol, norepinephrine, epinephrine, IL-6 because of stimulation of IL-6 secretion by Kupffer cells in the liver by norepinephrine and epinephrine. And also because of the high cortisol, we have decreases in the growth hormone IGF axis, reproductive axis, and thyroid axis. What you see here is it's a cut of a rat brain. These are the two ventricular nuclei that secrete CRH and AVP. If you give corticosterone to the rat, you can see the expression of CRH messages almost gone completely. In contrary, here is CRH secretion by the amygdala. If you give corticosterone to the rat, you have more of CRH secretion there. So you can see there's a different effect. Inhibitory in the hypothalamus, stimulatory in the amygdala. That's important because, and here you see a closer view. Here is the PVN, suppression, amygdala, central nucleus stimulation. The reason I mention this is because one of the characteristics of Cushing's syndrome is anxiety. They get quite anxious. And I would say, how can they get anxious if CRH is low? Well, it seems that CRH is high, and that's why about 75 or 80% of patients with Cushing's disease have anxiety, and a little lower number that have depression. Now, the HPA axis, when activated, inhibits reproduction, inhibits growth, thyroid function, and immune function. It has both anti-inflammatory effects and Th1 to Th2 shift effects. So primarily you have suppression of the cellular immunity and less of the humoral immunity. Here are the growth rates of children with Cushing's syndrome. Here's the growth rate. The average is about -3 standard deviations from normal, which is 0. Here's weight, which is about 1.5 standard deviations above normal. Here's the height, which is about also 1.2 standard deviations below normal. And here's the BMI, which is 2.5 standard deviations, almost 3 standard deviations. So that's what Cushing's syndrome does to children. And don't expect always to have an obese child to show that they have Cushing's syndrome. More typical is the suppression of the growth rate of these children. And here's the blood pressure of these children. This is systolic blood pressure. You can see it's up. It's almost 2 standard deviations above normal. Here is diastolic, also up. And here is mean blood pressure. So of the blood pressures, systolic, diastolic, mean, again, don't expect complete hypertension in a patient with Cushing's. And here's a study we did to show how insulin secretion depends on cortisol secretion. So down here we have the cortisol elevations in UFC versus months of the disease, time. Okay, so the glucose AUC goes up in response to glucose. The insulin AUC goes down, so clearly cortisol has an inhibitory effect on insulin secretion. And there is a time effect also. It's not only the amount of cortisol that the patient secretes, but also for how long the patient has been exposed to hypercortisolism. And this is what happens when you have hypercortisolism, right? Through cortisol, you get gluconeogenesis, insulin hypersecretion, development of insulin resistance, collection of visceral fat, sarcopenia, metabolic syndrome, and diabetes mellitus type 2, excessive coagulation, excessive blood pressure, arterial blood pressure, dyslipidemia, right here, and arterial dysfunction, inflammation, atherosclerosis, and cardiovascular disease. So you also have sickness syndrome. People with Cushing's feel tired. If they have PCOS, it can get worse. They have sleep apnea, and they have osteopenia and osteoporosis. In other words, in Cushing's syndrome, you have the so-called glucocorticoid-induced metabolic syndrome. It's not different from what chronic stress does to humans. Unfortunately, the see here didn't come out very well in this slide, but what you see here is BMI, and here is IL-6. As you can see, the more obese you are, the more IL-6 you produce, and the more obese you are, the more TNF-alpha you produce. Now, here you see identical twins at the age of 8 years and at the age of 11 years. The children were seen by their pediatrician. Nothing was noticed, although one can see here a small difference. Twin A has a little rounder face and maybe a little shorter. Here you see her at the age of 11 years next to her sister. Again, if you do not have the comparison of the sister, you wouldn't have thought that this kid has Cushing's syndrome. But this is when we saw her. You can see they're clearly different now. She's tall, she's short, and you can see the whole shape of the face and the body are different. And if you do a DEXA scan, you'll find that this twin is 30 kilogram fat versus 10 kilogram in the twin B. 10 kilograms more weight, body weight, 58% body fat versus 20%. And you can see that there is increased fat everywhere, primarily in the trunk. That's because of the visceral fat that these patients collect. And here's the bone. You can clearly see that the bone density here is minus 3.6 standard deviations. And here is the twin B, the normal twin. So she's down here versus here. So you have somebody who suspects Cushing's syndrome, and you have two steps to follow. Number one, you establish a diagnosis. There is no point in going to differentiate if you don't have a diagnosis. Then, if you do have the diagnosis, you go to differentiate causes, and there are some tests where you can do both at once. All right, the 1 milligram single dose dexamethasone suppression test is a screening test. It's okay, it has a lot of false positives. So if you really suspect Cushing's, you have to proceed further to do tests that will lead you to the diagnosis. Which are those? Those are the 24-hour urinary free cortisol, the 24-hour urinary 17-hydroxysteroids, the midnight free cortisol, collection of hair over 3 months of hair cortisol. And it's very reliable, we found. Now, as you can see here, when I say diagnosis, you correct for meter square. And the same, and here for the hydroxysteroids, you correct per gram creatinine. Very important when you're dealing either with extremely obese people or children, growing children. You have to take the normal curve of urinary free cortisol, adult, and correct it per square meters. And then see what a child or the very obese person has after correction. That makes the diagnosis much better, more accurate. Same is true if you correct hydroxysteroids per gram creatinine. Now, differential diagnosis can be made by the CRH stimulation test. In Europe, we have human CRH test. In the United States, they have the ovine CRH test. Recently, they've tried to develop a vasopressin stimulation test. It doesn't offer any advantage. We have the standard Little test or the single dexamethasone dosage modification, which is the 8 milligram test. You can give it all at once. Then we have the metirapone test, radiology, which means CT and MRI, basically, bilateral inferior petrosal sinus sampling, iodocholesterol scan, if you want to see whether there is an adrenal remnant, for example, in the abdomen. The insulin tolerance test, which is not used nowadays, and the combined dexamethasone CRH test, which is quite useful. However, you can make the same diagnosis with midnight plasma-free cortisol or salivary cortisol, and certainly with hair cortisol. Now, things have changed over the years. When I started working with Cushing's, we really had the 17-hydroxysteroids to make our diagnosis. Now we have the urinary free cortisol. We used to measure cortisol only. Now you also can measure ACTH, PMC, CRH, plasma and hair cortisol. We had the dexamethasone suppression test, which is combined with CRH stimulation, TEC-CRH, BIPSS, etc. Here is the CRH molecule. This is the human and the ovine. The ovine is a little different, has longer half-life, 41 amino acids. If you give to patients with Cushing's disease in the evening a CRH test, they have a big ACTH response and a big cortisol response compared to controls, right? How good is that? Well, it's good in about 90% of the cases. There's a 10% that don't respond. In that case, then, it looks like they have ACTH stimulation test, and that's what you see here. CRH given to patients with ectopic ACTH, no response of ACTH, no response of cortisol. If you're sure that somebody has ectopic ACTH and is hypercortisolemic, they never respond to CRH. However, if the test is, if the disease is periodic or intermittent, and you test them during the low cortisol period, in that case, you can have a CRH response. And here is the case of a patient with adrenal cancer. When she was given CRH, with undetectable ACTH and no changes in cortisol. 3 days after taking metirapone, which blocked her, you can see that the ACTH response has come back and the cortisol response is there. So the pituitary returns very rapidly its responsiveness to CRH, and that one should keep in mind. The suppression that we see in Cushing's is not pituitary suppression, it's really hyperpituitary suppression, above suprapituitary. Here is the bilateral inferior dorsal sinus sampling test. We put a catheter in this sinus, another one on that sinus, and also we have a catheter in a central vein. And we measure CRH, ACTH, and beta endorphin on both sides, whichever we prefer. And if there is a gradient between the center and the periphery, okay, on either side, then that's disease, it's pituitary problem. The lateralization is only helpful in about 8 of the cases, not in all of them. You can have wrong lateralization, so we can note extremely seriously. Here you see PTH level, or I don't remember, I think it's beta endorphin, doesn't matter. 480 on one side, 63 on the other. In the periphery, that's 2 minutes after CRH, it was quite low, 24. So in this case, which is the first that we did, there was a gradient, so what disease. The surgeon went in, removed the left part of the pituitary, the patient was cured. This case here, we saw a patient who had an ectopic ACTH tumor in the adrenal medulla. So things were difficult. So what we did is we did the petrol sinus sampling and really found no gradient. So we say this cannot be pituitary, it must be from somewhere else. And eventually it was in the adrenal medulla. And we diagnosed it by catheterizing the adrenal veins. Here you see the differences between Cushing's disease, ectopic ACTH, and adrenal disease in ACTH response, either before or after in the petrol sinus, either before or after CRH secretion. So here's baseline levels. You can separate most of the, can distinguish most of the CRH. So there's some improvement by providing the CRH or vasopressin when you do petrol sinus sampling. An important overlap that we frequently had a problem was to distinguish between a patient with Cushing's syndrome and a patient with pseudo-Cushing syndrome, someone who was obese, probably alcoholic and so forth, depressed, who also had elevated levels of cortisol. And there is sometimes this overlap, and we need to make the diagnosis of this overlap. Now, if you look at patients with depression, who we know have hypertension, and you give them a CRH test, and then you measure plasma cortisol and plasma ACTH, make the comparison between the two, the correlation, you can see that this sigmoidal curve, which is normal people, is shifted to the left. That means that patients with chronic depression, like here, have hypersecretion of CRH, hypersecretion of ACTH, which makes the adrenal bigger, and hypersecretion of cortisol, which, because feedback is patient still can get some inhibition and some lowering of the levels of ACTH. Whereas in Cushing's disease, it's different. You have a pituitary adenoma, which secretes ACTH. This produces hyperplasia of the adrenals, hypertrophy. Cortisol is elevated. It doesn't act very well as a negative feedback on the adenoma, but it acts very well at the level of the hypothalamus. And in fact, looked at spinal fluid patients with Cushing's, and it's very low CRH. So these are, finally, we did the so-called DEX CRH test, and we were able to diagnose these conditions. After we performed this and looked at in parallel at the free plasma levels of cortisol at midnight, we could make the differential quite well by just one measurement. And here I'm going to show you another effort that we made to diagnose Cushing's versus pseudo-Cushing's with interleukin-6, human interleukin-6. So if you give it to somebody with Cushing's, give him IL-6, there is no response of ACTH and there is no response of cortisol. Fantastic test. If you give it to normal people, you have some effect on cortisol, on ACTH, some effect on cortisol. If you give it to people with depression, the result is excessive. You have a lot of H and a lot of cortisol being secreted. So it shows you again how different the pathology between Cushing's and depression is. Now, if you have depression or Cushing's, you have flattening of the curve. Sometimes in Cushing, you even have a reverse of the cortisol curve. So if this is a normal cortisol curve, This is the curve you see in chronic stress, depression, and frequently Cushing's disease. Now, we've moved a lot in understanding molecular problems that produce either Cushing's disease or adrenal Cushing's syndrome. For example, here we found that glucocorticoid resistance, specifically in the adenomas, can lead to increase in the size of these adenomas. Menin can be defective. This is the gene the protein that's produced by the gene that causes MEN1. USP8 is an important ubiquitin-related protein, which increases the activity of EGF, and that results in production of adenomas in the pituitary. Ectopic HTH, we're still not very far ahead molecularly. Now in adrenal Cushing's syndrome, which can be benign or malignant, we have defects in the menin, in GS-alpha and McKinnon-Bright, in phosphodiesterase 11A, or cyclic AMP in subunit A in the so-called carne complex. We have problems in these proteins, P18, 27, P3, etc. And also can have promiscuous receptors, like where we have the so-called food-induced Cushing syndrome, etc. In the so-called massive macronodular adrenal hyperplasia. It's rare, but it's very interesting, and it's usually due to expression of promiscuous receptors. Transmit information that shouldn't be transmitted to those cells, and those cells grow and become adenomatous. These are the situations during Cushing's disease, as I said before, and the various other syndromes in which you can have defects in the pituitary. I won't spend too much time on this. Now, the history of imaging evaluation started with X-rays, where you could make a diagnosis of 10%, to CAT scans, to MRIs. Here you see a pituitary, that you see it here, right? This is the stalk. These are the optic chiasm. Before gadolinium, and this is here, the tumor after gadolinium. You can see it clearly. It's a defect right here. This technology has advanced tremendously. Now you can make a diagnosis in probably 90% by just in MRI and special views. Here you see the case of somebody who has, you see here, a big adenoma. This is the adrenal on this side, adrenal on that side. This adenoma is a secondary adenoma. This patient ended up having Cushing's disease, and you have presentation of this, which could be a problem after the removal of the pituitary adenoma, because it could keep functioning perhaps a few weeks. Here you see another case. This is an adenoma that secretes cortisol, and you don't see the other adrenal at all suppressed. And what you see here is an endocrine cancer. Okay? Very typically, if you take the T2 vision, you can see more water. These tumors are full of water. You can see how it lights up. So this was a cancer, and that's how most cancers look. Remember that also you may have to make sure that you're not dealing with a field. Now let's look at the treatments for Cushing's syndrome. It seems that surgery is still the therapy of choice. So we use transsphenoidal resection in Cushing's disease. We use resection of primary and metastatic tumors in adrenal adenomas or carcinomas, as well as ectopic ACTH-producing tumors. Now, if for any reason fail to do this, there is always the solution bilateral adrenalectomy. In patients with Cushing's disease, if you do bilateral adrenalectomy, you cure them from their hypercortisolism. If you do it right, you cure it completely. The patient has to take cortisol and aldosterone, Florinef or Cortinef. However, if they have Cushing's disease, they develop Nelson, which is nothing else but overgrowth adenomas, which sometimes can produce problems because of space occupying properties. Now, press on the optic chiasm, they can press on the sinuses, and so forth. Now, what are the medical solutions? For a long time, the sedation, we don't do that anymore. Anyway, alone it doesn't work. You have to give it together with mitotain, an adrenoleutic. If you're not in a hurry, or if you cannot do anything else, you can always use inhibitors of steroidogenesis, such as methylaminoglutatamide, trilostane, and more recently ketoconazole. That's a good drug. Okay, it works. You to a child that's have a whole life ahead of them, but who is 80, you can normalize cortisol secretion. That's fine. The only one of these drugs that can be used intravenously, and of course it's been used primarily in very severe Cushing syndrome due to ectopic ACTH secretion, is etomidate. It acts very rapidly. Now, there have been cases where you use glucocorticoid receptor antagonists, such as RU486 or others, that do work, but you have a problem. And the problem is that you cannot follow cure by measuring cortisol. But cortisol is not going down if you use a cortisol antagonist, the glucocorticoid receptor. Recently, they've been using new somatic analogs, such as pyricereotide, which work on receptors 1, 2, 3, and 5. And in a small percentage of patients, ACTH secretion normalizes. If it's very high, then you won't see much of an effect. It usually works in mild Cushing's disease, and it's a way to gain time. Now, these are the imidazole, like ketoconazole, block several enzymes in the adrenal cortex, and they're used extensively either for a limited period of time or to prepare patients for surgery, or in patients that you cannot do surgery. Now, this is the twins that I showed you earlier. This is the patient, and this her face looks now. And this is the face of her sister. So they look much more similar. But look at the shape of their bodies and the height. This gives 17 centimeters of height compared to her sister. And of course, she never lost all fat in the abdomen. We did OGTTs and so forth. She's still resistant to insulin, even though she recovered her muscle mass and she has recovered her bone mass. That's because she was young. However, she has insulin, and she should. We examined the final height of children who had Cushing's disease as children, and average, these children lose about 7 centimeters. In this case here, it was 17 centimeters, it was a lot. And here is how they look at the age of 23. Now, when you do surgery on Cushing's disease, and then you measure the IL-6, you find what you would expect. IL-6 is suppressed because of the high cortisol, although not down to normal. Normal is down here. less than 1. So IL-6 is mildly elevated in Cushing's disease before treatment, and this day 4 or 5 after treatment, this at the time at an adrenal crisis. I don't know, we used to do that at the NIH. Days 4 and 5, we just followed them, and when feeling bad, then they gave them their replacement hydrocortisone. And on post-op day 9 and 10, IL-6 is normalized, not completely. It takes longer time because don't forget it's been secreted by fat as well. So it will be elevated until hopefully the patient becomes lean after 1.5 years. If you do a stimulation test, the first surgery, curative surgery, you see that ACTH is high and cortisol is low. So, excuse me, if you give ACTH is high, cortisol, then we tested these patients at 1, 3 months, 6 months, and so forth, until 12 months. What you notice, excuse me, is that the ACTH test, the brief ACTH test, single dose of 250 micrograms, normalizes completely cortisol. However, neither ACTH response to CRH, neither cortisol response to CRH normalize completely. So we go by this test. So if you want to see whether we can stop replacement, do an ACTH stimulation. If it's not, then stop replacement. This is if at these times, 10 days, 3 months, 12 months, you did a confusion of states, demonstrated that we were able to recover ACTH in response to continuous infusion of CRH very rapidly. It never went down. You can see here is high, high, high. So the problem is not the pituitary, as I said before, is the hypothalamus. The suppression takes 6 months, a year, and you need to follow the patients and find out that normalize. And here is a graphic. So how, if you don't give a patient who you stop glucocorticoids cortisol, wait long enough, you'll get ACTH comes back first, and then cortisol is coming back. It's an old study that cannot be repeated today, but it's very informative. So now what do we do with FAP? We follow the children, and we know that they have suppression at least for 6 months. A very typical thing in children is that they drop in school grades. Whereas they're good students, excellent students, grades drop, and they have a personality with executive dysfunction. We not cure them completely. We have to make sure that we give them appropriate psychological and other therapy so that they remain functional. Now, Cushing syndrome in adolescents and adults, we did follow them up. And again, adrenal suppression lasts from 6 to 12 months. What happens during the recovery, they develop atypical depression, they're fatigued, they're hyperalgesic, and they have panic attacks. So again, they're not fully normal the first 12 months. Again, I think it's important to have psychological follow-up and in young children educational follow-up in order to these patients normal. Now you tell me, why do these things happen? Well, it's because glucocorticoids are very powerful epigenetic agents. As I said before, 20% of our genome is affected by glucocorticoids. A certain percentage of that is affected epigenetically. In other words, there are changes that last for a long time. And the younger you are, the more of an you have. Okay, so you can see the effects of cortisol along the life. Plasticity and remodeling follows this pattern, and then stress exposure or Cushing syndrome or use glucocorticoids have effects that are cumulative and last a long time. Finally, in medicine and in research, we always have to follow dictum by Epictetus, who was a Stoic philosopher, very important one, a former slave, who suggested be equanimous and remember not to believe easily. Research means that we continue to follow our patients and keep examining them until we know that everything is all right. Thank you very much.
Thank you, Professor Crusos, for that once again an excellent lecture. And now we request all the panel members to please join. And Dr. Prem to take us questions.
Yes, first I would welcome the panel members. So we have our Professor Nalinisha Madam. Madam was an ex-HOD and Emeritus Professor at KEM Hospital, Mumbai. Madam needs no introduction to all of us. She's one of the most eminent endocrinologists from India. And next, we also have Dr. Parag Shah, sir, from Gujarat, Ahmedabad. Sir is also known to all of us. So welcome Nalini Madam and Parag Shah, sir, for the question and the panel discussion. So we have nearly 20-25 minutes for panel discussion. So I think for the panelist, any queries to the speaker, we can take it up first and followed by the questions from the audience. Is it?
Thank you, Prem. Let me start with a couple of questions to Dr. Crusos. So you have told, am I audible?
Yes, sir, clearly audible.
Yeah, you have told about hair cortisol. I think for cyclic, the entity of cyclic Cushing, hair cortisol should be the best modality, or what the sensitivity of hair cortisol vis-a-vis others when you are dealing with cyclic Cushing's.
Exactly, because it reminds you of what we do with hemoglobin A1C, as glucose is attached to it, and we can see over time how much glucose has been around. It's very similar with cortisol. For about 3 months, which means 3 centimeters of hair, you have accumulation of cortisol attaching the protein of hair. And then we cut the hair into 3 parts, and we know what happened a month before, 2 months before, 3 months before. How do we do it? We just extract the hair and use a regular sensitive assay to measure cortisol. We have found it very useful, especially for research, because you can see at various conditions, obesity, anxiety, depression, etc., what happens overall to the HPA axis and how activated it is and for how long it is activated.
Yeah, thank you. And another question you have described about the very rare syndrome of supersensitivity to glucocorticoids, the opposite of glucocorticoid resistance. Now, if you come across such rare cases of hypersensitivity to glucocorticoids, how do you really clinically manage those cases? Is it with glucocorticoid antagonists?
There are glucocorticoid antagonists you can use in small amounts, right? Or you can even use ketoconazole or something to decrease the amount.
The secretion.
The difficult thing there is to make the diagnosis.
Yeah.
Because they're just obese, they have a little metabolic syndrome. They look like something very common. But what's surprising is that the cortisol levels are low for look. You would expect to be more stressed, to have higher cortisol levels. That's where you have the suspicion for it.
Yeah.
Most doctors don't think about it, so I think a lot of these cases go undiagnosed.
Thank you very much. Prem, now go ahead with your questions.
Yes, Professor George, I will start with one of the questions from the audience, Professor S.K. Singh, sir. So the question is there a way out to replace IPSS?
We use IPSS very rarely now. And that's because the MRIs have become very sensitive. So the difficulty is very rare, but we need to do it. It's not as we used to do it 25, 30 years ago. Now the need for it is much lower.
Okay, thank you. And we move on to the next question. The role of glucocorticoid hypersensitivity in glucocorticoid withdrawal syndrome.
Actually, when we withdraw, I'm sure there is some hypersensitivity the tissues, because we know that possibly glucocorticoid level, receptor levels are decreased when we have high glucocorticoids, and possibly there is a period with hypersensitivity afterwards. But it doesn't seem to make much of a difference, because after we cure a patient, this will cause remission of the disease by removing the tumor. We put them on standard replacement hydrocortisone. So we give them about 10 to 15 milligrams per square meter per day. In most adults, it's about 20 milligrams a day, and it works fine.
Thank you. And another question is, have you managed glucocorticoid resistant syndrome patients, female, in pregnancy? And do you shift over to hydrocortisone or prednisolone?
We haven't had this experience. It's a rare syndrome. It just never happened to have somebody.
Right. Okay.
However, we have patients who had been pregnant and had children, and they had no problem. And the reason they had no problem is because the feedback regulation works. So what they do is more cortisol, and they compensate for themselves. You see, most patients with mild glucocorticoid resistance compensate perfectly. They can be totally asymptomatic. It depends on the level of the resistance, how resistant they are, and on the level of their tissue sensitivity to what problems they will develop. However, you need to know that there are patients with glucocorticoid resistance who are totally asymptomatic.
Right. Thank you. And the next question is, in patients with glucocorticoid resistance, will they have similar resistance to all synthetic glucocorticoids?
Generally, we chose to use dexamethasone. So everybody has gotten dexamethasone for one main reason, because dexamethasone does not have mineralocorticoid activity. See? So by giving dexamethasone, we take away cortisol and ACTH without touching the renin-angiotensin axis. And that's the only reason we use dexamethasone. And most of these patients completely normalize on dose of dexamethasone that you would consider elevated. For example, we give between 1 and 4 milligrams of dexamethasone a day in these patients, and they tolerate them extremely well. Because their tissues are resistant, so by giving a little extra, it doesn't matter. The tissues feel that they get a normal amount of glucocorticoid effect.
Fine. Thank you. And another question is, how to follow up glucocorticoid resistant patients in the long term, and how are their survival rates?
Again, it's a small number, so we cannot calculate survival rate.
Right.
We hope, though, that by treating them in time, that we normalize their life expectancy. Granted that we don't give them extra glucocorticoid, they're not cushingoid. We give them just enough to keep their ACTH normal. We follow them regularly and hope that they will do okay. Now, the first patient that I saw you died when he was 56 years old, and he died at the age of 75. And when we saw him, because of the chronic hypertension, he had already atherosclerosis. Probably we controlled his hypertension and he got better, but then he died where is a little lower, 75, than the life expectancy in his country, which is Holland. It's probably 78. So we hope that we normalize these patients and their life expectancy.
Right, right. Next, can we have Professor Lee? We have a few questions to Professor Lee. Sir, can you just unmute yourself? Professor Lee, sir, can you hear me?
Yes. I can hear.
Yeah,
Can you
sir. Yes, sir. Few questions from the audience. In central precocious puberty, what is the dose and the frequency of GnRH agonist to achieve the best results with minimal adverse effects? The dose and frequency of GnRH agonist.
First, it depends which GnRH analog one is using. You know, the most commonly used one in the United States is the leuprolide, and that is in doses to be given every 4 weeks or every 12 weeks. There is also a new medication that involves a large injection that lasts for 6 months. There's also the implant. I think the frequency of the injections doesn't matter. For example, with the Depolupron, the 12-month has become very popular because it requires fewer injections. The other thing that has happened, particularly during this pandemic, when patients are not able to be seen physically that often, is that the larger dose is used, I think, because it's felt to be safe, and then one can feel assured that suppression will occur. Okay, let me start my video. Can I start that?
Sure, sure.
Okay.
Yeah, thank you.
The part of that question referred to adverse events, and I think one of the reassuring things about this medication is that as a result of the studies from the Depolupron, the 3 different doses that are for 4 weeks, and the 2 different doses that are for 12 weeks, the adverse events were not increased in relation to dose. And so the default that has happened in the United States when patients are not available to carefully monitor their treatment is to use the 12-week or 3-month dosage. Whether or not the 6-month dosage will impact that is difficult to say. And then, of course, there is, and I'm sorry, I don't know what you're using in India. There's also the implant that lasts literally 4 years. And so the point with dose is to start out with a dose and then check in 2 to 3 months to see if there's evidence of suppression, and then check in 6 months to verify that puberty hasn't progressed, that check growth rate and bone age. So there's no straightforward answer to the dosage question.
Fine. Thank you, sir. And another question is, sir, would you consider giving, medroxyprogesterone acetate for all along with GnRH agonist? If yes, then what is the preferred dose and route of administration?
Consider giving medroxyprogesterone in what situation? Along
CPP.
with GnRH?
CPP, yeah, along with GnRH.
I don't really see a reason to give medroxyprogesterone, and is there a reason? It should not be needed if we're talking about central precocious puberty.
Fine, sir. So next question, how to approach isolate?
Prem,
yes, sir.
Before you go ahead, I think Professor Nalinisha has a question to ask.
Yeah, sure, madam. Sure, madam. Nalini, ma'am? Yeah.
Yeah, thank you. So, Professor George, I think, and Cushing and both glucocorticoid resistance as something which you really have, I think, lived your life dealing with these two. So your depth and expertise was something which was extraordinarily visible, even in the short span of interaction that you could hold with the audience. So that's a phenomenal job, and congratulations for that. May I just ask you, does it behave something, the thyroid hormone resistance, with different organ system or cellular system behaving differentially towards resistance? Or do I have central resistance which is different than the peripheral resistance, and vice versa? Because that's going to change me from Cushing to Addison, really speaking. So do you get that kind of a spectrum at all?
We get a spectrum, but it's very small spectrum. In other words, you cannot go that wrong.
Okay.
Even when there's, let's say there is different sensitivity in the hypothalamic pituitary unit and let's say the fat, that difference is not major.
Okay.
But if the fat is more sensitive than the pituitary, in that case, you're going to get some obesity over time. It's not as dramatic as you see with thyroid resistance. The tissues are not that different, but they do have some difference, and one needs to think about it. And we have seen some problems because of that.
Perfect. And how exactly do you titrate the doses of dexamethasone when you treat these patients? Because the range is sort of anything from 1 to 4 to 8 milligram, which is like huge difference to me.
I'll tell you, we will normalize ACT, cortisol, and adrenal androgens.
Perfect.
All that. So clinically and biochemically by normalization of the axis.
You just look at the basal values, or do you look at some sort of stimulated suppress? Just the basal values. Yeah. Okay. And amongst the adrenal androgens, your preferred one is DHEAS?
We prefer delta 4, androstenedione.
Okay.
It's more affected by ACTs than DHEAS.
Sure. And your second part of presentation, which kind of narrated the whole physiology to the clinical picture, to the management of Cushing, I wanted to understand from you, what has been your experience with recurrence of childhood Cushing and your positioning of A, screening parameters, and B, modalities of treatment in these patients?
We have about 10% recurrence rate. And in this case, we bring them back and we do a second operation. And about 70% of the cases are the second operation. So 9 out of 10, you just follow them. They don't need to do anything. They're cured. But one will need more help.
Right. And you kind of had clear reservations on radiotherapy. I could perceive that part from your presentation. I mean, I think you've given it up. Is that the way you see it?
Primarily, yes. We may do the gamma knife in cases where we really need to limit the tumor in the pituitary. But generally, we don't do linear acceleration, the standard one, and combined with mitotic, which is the way to treat these patients. Now we have better surgeons they do a better job. It's very rare that we're going to need to do radiation. Very rare.
Right. Thank
It's
you.
not a choice anymore.
Thank you. Sure. Sure. Professor Peter Lee, if I may please ask you a question. And this relates to your monitoring parameters in patients with central precocious puberty. What are your expectations vis-a-vis auxological parameters and the reproductive parameters like breast changes? I'm not talking about menses because that control is pretty effective, but breast changes in particular and biological changes like uterine dimensions and so on treatment.
Okay, monitoring of physical development, particularly breasts, is sometimes quite difficult. If the patient is treated when there's still minimal breast development, one can see considerable regression. After that, it's sort of the impression that the breasts become less firm, etc., and it's often difficult to assign a Tanner stage. And so I would limit the breast observation to the observation that there's not clearly progression of breast development. Other monitoring, which used to be done a great deal, was GnRH stimulation tests, but that was back before the sensitivity of the gonadotrophin assays. Generally, I monitor only by obtaining an LH level. There may be difficulties with that because the LH level is not necessarily back in the prepubertal range. If the LH level is in the prepubertal range, that's fine. If the LH level is higher than that, one needs to decide what more to do. The GnRH analogs do cause a very rapid or considerable synthesis of the alpha subunit of these peptide hormones. And so there's the issue of maybe that is being measured or making the LH higher, or the question of whether there is immunologically measured LH that is not biologically active. And so if LH is back in the prepubertal range, one does not need to do a GnRH stimulation test. If other criteria such as breast development suggest progression, if growth rate is still accelerated, one is probably needs to do a GnRH stimulation test to see whether there's evidence of suppression there. It's worth making a comment about bone age too, because bone age advance lags from considerably after the sex steroid exposure. And so one cannot expect bone age deceleration to be present in the first 6 months of treatment, or one should not be disturbed if bone age it has not slowed down as long as it's not accelerated dramatically. After the first 6 months, if there is suppression, bone age advancement should be very slow, maybe less than a year's worth in a year if bone age is markedly advanced. So generally, it's the clinical impression looking at the same parameters that one looks at to diagnose the central precocious puberty.
And what's your experience with the height centile curve? Do they maintain it? Do they decelerate? And how soon will they change that?
Well, one would hope that they would grow at a normal growth rate. And so if they're on the 97th percentile or +2 standard deviations, it's consistent with treatment that they continue to grow at that height, but not at an accelerated growth rate. There is the problem, and that's probably part of what you're talking about. When patients have been on for a prolonged period of time, their growth rates may slow down. That seems to be related to bone age. Those with the much more advanced bone ages, where you really can't expect rapid growth, may be growing slowly. The other issue there, of course, is the issue of the fact that it's sex steroids, particularly estrogen, that stimulates growth hormone and IGF-1 synthesis. And if you've taken that away, you may have been creating a growth hormone deficient status, but that's very awkward and very expensive because some have opted to add growth hormone therapy to GnRH. I think it's very important at each interval, say every 6 months, as the patient's been on for more than a couple of years, to obtain a bone age, assess the bone age, and assess the height prediction. Even though we know it's inaccurate, the relative height prediction tells one something. And of course, that's based on growth rate. So hopefully they will grow at a rate of at least 5 centimeters a year for a reasonable period of time.
Thank you.
I invite any comments or queries from the panelists again, Niranjan sir, Mala madam, Parag sir. Or else
I think you can go ahead with the questions. I think you have quite a few. Yeah.
Yes. So to Professor Lee, sir, is there any difference in parent adjusted height and actual height attained when GnRH agonists are started in children after 8 years of age?
Thank you for asking that question, because that's a very important question. Because early data were interpreted that there was not a value in treating to preserve or reclaim height in individuals that were beyond 6, 7, 8 years of age. That is not true. As long as there is a potential for growth, the GnRH analog therapy can gain back and preserve growth. And so if a patient is dramatically short, it may well be worth treating that patient to give them a few more centimeters. And of course, a few more centimeters between 148 and 152 centimeters are a great deal more important than the difference between 152 and 100. I hope that illustration makes sense. But the point is that as long as there's a potential for growth, there is the possibility of gaining height back. Of course, one reaches a point where if the bone age is advanced enough so growth is 95% or 96% complete, that there's no way to tell how much height you gain back, because there's no way to tell how much they grow without treatment or with treatment. Another point I think that's worth making too is if the patient is growing at a dramatic growth rate, say 12 centimeters a year, it may be worth considering not interrupting that puberty if their height looks like it's going to be reasonable. And so you sacrifice whatever morbidity is associated with being tall during childhood by allowing that patient to grow. Because if a patient's grown 12 centimeters this year, they're not going to grow 2 centimeters next year. They're going to grow a considerable amount next year. And so there is a place where it may be debated that one would not want to use a GnRH analog. I hope that makes sense.
Yeah, thank you, sir. And one more question, sir. And how to approach isolated erections in a child with no growth spurt, no increase in size of testis after mini puberty time is passed off. So how long can he have erections without precocity and mini puberty?
I would be concerned about that history of the possibility of sexual abuse. On one hand, you know, prepubertal children, boys from in utero onward have erections. They usually are not prolonged, and they come and go and should be treated as a normal phenomena. If a boy has prolonged erections, that and prepubertal hormone levels, particularly testosterone levels, I think there is a risk. I can't say how much. There is a risk that that boy has been sexually stimulated and abused. There is also a possibility, I think we need to be realistic about human sexuality, that that boy has realized pleasant sensations from stimulating his penis and having erections as well. That you can't have precocious puberty based on erections alone. So,
right. Thank you, sir. And one more question, sir. Risk of PCOS in GnRH analog. Is precocity itself causing PCOS, or is it GnRH analog?
I missed the first part of what you said.
Just a minute. The risk of polycystic ovarian syndrome in GnRH analog. Is it the precocity itself causing the PCOS, or is it the GnRH analog causing the PCOS?
I would back up and say that that risk has been hypothesized now for more than 20 years, but it is not clear that the GnRH analogs increase the risk of GnRH. And I think that most of the thinking is that this individual already had the basics of developing hyperandrogenism. That's why it would be interesting to know if such patients presented first with androgen findings in sexual hair, as I alluded to, but I don't think that risk has been verified in spite of attempts to verify it. And so I think we need to think in terms of PCOS being a common disorder, and there's no reason to think that a patient that has central precocious puberty may not develop that.
Right. Thank you, sir. So I think we are just running short of time, and I just inquire from the panelists, Niranjan sir, Nalini ma'am, Mala ma'am, and Parag sir, any more queries or comments?
No, thank you.
No.
Yeah, Parag sir.
Thank you. That was an excellent session, and I thank the organizers for giving me the chance to, chair this session, participated by stalwarts in the field of pediatric endocrinology and cortisol metabolism. So I think over to the organizers.
Yeah,
it's an honor to be involved. Thank you.
Thank you, Professor Peter Lee, Professor George Kiroses. It was it was an excellent lecture for all of us. And thank you, Niranjan sir, Parag sir, Mala ma'am, and Nalini madam for the excellent questions and discussion. And thanks to Rakesh sir and Sri Nagesh sir for giving me again the opportunity to be with the stalwarts. And I handed over the sessions back to Rakesh sir. Thank you.
Thank you. I thank the chairperson, the panelists, and the rapporteur for excellent job, and the speakers who are going to be here with us for the next session also. We'll have a short break. We'll have a corporate presentation from USV. I invite Dr. Mrs. Farida to take.
Yeah. Thank you, Professor Rakesh Sahai, and good evening to each and every one. I thought I'll just take this opportunity for a couple of minutes to share with you our thoughts on the program as well as our USV. I would just like to, sorry, yeah. So at the outset, I think it's a great meeting which is going on, and we are extremely thankful to all our organizing committee members, Professor Rakesh Sahai, Professor Bipin Sethi, Professor K. Nilavani, Professor Dr. Sri Nagesh, as well as the patrons, advisors, as well as the members who have helped us to do set up the entire program. I would also like to thank the chief guest who came for the inauguration, the executive committee members of the Endocrine Society, all the chairpersons, the international speakers, expert panelists, rapporteurs, oral and poster presentations, judges, and also the endocrine audience. Just want to share that USV has been in the healthcare business for almost about 59 years, and we have been leaders in diabetes all these years by value and prescriptions. In fact, 1 out of every 5th prescription in diabetes contains a USV oral anti-diabetic brand. We have been leaders in cardiology also by prescriptions. You are aware that Ecosprin is one of the brand. When government reduced the prices way back 15 years back, we were the only organization that continued to sell Ecosprin, which is even now at about 30 paisa a tablet. We are present in 75 countries, and we are global leaders in generic metformin. 1/3 of the world's requirement of metformin is supplied by USV. And we do have partnerships with multinational companies, and specifically the current partnership which is ongoing with Janssen for our canagliflozin, that is Sulicent. Our profound gratitude to each and every one of you and your family for being an integral part of our journey. And our aim is to partner with you to ensure better patient care so that India can be recognized as a healthcare capital rather than the disease capital of the world. If we just talk about the roots of our USV, we are extremely proud because our roots are deeply ingrained in our Indian history. In fact, our founder, Dr. Vittal Balkrishna Gandhi, who is the founder of USV, he was a freedom fighter, and he was a part of the first parliament of our country. He was a very, very integral member who was working very closely with Pandit Jawaharlal Nehru. In fact, in Bombay, there are 2 streets which are named after our founders, and these 2 streets are in very prominent locations of the business locality. His son, Dr. B.B. Gandhi's son, Arvind Gandhi, had also done a collaboration with Dr. Casimir Funk, who was the inventor of vitamins, and that is why our old brand Viceneral syrups was invented by Dr. Casimir Funk way back in 1970s. Coming to the present, we have 5 manufacturing plants and 2 are under construction, and where we manufacture active ingredients as well as the branded formulations. And we are all aware of the brands that USV has. However, I must mention this, that as an organization, we believe that knowing is not enough and we must apply. And only wishing is not enough, and we must do our bit, however small it is. And of course, Mahatma Gandhi said that if you want to be the change, see the change, then we need to be the change. And as a result of which, our partnership with all the physicians since the last 5 decades have been in area of creating awareness in all the chronic diseases that we are a part of. And as a result of which, every year about more than 13.9 million to 14 million people are kind of made aware of conditions like diabetes, hypertension, cardiovascular disease, and recently endocrinology also. We are continuously, since the past 5 decades, we work on finding out the diagnosis of the undiagnosed pool of diabetes specifically, and more than about 1 crore people are screened every year for diabetes as well as for hypertension. Our National Diabetes Educator Program has been going on for the last 9 years, and we have trained about 14,000 paramedicals along with you all in partnership with each and every one of you, in order so that we have created jobs for many of them and increased the patient care to some extent. We also strengthen and support research. I am sure that many of you may be aware that our Indian Diabetes Prevention Program, which was conducted under the leadership of Dr. Ramachandran of Chennai, was supported by USV way back in 2006, and it is widely quoted in the international publications for prevention of diabetes. And of course, recently, last year, for the next 3 years, we are also providing a handsome grant to Endocrine Society of India in order for their translational research, in order to motivate research. And of course, our programs to educate the physicians are continuing, and which kind of leads to continuing medical education. This is one program for endocrinologists where it is going on for the last 17 years. And since the last 3 years, we have been privileged that Endocrine Society of India has partnered with our A.V. Gandhi Award for Excellence in Endocrinology. And through this program, I would like to mention that our commitment to endocrinology and to endocrinologists is more than 100%. I would say it goes to more than 200%. Or even though we do not have many brands in endocrinology except in diabetes, but our commitment continues. And in this tough time during the COVID time, in fact, we have been supporting for your safety against COVID. And as of September 10th, about almost 30 lakh units of safety gears have been provided to various physicians across the country. Because and also that we are extremely committed to make sure that our postgraduate students who are there in different parts of the country are supported with these safety gear, so that while they fight in the front, they are also safe. And as we believe that life without a purpose is meaningless, and we definitely have a purpose which is beyond business, and to be a part of your and your patient's journey. And therefore, I just want to end by saying that we are, again, I would like to reiterate that our commitment to endocrinology and endocrinologist is going to last till the time that USV is there in healthcare business, and it is more than 100%. And we might have erred at some points of time, but however, it would have been unintentional. So with these few words, thank you so much. And again, thank you to the entire organizing committee for extremely putting in a lot of effort in order to make this meeting a great success. Thank you so much. Thank you.
Thank you, Mrs. Farida, for the support provided for this program. And I would now request the next session to be started with Dr. Beatrice to take over the proceedings. She is the rapporteur for the next session.
Thank you, sir. Very good evening and a warm welcome to all of you. So I'll introduce the chairpersons of the session. We are privileged to have with us today Professor Vagish Iyer. He's Professor and Head, Department of Endocrinology at St. John's Medical College and Hospital, Bangalore. He has served as co-investigator and principal investigator to almost 80 multi-center clinical trials. He's editor-in-chief in the Journal of Indian Clinical Sciences and associate editor in Journal of the Indian Thyroid Society. And he's author to 36 national and international publications and 53 poster and paper presentations in various conferences. And he has contributed to about 14 chapters in reputed textbooks and CME updates. We welcome you, sir. Next slide, please. We are also privileged to have with us today Professor V. Suresh. He's Professor, Department of Endocrinology, Sri Venkateshwara Institute of Medical Sciences, Tirupati. And sir has been awarded the Professor V. Ramalingaswamy Award for being the best intern at AIIMS, Dr. P.N. Berry Scholarship for London 2005-2006, and International Sponsorship Scheme, so RCP London, for the same year. And he's also been awarded the prestigious Andhra Pradesh State Teacher Award for Medical Sciences in 2018. And he has over 65 national and international publications. We welcome you, sir. And now over to the chairpersons to take the session from here.
Thank you. Thank you first, Dr. Rakesh Sahai and Dr. Nagesh, and also Dr. Beatrice for inviting me to this prestigious event and to take part in an event where all leading speakers are present from all over the world. First of all, we're a little bit late, so let us directly for the session. I want to introduce a speaker who has already been speaking in the previous session on precautionary, but the newcomers who are somebody and right now. For them, Professor Peter Lee is a professor of pediatric endocrinology and consultant, Pennsylvania State Milton S. Hershey Medical Center and Lake Valley Hospital, Hershey, Pennsylvania. He's also past president of the prestigious Law Silkins Pediatric Endocrine Society, and he's author of many guidelines on puberty and disorders of sexual differentiation, and author in chapters on the same subjects in most endocrine textbooks. And he has around 317 peer publications, more than 11,000 citations. Over to Professor Peter Lee. Sir, Professor Peter Lee.
Was this not to be preceded by a case presentation?
Yes, sir. I'm here, sir. I'm going to start the presentation.
Okay.
Good morning, Professor Peter Lee, sir, and good evening to all the distinguished faculties and my dear friends. I'm Dr. Praveen Kumar from Care Hospital, Hyderabad. I'm resident. Today, I'm presenting a case of a boy aged 14 years, 9 months, who is studying class 10, who recently visited our OPD with the chief complaints of absence of secondary sexual characters. He's concerned as his cousin, who is 6 months younger, has grown taller and has developed facial hair. Birth history is a product of non-consanguineous marriage, third in the birth order by full-term normal delivery. At birth, there is no history of prolonged jaundice, hypoglycemia, or midline defects. There is no history of micropenis, cryptorchidism, or hypospadiasis. His developmental milestones are normal, and his academic performance is good. There is no history of headache, vomiting, visual disturbance, head trauma or surgery, or radiation exposure. On probing, he does mention about decreased sensation of smell to good or bad odor when compared with others. There is no history of testicular pain, injury or swelling, or radiation or chemotherapy exposure. There is no history of any thyroid illness, eating disorders, gastrointestinal tract diseases, or any other chronic systemic illnesses. In the family history, there is no delay in the growth or puberty in the father or his immediate elder brother, but his eldest brother has similar problems to him and presently on monthly intramuscular injection. On examination, anthropometry details, his weight is 53 kgs, his weight age is almost the same as his chronological age, his height is 153 centimeter, his height age is 12 years, 9 months, which is less than the chronological age. Mid-parental height is 165 centimeter. His arm span is 157 centimeter. Upper to lower segment ratio is 0.93. Vitals are normal and his Tanner staging is A1, P2, and T volume is 1 ml on both the sides, which is soft in consistency, corresponding to G1. Stretched penile length is 6.8 centimeter. There is no gynecomastia or synkinesia. In systemic examination, anosmia is noted, otherwise it is normal. On investigations, his hormonal profile showed total testosterone of 16.46 nanograms per dl. His follicle stimulating hormone is 0.91 international units per ml. LH is less than 0.1 international units per ml. Inhibin B could not be done. His TSH is 2.6 microinternational units per ml. Prolactin is 15 nanograms per ml. Other routine investigations of complete hemogram, renal function test, liver function test are in the limits. His bone age corresponded to 14 years. We could gather more information regarding his brother who had similar history, and he's diagnosed to has hypogonadotropic hypogonadism with hyposmia at the age of 18 years, 6 months. At his diagnosis, his height is 170 centimeter, weight is 60 kgs, arm span of 175 centimeter, upper to lower segment ratio of 0.78. His Tanner staging was A1, P2, and G1 with stretch spinal length of 4.5 centimeter. His hormonal profile was similar with testosterone of 14.56 nanograms per dl, FSH of 0.9 international units per ml, LH of 0.1 international units per ml. His TSH is 1.2 microinternational units per ml and prolactin 30 nanograms per dl, and rest of the other hemogram, renal function, liver functions being normal. On MRI, in T2 weighted coronal section, it showed bilateral agenesis of the olfactory bulb. With this, he was diagnosed with to have Kallmann syndrome, and presently is on monthly testosterone treatment and is in lieu of the gonadotropins. With these details, I would like to consider the differential diagnosis of delayed puberty in this boy of 14 years, 9 months. Is it possible with the possibility of an exception of having constitutional delay in growth and puberty? And secondly, hypogonadotropic hypogonadism. And lastly, I would like to keep the differential diagnosis of functional hypogonadism. With this, I would like to conclude my case presentation, and I would hand over the session to Professor Lisa. Thank you.
Thank you very much. That's a very complete presentation and brings in many of the details that we need to talk about in the next few minutes. Key to this presentation, even without the sibling, is the history of anosmia, and that should direct us to the workup and the presumed diagnosis of Kallmann syndrome. It's also key, of course, that he had a sibling with a similar presentation. The small testicular volume indicates prepubertal status or hypogonadism, as does his low LH value. I was pleased to see the upper and lower ratios were included because there is the phenomena. If puberty does not occur when it should, the long bones of the body continue to grow, and so the legs are disproportionately longer than the upper segment, and that's a good biologic finding. So can someone put up my slides, or shall I try to do that? Very good. Very good. And so that is our introduction to delayed puberty and the learning objective. And we've already been focused upon the fact that lack of pubertal development may be a consequence of delayed or absent hypothalamic pituitary or gonadal function. And we can categorize patients, if we don't have clues, as we did in this patient with anosmia and family history, by gonadotrophin levels. And we need to remember that the delay may be a temporary or partial or permanent condition. And the next slide, which if you saw my previous talk, you see the same figure. And this points out that the failure may be at the level of the hypothalamus, Rarely it occurs at the level of the pituitary, and that is if there's pituitary disease of some sort, resulting in hypogonadotrophic hypogonadism, or if there's an absent gonad or a dysfunctional gonad in hypergonadotrophic hypogonadism. So the issue, if gonadotrophins are low, let's go to the next slide. This may be delay with normal potential, as with constitutional delay, or a whole host of diseases that need to be screened for in some manner, or if there's a permanent hypogonadism, as we suspect there is in this patient, or if there's hypogonadotrophic hypogonadism, the entity that was referred to earlier as functional hypogonadism, in which there is testicular failure. Moving ahead, the diagnosis should be made when puberty does not begin within the range of time when puberty should begin, or also if puberty has begun and does not progress at a normal rate, because puberty should proceed to completion on the average in around 3 to 4 years, sometimes slightly longer. And so you can see the general ages that are accepted for the late onset of puberty are 13 for females and 15 for males. The next slide points out that for puberty to happen in females, physical pubertal changes to be seen in females, one needs both LH and FSH, because, in order for the granulosal cells to secrete estrogen, they need precursors, either androstenedione or testosterone, that are produced by the thecal cells. And as you can see in this scheme, LH is required to stimulate the steroidogenesis in the thecal cells, but LH also is required to secrete estrogen. And so both are required, again, before one sees physical changes of puberty, in contrast to, as you see on the next slide, the secretion of LH alone results in stimulation of Leydig cells to produce testosterone that stimulate the physical changes of puberty, except for testicular growth. And FSH is required to stimulate the seminiferous tubules. And of course, it's the seminiferous tubules that make up the majority of the volume of the testes. And one, at some point, if one wants to determine functional health of the seminiferous tubules, one can go back and measure inhibin B and anti-Müllerian hormone. So again, in the next slide, again, I thank the case report for covering these entities. It's important to screen in history for anything that might be temporarily delaying the onset of puberty, such as anorexia nervosa, very intense exercise, tumor in the past, or radiation. Anosmia is key to always ask. And then on a physical exam, we've talked about the ratio where we're staging. It's important to do a neurologic exam with fundoscopic examination and to assess body fat and the thyroid gland. Next slide points out that testing includes LH and FSH. Again, I emphasize LH. The figure on the upper right points out that When gonadotrophins are low, GnRH stimulation test does not differentiate necessarily constitutional delay from hypogonadotropic hypogonadism because there's an overlap there. He is already beginning in which constitutional delay will have a higher peak. So it's generally not helpful here to do GnRH stimulation testing. We'll come back and talk about the reason to measure prolactin. We've already talked about measuring sense of smell and to verify what the bone age is, because typically puberty should begin, if it's potentially possible, when females have a bone age between 10 and 11, or when males have a bone age between 11 and 12 to 12 and a half. Next slide. Additional considerations that you may want to do more measurements are listed here, but I would suggest at the first level tier of testing, one not necessarily need to do all of these, particularly the karyotype. If one suspects a problem in the central nervous system, of course, an MRI is appropriate. We talked in the previous presentation about early puberty, the value of doing a pelvic ultrasound, which one might consider doing with delayed puberty, but one must remember in a prepubertal individual, if one can't see the ovaries, doesn't mean they're not there. Another minor component in terms of frequency, but a significant situation is if autoimmune disease is suspected, one could check the side chain cleavage enzyme to see if there's autoimmunity against the gonads. Then moving on to the spectrum of changes that present with low gonadotrophins. We talked about constitutional delay. Here again is the list of conditions that temporarily delay puberty that may temporarily delay puberty in an individual that has the potential for normal pubertal development. And then, of course, the permanent situations, which include hypogonadotrophic hypogonadism, isolated, the anosmic form, and also the form in which there is a normal sense of smell. In parentheses after those are the genes that are related to that. They are not absolutely necessary for diagnosis, but helpful. There are also rarely permanent pituitary deficiencies, but one would likely make that diagnosis before the individual reaches the age of puberty. So going back to the top in constitutional delay of puberty, on the next slide, you can see the typical picture of that. It tends to run in families. It's considered to be a result of a variety of genes. And so there's a positive family history in up to 50% of individuals that have delayed puberty. That family history tending to be with the same sex. So boys with delayed puberty tend to have a father, an uncle, or a grandfather that had delayed puberty, and women tend to have delayed puberty in their family. It's generally considered, if untreated, that constitutional delayed puberty will begin spontaneously, although that may be very late. And so often it is considered appropriate to give courses of testosterone for a limited period of time to mature the individual in terms of growth and development and pubertal changes. You see the growth curve here in the deceleration of the growth on the normal curve, because the normal curve is for cross-sectional data. And at the point that the growth curve is being decelerated is at the point that a percentage of the population is experiencing a pubertal growth spurt. Eventually, one would hope that this individual would catch up, and so they would end up being at their genetically expected height. And so if you look at the general percentile where this patient was growing along when he was 5, 6, or 7 years of age, that looks at least in the general range of the percentile that he finally ended up being, albeit he didn't attain his adult height until he was 17 or 18 years of age. Talking about this common situation, we need to go back for a cause of temporarily delayed puberty and the reason for measuring prolactin. And on the next slide, because particularly among males, individuals may have high levels of prolactin, very high levels of prolactin, and may have a prolactinoma that blocks puberty. It may happen both in males and females and cause delay of menarche as well. The high levels of prolactin from the adenoma suppress the GnRH pulse generator. Sadly, if this prolactinoma is huge, it may destroy the LH and FSH secreting cells, but this is the reason to be sure to measure prolactin in patients that present with delayed puberty, even if they don't have a galactorrhea or anything suggesting that. Okay, from that, let's move on to next slide, hypogonadotrophic hypogonadism. And we saw that this patient presented with Fitting-Coleman syndrome, which is associated with hyposmia. The incidence is suggested here, again, being more common in males than females. There are also hypogonadic hypogonadism causes that are sporadic, that are not associated with anosmia. And of course, secrete gonadotrophins may result from other damage to the hypothalamus, pituitary, or surrounding areas. And you can see this list here. Central nervous system defects, including septo-optic dysplasia. A craniopharyngioma may present indeed with delayed puberty, and it's important to diagnose that as promptly as possible. And once again, this may be associated with other anterior pituitary deficiencies, but again, one would generally expect them to present earlier. Syndromes that are associated, let's go to the next slide, because I had forgotten that we had this scheme for Coleman syndrome here with the fascinating pathophysiology because of the lack of the migration of the GnRH producing neurons, as you see schematically here in the image from a rat, that develop at the olfactory bulb. And when there's damage there to the olfactory bulb, as well as to the neurons, individuals have a Coleman syndrome. And the genetics of this are variable, although commonly X-linked, which is the reason it's more common among males. The clinical presentation you see here, and in males, they present with small testes or cryptorchidism, a lifetime of hyposmia, and specific mutations are listed here as well as on the previous slide. The next slide, just mentioning the genetics a little more, that constitutional delay is multifactorial. We've just talked about the variations with Coleman syndrome or other results of hypogonadism that is multifactorial. And so genetic verification is helpful, but we need, as with other genetic situations, we need to remember all of the gene mutations or malarrangements may not have been discovered yet. And so searching in genetics may not be helpful. Moving then to hypergonadotrophic hypogonadism on the next slide. Obviously, there's a whole host of causes of destruction of the ovaries or the testes, and you see them listed here. Autoimmune is here, radiation therapy, galactosemia, which again should have been diagnosed well before the age of puberty, irradiation for tumors, and then of course the common female Turner syndrome, as well as mutations in the gonadotrophin genes and the gonadotrophin receptor genes. There are a list of syndromes that are listed here. We mentioned Turner's, but there's a long list of syndromes and other mutations. So the possibilities are long and but need to be searched for if individuals have clearly elevated LH and FSH levels. Because it's so common, the next slide simply reminds us next of Turner syndrome, and that patients with gonadal dysgenesis may or may not have other phenotypic variation. The classical ones are the cuvus valgus here, the facies, wide-spaced nipples, and so forth. Turner syndrome, we need to remember, may present simply with short stature without any stigmata, and so one needs to screen for that. There are causes, thank you, for hypogonadism, both that cause both hyper and hypogonadotrophic hypogonadism, autoimmune disease, the autoimmune polyglandular syndromes being rare, but a cause that should not be missed, that can cause failure at the level of the hypothalamus as well as the gonads. HIV also fits in that category. Treatment then. Treatment in males, even for temporary, that needs to be discussed, commonly involves testosterone, and there are various ways to give that. Gonadotrophins may be used later to stimulate sperm production. And by the way, there's a very interesting corollary between testicular volume at the time of diagnosis and the ability to produce sperm when stimulated with gonadotrophins. The larger the testes, the more likely there is to be stimulation. So the very, very tiny abnormal seeming testes are unlikely to produce sperm, although there are, as we know, other methods of assisted fertility. Among females, one can initially treat with estrogen and then follow that by progesterone for cycling. Age of onset of treatment needs to be individualized for the patient, and the patient needs to understand what the issues are in terms of his or her development, potential function, and fertility need to be discussed. And so going ahead, I think these last slides of graphs help point out, and then the following slide has the reference, the relative likelihood when one sees a patient with delayed puberty. You can see, because of the frequency of Turner syndrome, females presenting with delayed puberty, about a quarter of them have elevated gonadotrophins. Among the remainder, it's still the majority, as in males, that have constitutional delayed puberty or functional delay because of an underlying or concomitant disease, whereas in fact there are 19%, about a fifth of these patients do have permanent hypogonadotrophin. So these patients need to be worked up sufficiently to arrive at a diagnosis. We'll come back to this eugonadotrophic gonadotrophins very briefly very soon. The next slide underscores what I just had mentioned and gives you that reference. And even though it was almost 20 years of age, I think it gives us an excellent perspective about the relatively frequency of causes of puberty. And the next slide shows a similar data for boys, that only 7% in this series had hypergonadotrophic hypogonadism. And it's worth saying at this point, because Klinefelter syndrome is mentioned here, that Klinefelter syndrome usually, in fact, almost always does not present with delayed onset of puberty, although it may present with delayed progression of puberty. And so most boys that present with delayed puberty have low gonadotrophins. You can see that 2/3 of those have constitutional delay of puberty, but we should not miss that 20% that has a functional cause, such as a prolactinormal. And also we should not miss the 9%. And we're not always as fortunate as we were in the case presented today of having hyposmia and a family history to direct us. One slide on eugonadotrophic eugonadism, and that's the next slide. It maybe shouldn't even belong here, but it's when puberty does not progress normally, or menarche does not occur because of hyperandrogenism or because of vaginal agenesis, or also because of hypothalamic amenorrhea. Thus, for females, at some point, the assessment needs to involve a vaginal examination, and there's still questions of pelvic ultrasound. And so the last slide summarizes the approach that I would think is very important for this situation, that one initially sorts out whether gonadotrophins are elevated or not, and then follows a workup to see whether this is transient, whether it's related to an underlying chronic condition, or whether it's permanent. So thank you very much. I hope this overview was helpful.
Thanks, sir. Now I think there are no questions in the chat box right now, and we can, because we're a little late, merge this panel discussion. And whatever questions up on the chat box also will take in the panel discussion.
Before
I
that,
will introduce the panelists. Yes. Dr. Vagesh?
yeah. Good evening. Thank you, Professor Lee, for your elusive presentation on delayed puberty. To join the panel, I call upon Professor S.K. Singh. He is a senior professor and currently the head of the Department of Endocrinology and Metabolism at prestigious BHU University, Varanasi. He is a former president and a vice president and secretary of ESI. He is a president ESI 2011. He is professor of endocrinology from past 17 years. He also has a fellowship from INSA and the European Commission. He has published more than 160 publications, with 75 publications being in the international journals and 86 in the national. He's a principal investigator for the prestigious ICMR and the UGC projects. Our next panelist is Professor Krishnaji Sheshadri. He's a senior consultant endocrinology and diabetes in Apollo Hospitals and also a senior clinical and research lead in Apollo Sagar. He's a director of the Primer, a medical education company, and PAMS, a medical organization. He has several index publications, including original work. He has written lots of chapters and manuals. He is editor-in-chief of Thyroid Research and Practice, and he is a recipient of a PN Oration from ESI, and also Samji Moses Oration by RSSDI and Dr. Sindhu Pandit Oration in medical education. So next, Dr. Professor Manoj Chadha. He is an endocrinologist currently at PD Hinduja and a Medical Research Center and a Hope and Care Center, Navi Mumbai. He is a president of Indian Society of Bone and Mineral Research Society, President Endocrine Society of India. He is a member of National Academy of Sciences, faculty at the annual conference of ESI and RSSDI regularly. He has Indian College of Physicians and also College of Physicians of Ireland. He is an examiner's Part 2 membership exam for Royal College of Physicians. Please, I request all the panelists to join and we'll take forward the discussion.
Hi, Vagesh. Good evening.
Good evening, sir. Good evening, Dr. Sheshadri.
Thanks for your kind introduction. I hope that this would be very interactive discussion.
Yeah.
So over to Dr. Sheshadri and Dr. Manoj Chadha.
Yeah.
Good evening, everyone. You know, it has been so wonderful listening to people that you attended in a meeting when you trained, and it's just amazing to be in the same screen space as Dr. Lee. And I have followed his work from the time I was an endocrine fellow, and this is just amazing to be in the same screen as Dr. Lee. And again, my colleagues, Dr. Singh and Dr. Chadha, it's wonderful to be with you. This is just an amazing meeting. I'm so happy to be part of it.
I think to keep the ball rolling, I have some basic questions to Professor Lee. So with the secular trend with the decrease in the age of a menarche, is it the same goal of a delayed puberty applies? Age cutoff for a delayed puberty. Sorry, I think you have to unmute.
I don't think we have better data than that.
Okay.
You know, I don't think we have data that with the secular trend, there's not data that puberty is being completed earlier. So I would use those same data. Given that, however, I think we need to be flexible with patients and not insist, for example, that a boy has to be a certain age.
You do this every time that I have a meeting. Don't come here then.
And so I think we need to be flexible, and some children we would work up sooner than others, and perhaps some children we would treat sooner than others.
Dr. Lee, I have one query. You said 13 years to be investigated in case of girl if they don't have pubertal changes, and 15 years in case of boy. Can we have 13 and 14 a difference of only 1 year, as we have a difference of 1 year in the mean onset of puberty in male and females?
Yes, and I would agree with that, and that's what I was alluding to, trying to say I don't think we should set a number that is absolute, and because there's some individuals that have needs for treatment for a variety of reasons at a younger age, and so yes.
Dr. Lee, can I ask a question?
Yes.
So how do you balance the need for height with the need for puberty? What are the kinds of discussion that you would have with families about, at what kind of height would you say, you know what, we've had enough, let's start accelerating puberty?
Well, I think that's a good question, and we need to discuss this with the family and discuss if they have realistic expectations for height. Another very key thing, and that's where the bone age would come in, it would be very important not to start testosterone before the general age of puberty, the bone age of puberty. And so if one would start a boy who has a bone age of 11 on testosterone, he's going to lose height potential. So in relation to height, that is important. And so I would not start testosterone in a girl with a bone age less than somewhere in the ballpark of 11 and a boy in the ballpark of 12 and a half, something like that. So
thank you.
We need to be careful not to be caught in the society's expectation that being taller is better, and we always need to remember that. So.
I've always talked to patients about being tall is in your heart, but that argument doesn't work all the time.
You're right, but it's worth trying, yes.
There are a few audience questions coming in for Professor Lee. There is a question: in certain cases with initial diagnosis of hypogonadotrophic hypogonadism, the testicular volume improves even on testosterone therapy. So till what age we may consider reversibility of hypogonadotrophic hypogonadism, and how do we predict the same?
That's a very important question. And, the fact that testicular volume increases suggests that it may not be permanent. And I think we need to remain open for a long period of time. Not for the patient who has the tiny pea-sized testis, but for these other patients, we need to remain open, because I have heard of my prior patients in their early 20s no longer needing testosterone. So constitutional delay, I don't know, and where you say that's a partial hypogonadotrophic hypogonadism, but individuals do continue to mature well into that third decade of life. And so the patient should be aware of that, unless there is something that tells us that they clearly have a permanent hypogonadotrophic hypogonadism. Excellent question. Thank you.
There's another question, Professor Lee. Cause of hypergonadotrophic hypogonadism in a girl with 46XX karyotype after Turner syndrome ruled out. Can autoimmune causes present with isolated delayed puberty in a girl with no other symptoms? And is there a role of genetics in such cases?
I think it would be most unusual for this to be autoimmune without any other autoimmune suggestions of autoimmunity other places in the review of systems or without autoimmune disease in the family. I think that is most unlikely. One can always raise the question of perhaps the karyotype in the ovaries is different than the peripheral karyotype, and it may not be two fully functional X chromosomes in the ovaries. So that is a difficult situation, but it may occur. So,
if I could interject at this time, Professor Lee, what is your opinion in the US, especially with so much about endocrine disruptors going around and delaying puberty and affecting the ovarian function in one aspect? Would you look at that part in this hypergonadotrophic hypogonadism?
I think because that's very hard to verify, in my everyday life, I have not looked there unless there's something to suggest. I wish we had some way to screen for common endocrine disruptors. And part of the issue, I think, all over the world is there's so many potential endocrine disruptors in the plastics that we have contact with and our food has contact with that that's very difficult. Are we having the discussion, the presentation about endocrine disruptors today?
No, we're going to do this as part of this discussion.
I see. Okay. Okay.
Can I just add to that? We haven't seen any logistic regressions that have looked, or multiple logistic regressions that have looked at, the effect of multiple disruptors in the same population. And these are so ubiquitous that include microplastics that are present everywhere else. Is it even worth clinically considering unless you see a big population trend?
I don't think so. This has been discussed now for 25 years, hasn't it? Isn't that when Skake Box first came up with this and had a large meeting? But we have found out that some of the causes for endocrine disruptors really turned it out not to be that, and so I think it's something we need to remember, but I think it's not part of our practical daily life in assessing patients. I don't have much more to add in relation to that.
Another question to Professor Lee. Does the finding of bilateral undescended testis in a prepubertal male child without any evidence of genital ambiguity, does it mandate evaluation for hypogonadism or other possible endocrine etiologies? Sir?
In what age is this patient?
A prepubertal male child.
Prepubertal, so because if an individual has undescended testes after the first year of life, that raises considerably the possibility of damage to those testes. And so I would follow that patient. Number one, if surgery can be done to bring those testes down as soon as possible, that should be done. And number two, follow that patient very carefully into the age of puberty for evidence of testicular damage. And in that scenario, it's worth remembering that at the onset of puberty, FSH levels rise before LH levels. So in there, where I've emphasized how important LH is, I would measure both LH and FSH.
Dr. Lee, can I supplement this with two questions to you? One is, can you now I think we've moved away from using HCG in undescended testes. Your comments on that? That's one. The second thing is, over the time in your own career and long academic life, you've seen the LH assays change. How does this influence clinical practice? I'm sorry to ask two questions, but these seem to be pertinent.
Yes, but they're both important questions, and I think it's in relation to the use of HCG. It became evident, even though HCG may stimulate the descent of testes by the end of the course of injections, if you're injecting for 2 or 3 weeks, almost always those testes have reascended by 6 to 12 months. So it's there is no HCG is going to help function in the future, and it certainly isn't going to cause the descent of the testes. Part of that is related to the fact that there's a inguinal hernia among many individuals that have undescended testes, and as long as that hernia remains open, particularly in the prepubertal individual, that testis is likely to reascend. The issue of the LH assays goes on and on and on, because over time, from when the LH and FSH assays were first developed back in the late 60s, early 70s, the assays have become more and more precise. And so there's one just needs, if at all possible, to know which assay one's using. And in pediatrics, we need to use the 3rd generation assays. Hopefully those assays that will measure both the alpha and the beta component of the assay, but it's important that you know what the value is for those assays. And I don't know about in your country, but in the United States, we often do not have the choice of what assay is done. And so we have that complexity, which is something we need to be mindful of very much.
Professor Lee, there is an interesting case scenario put up by one of the participants. This is a girl with delayed puberty with poor development of internal genitalia, and she has high normal LH and FSH rather than elevated LH and FSH. Would this suggest estrogen resistance?
I think it would. I think it likely would. And it certainly would be worth a clinical trial of administering estrogen to see if at doses that would normally suppress gonadotrophins, their gonadotrophins are suppressed. It's an interesting, unique phenomenon.
Can this could be a case of partial aromatase deficiency?
Of what resistance?
Partial aromatase deficiency, rather than the estrogen resistance.
That's interesting.
And in that case, giving estrogen will definitely suppress the gonadotropins.
You're right. You're right. That's very interesting. How that would present in a female. That's very interesting. Yeah. I like your thinking. That's good.
Any comments, questions from the panelists, chairpersons?
Yeah, Dr. Lee, I want to take you a little more into, A few years ago, we started looking at, if somebody has got isolated hypogonadotrophic hypogonadism, that you could think about stopping the testosterone after some time, after 2 years, and then recheck. Now, how often do you see this in women as to men? Should we even attempt this in girls? Maybe after and what would be your reasons for not stopping it?
I can't, to ask your last question first, I don't see any reason for stopping for a trial to see what happens. And you could do that either in a male or female to see if they truly need replacement therapy. I have to say, with females with constitutional delay of puberty, I have never had personal experience with an individual like that, or an individual that constitutional delay or hypogonadotrophic hypogonadism that reversed itself. I have never seen that occur. I've seen Kallmann syndrome in females as well as males, and hypogonadic hypogonadism, and whether there's a comparable situation ranging from constitutional delay of puberty to maybe partial hypogonadotrophic hypogonadism to permanent in females as there appears to be in males, I'm not sure. I think it's very prominent in males, and indeed there are males that were married males that were in a regular sexual relationship who for years were infertile and had very low sperm counts, and at some point after 20 years or so proved their fertility with not a terrific sperm count, but enough to do the job. And so I think there is partial, or there's lots of gradations there. I think it's a fair way to say.
One more question that many of the audiences have also put forward, and that's a controversy that doesn't go away. Are there a subset of patients in whom you should start, in boys that is, that you should start puberty with gonadotropins rather than testosterone? I've never done gonadotropins, but every time somebody talks about it, I feel very inferior because I use testosterone.
That's the same question I was going to ask you.
Well, one could argue that physiologically it makes more sense. I think the expense and the frequency of injections and the monitoring that are required with gonadotropins makes it so it's only been done in research situations. I have tried it a couple of times. It is very difficult to monitor that, and the practical outcome, I think, is more that if we're hoping to enhance the fertility of this individual, is that the evidence is fairly clear. If individuals were treated with testosterone, even for prolonged periods of time, there's not evidence that that diminishes their ability to respond to gonadotropins. And so my general approach as a result of that has been you use the testosterone up until the time that male wants to father a child, and at that period of time do a trial of gonadotropins and follow closely what's happening. It takes a long time too, because it takes sperm so long to mature. Those individuals need to hear that we're talking about months and years, many months and years before they have mature sperm. And the whole area of assisted fertility is changing so much that it'll be interesting to see how much those kind of protocols are used versus someone going into a tiny testis and trying to find a germ cell to use for assisted fertility.
So in that case, Dr. Lee, we can say that longer the delay in initiating gonadotropin, poorer would be the outcome as for the spermatogenesis is concerned. So if we delay in starting gonadotropin, perhaps the spermatogenesis will not be that adequate. So it's better to start gonadotropin early as early as possible in order to get a better outcome for spermatogenesis.
I can argue with, yes, I cannot argue with that. There's the practical side of it and the cost.
Yeah.
And,
but there's another side, and can you comment on this? Because one of the challenges with gonadotropins has been the sexuality itself. That people who had started on gonadotropins, they do complain of not having a libido that is satisfying or a sexual experience that is satisfying. So the counter argument has been that, you know,
my point was that we should start gonadotropin as early as possible, but for induction of puberty, I think testosterone still stands a good option, and by the stage of 2 to 3, we may consider adding gonadotropin or starting gonadotropin in order to get better spermatogenetic outcome. But testosterone, of course, we all are practicing, and it is practical also to start testosterone, because no point in going for gonadotropin if we cannot monitor it, we cannot continue it for long. So it's good to start testosterone, but then we must keep an eye on initiating gonadotropin in cases where infertility is also a concern. That's the point.
But monitor the testosterone to make sure it's high enough to enhance libido.
Yeah. Absolutely. In fact, in our practice, one of the things that we've done over a period of time is, you know, when the person's ready to get married or have sexual relationships, is to actually tell them, you know, if you want to be on testosterone for 5, 6, 7 months, when you're ready to start a family, then we can have the conversation of gonadotropins, and that's the way it's worked, simply because gonadotropins alone don't do this.
I feel the purpose of that short course of gonadotropin is just to mimic mini puberty, which they lose. IHH people, they don't have a mini puberty at birth. Probably that's the one purpose we give for a short period. Then we can always replace with the testosterone. Your take on that, Dr. Lee?
I'm not sure I followed.
A short course of gonadotropins to mimic a mini puberty,
or a short course to see what it would do, right?
Yeah.
It's a short course and monitoring. I think any of those combinations could work, you know, with, again, if there's any possibility of spermatogenesis, one should consider gonadotropins all along. But if there's no possibility, obviously, testosterone will be sufficient for needs.
Dr. Lee, what is your opinion about using inhibin as a surrogate marker of spermatogenesis? Have you used that in practice?
I think it's excellent. It's excellent to compared with, yes, even regardless of age, compare, because that tells us about the, it tells us something about the spermatogenic unit, not unit, you know.
So are there age-adjusted normals, or these are just, or do you use just the manufacturer's normals?
Well, there's the normals are pretty constant after puberty, and so either one should be sufficient there.
Oh,
the shifts,
thank you.
In pre-puberty, yeah.
So would inhibin be sort of replacing the GnRH stimulation test to separate CDGP from the hypogonadotrophic hypogonadism? Do we have enough experience with that?
I think we cannot predict that when the child presents in the GnRH stimulation test. I think we do have enough experience, at least in the assays that were used when those tests were done, to say that you cannot differentiate at that point. Because there's many that have looked very hard to see if there's some indicator, as you know, or whether this is a permanent defect or constitutional delay. So,
what would be the counterpart of inhibin B in female, in girl child? The counterpart of inhibin B for diagnosis or for differentiation of IHH from consciousness delay in a girl child, where inhibin B is not helpful.
there is inhibin A has been monitored in females. I don't have enough experience with that to make a comment.
Yeah, but we don't have the exact cutoff for inhibin A as we have at least for inhibin B.
Right.
In boys. Yeah.
Yes. I hear you. Yes.
Dr. Lee, I want you to share your. I mean, you've had such a long career of doing this. Can you talk to us from the human side of what you do? Your most difficult conversations, the lessons that you have learned in taking care of this. I see. You know, when we start out, we are looking so much at the numbers, and over a period of time, we start seeing the people behind those numbers. And you know, I'd like to hear that. I'm sure our audience would love to hear that. Your personal experiences, especially your conversations with families, the most difficult ones, and how you help them.
Well, I hear what you're saying. I don't know how helpful I can be, but I certainly have shifted more and more to less testing and listening to the families, and there's certain things I also, you know, a lot of the decisions in relation to treatment depend upon the temperament of the parents, or more importantly, the temperament of the patient. And I've been very impressed by the fact that there's some patients that have a very, very difficult situation, such as Kallman syndrome, a boy with Kallman syndrome with a micropenis, and who kind of accepts that and is willing to live with what his situation is, versus other people that are don't even want to hear that there's anything less than average with them, or anything outside the range of normal. And I guess the other thing is, both in personal relationships as well as in patient relationships, you know, all of us have our good and our bad points, and and our personality difficulties or insecurities, and those persist through life. And so the sooner we learn to accept ourselves as not being perfect, and making the best of what we have, and being thankful for the good things we have, that's almost like preaching, I'm sorry, but your point is taken, that I do make decisions much more based on the dynamics of the interaction with the patient and with the families, and tend not to do testing unless I would do something different about the care based on those test results. And that's, it's, well, it's somewhat difficult sometimes to make those decisions. But if I'm not going to change a patient's, they continue a patient on testosterone and growth is not a problem, there's no reason to get a bone age x-ray or that sort of thing. I hope that makes some sense.
And do you want to take some questions, or are they filling up?
Yes, sir, yes. Professor Lee, there is an interesting hypothetical question coming in for you from the participant side. What is your thoughts on inducing mini puberty in male infants with hypogonadotropic hypogonadism? Let's say bilateral undescended testis, micropenis.
I understand that, and I have done that. I think it's very important, backing up a little bit, it's very important in documenting that they have hypogonadism by measuring what their testosterone levels, we're talking about boys, what their testosterone level is at about 6 weeks of age. And it certainly does no harm to give testosterone. We don't know if there's a physiologic reason for that increased level of testosterone, but it would be, that's one of those studies that I'm way too old to do, but if somebody would do that study and randomize, find enough patients and randomize patients and treat them and not treat them and see what their outcome was, it might tell us something very interesting. So it's one of those things that's not harmful and is relatively simple, and I would think it would be worth doing. And if at that age does not necessarily stimulate genital development, but if it does cause a response in penis size and penis growth, that's reassuring to the parents at that time as well. So.
Thank you, sir. As we are running short of time, probably 1 or 2 questions from the chairperson's panelists we can take up.
So, I mean, the initial estrogen management of Turner syndrome, we use patches in the US and not available in India. But is there an advantage one estrogen preparation over another, particularly in terms of the height gaining? Any estrogen preparation preferentially benefits the height gain or negatively impact?
I am sorry, but
Dr. Lee, the question is there a preference of one estrogen preparation versus another in management of Turner syndrome? Conjugated versus others, probably.
I understand, and there's arguments on both sides. What do you have available? Do you have ethinyl estradiol?
Yes, sir. And conjugated equinestrogen, or both.
Yes.
And it's Valerate also.
Valerate also.
And
we have all
Valerate
three
also.
preparations.
We have Valerate. Yeah.
You have also
Valerate.
Valerate.
Okay. I have to admit that I have continued, even though I realize that the potency may vary over time, I have continued to use conjugated estrogens over time. We do not have the valerate available readily, and estrogen, estradiol, ethinyl estradiol is, there's some concerns about that, and its passage to the liver and so forth. That so I'm not sure. I'm not sure there's a basis for a strong preference there. So,
as a corollary to that, can I ask, what about breast development management in patients with both Turner's or any kind of hypogonadism? There is always this argument about the estrogen and progesterone, but should we back off when the dose when the breakthrough occurs? How do we work with patients on breast development and your experience with this?
So are we talking about a patient who does not have what's considered adequate breast development yet?
Right. You started the medications. There's breakthrough bleeding, let's say in 6 months to a year, but the child and the family don't feel the breast development is adequate. The mother's breast size is not small or inadequate.
I have seen patients in that situation that have been put on higher doses of estrogen along with progesterone, but very high doses of estrogen, and that has caused the development of what people have called tubular breasts, the abnormal configuration of breasts. So I think I would, because I've seen that, I would hesitate to increase the estrogen dose with the perspective that over time, even on cyclic medication, that over time the breasts are going to grow to their genetic potential, and try, as we do with penis size, to try to de-emphasize the concern about size.
So I think if we go over time, so we should close the session and subsequent questions we can later. So I thank Dr. Billy for talk, which was very active. The discussion also good, and I'm also thankful to Dr. Bliss for conducting the event, and to my chair, Dr. Agesh, and all the analysts, Professor K. Shadri, and Professor Enda. So I'll hand over the organizers for the next.
Thank you, sir.
Thank you, Suresh.
Yeah, I would like to thank the speaker, Professor Lee, the chairpersons, the panelists for that wonderful session. And I thank the audience for their active participation. And hang in there because we have one more interesting session coming up. And I'll hand over to the moderator of the next session, Dr. Amit Goel. Dr. Amit is a consultant endocrinologist at KIMS Hospital, Secunderabad. He's a director, AG Health and Dr. Amit's Clinic. And he's been awarded the best poster in ESICON 2017. And he has publications in leading international journals on pseudomotor dysfunction in diabetes in Indian patients. And he's been a panelist on regional as well as national media. Over to you, Dr. Amit.
Thank you. Can I have the next slide? Yeah. So at the outset, I would like to welcome our panelists for the discussion on disorders of sexual development. We have come to the last session of the event. It started since yesterday, went on across 6 sessions, and we are at the last session today. So to chair the session, may I please welcome Professor Vijay Sarathi, who is the Professor and Head, Department of Endocrinology at Vaidhi Institute of Medical Sciences and Research Center, Bangalore, India. He's been awarded the Best Resident Doctor Award at KM Hospital, Mumbai in 2012. Sir has been the Young Investigator Award, has received the Young Investigator Award 2013 at Vellore,
has also been awarded for the best conclusion and best methodology in 2012 at the A.V. Gandhi Award, has over 70 publications in national and international journals, and is the editor and was the editor from 2015 to 2018 of the Cape News, that's the newsletter of the Indian Society for Pediatrics and Adolescent Endocrinology. Our next chairperson for the session today is Professor Satish Kumar Kamalanathan. Sir is additional professor of endocrinology at JIPMER, Puducherry. Sir has won the Best Reviewer Award for the IJEM, the prestigious IJEM for 2013. Sir has been a peer reviewer for IJEM, IJMR, JPEM, QJM, JPP, PR, IJO, IJDDC, and BMJ case reports. Sir is the associate editor of BMJ Endocrine Disorders and IJMR. He's an ad hoc reviewer of abstracts submitted for the US Endocrine Society annual Endo meets for the last 6 years. He has a credit to start the Department of Endocrinology in JIPMER in 2010 and has got several grants from DST, SCRB, ECR, and ICMR, has around 80 index publications and 5 book chapters. So it's my honor and privilege to welcome both our esteemed chairpersons to chair this session on the topic of disorders of sexual development. Over to you, sir.
Good evening, everyone. At the outset, I'd like to thank the organizing committee for giving this opportunity to be part of this wonderful event. I think like all the audience who are there currently are very well aware of Dr. Peter Lee. So in fact, I don't want to spend much time on his introduction. I would directly request Dr. Peter Lee to proceed with his next lecture. Over to Dr. Peter Lee.
Thank you. Can someone put up my PowerPoint, or should I try to do that?
Dr. Sri Nagesh, do you?
Shaila Bhattacharya, who has done her DM endocrinology from PGI MER Chandigarh, and also has completed MRCP and DCH in UK. She is a professor in the Department of Pediatric and Adolescent Endocrinologist at IMMC Devanagari Shivajyoti Clinic and Manipal Hospitals, Bangalore. She pioneered the fellowship program in pediatric endocrinology in Manipal, and this is to train the post-MD and DNP pediatricians. And her area of special interest include growth disorders in children, early and late puberty, childhood and adolescent diabetes, and diseases of thyroid gland. She has more than 30 publications in various national and international journals, and has co-authored various information booklets in diabetes, thyroid, in various languages. Our next panelist is Professor Uma Kaimal Saikia, who has done her DM endocrinology from AIIMS, and she is a professor of endocrinology in Guwahati Medical College, Assam. She has 35 publications in national and international journals, and is a member of Endocrine Society of India and ISBMR and Indian Society and ISPE. Her areas of interest include thyroid disorders, reproductive endocrinology, and disorders of sex development. Our third panelist is Professor Abhay Sahu, who has done her DM endocrinology from AIIMS. He is a professor of endocrinology in Department of Endocrinology and Metabolism, IMS and SUM Hospital, Bhubaneswar. He was the organizing secretary of ESICON 2018 and was the organizing secretary of also ESOCON 2012 and Aerocon 2016. He was a co-organizing secretary of ESOCON 2014 and 2016 also, and is an investigator in 3 ongoing international trials, and is invited as guest faculty to various national and international conferences. He is a recipient of Rajdhani Gaurav Award, Orissa in 2016. He has multiple publications, posters, and paper presentations in various international and national journals. Welcome to all the panelists here in this session. I hope Dr. Lee has got the PowerPoint ready now.
Professor Lee, sir, can you please mail me your PowerPoint otherwise?
So, ma'am, like to start with, like it would be about recognition of a patient who comes with disorder of sex development. It's true, like we always take it as synonym with ambiguous genitalia or an atypical genitalia and DSD. But there are few instances where the patient has a disorder of sex development, but he would absolutely look like a normal male or as a normal female. And these patients do get missed and present only during later in the childhood or sometimes around pivotal time. So what strategies you suggest for the pediatrician especially to identify these patients as disorders of sex development very early in the infancy?
Thank you very much, Dr. Vijay. It's a pleasure being in this update, especially with all the international speakers and especially Dr. Peter Lee, where whenever we went for international conference, we used to run to listen to his lectures. Today we are listening to him. It's a wonderful opportunity. Thank you, Dr. Rakesh and Dr. Nagesh. Coming to your question, how not to miss the DSD. So this is the most neglected area during the first examination of the child. So I think genital examination should be included first thing along with the cardiovascular examination or any other examination in the newborn. So when you see that a child has got gonads or not gonads is the first thing which you need to see. So you have to see whether these gonads are in the labioscrotal region or in the inguinal region. Next is you see whether there is a clitoris or is it a phallus which is small, that is micropenis. You see the opening, is there a single opening or two openings? You see the pigmentation. You see also the urethral opening, whether is there any hypospadiasis, whether it is a proximal or a distal hypospadias. Proximal to see whether it is a pinoscrotal, scrotal or perineal hypospadias. So all these things have to be examined. Depending on these things, you can tell whether the child is a male or a female. When all these things are not intact or not able to be identified accurately, then you would call this as DSD and then further workup has to be done.
Thank you, ma'am. I think Dr. Lee is back. Is he ready with his presentation? Dr. Lee?
Could you describe your presentation this now?
Now, I emailed the presentation.
Yeah.
Right. So I think Nagesh will take some time to upload it then. So we can move on to the next question. I would like to ask Dr. Saikia regarding this question. The same scenario, but like many a times what happens in that, especially for hypospadias, it's a very gray zone. Like at what level of hypospadias we need to evaluate a infant for DSD. So may I ask Uma ma'am to answer this question?
Thank you so much, Dr. Vijay, and I thank the organizers for inviting me to this August gathering. Hypospadias, as we all know, it could be a distal hypospadias or which is also called a glandular or subcoronal. It could be mid-shaft, or it could be a proximal hypospadias, which again may be perineoscrotal or it could be perineal. So, and we know that this is one of the most common congenital malformations in a male child. So it's about, I think, around 1 to 200 to 300 live births, live boys. So when it is, especially when a child presents with hypospadias, we would like to see whether there is any other ambiguity which may not be noticed by the parents in the form of whether both the gonads are palpable or not. Is there a microphallus? So presence of these associated abnormalities would point towards a more serious abnormality. And of course, if it's a proximal hypospadias. So if there is no other abnormality and all the genitalia after careful examination is normal, if it is a distal hypospadias, I think we can just, we need not evaluate so extensively. But if it's a proximal hypospadias, even if it is isolated, it could be an indication of a serious disorder, maybe a disorder of androgen biosynthesis or an androgen insensitivity. So in that case, we would definitely go for a complete evaluation for DSD.
Thank you, ma'am. So Dr. Nagesh?
Yeah, I've got it. I'm opening it in a minute.
Right. Thank you.
Yeah, this is open. Professor Lee, sir, I hope you can see it.
Wonderful. Wonderful. I'm so sorry. So I can be heard?
Yes, sir.
Okay. As we've already heard, this is a very, very complicated topic, and hopefully as we go through this, it'll provide us with some more information for discussion. There's going to be a focus on infants born with ambiguous genitalia, and also comments on how the approach has changed and is continuing to change. And so the next slide gives you the long outline. I will begin a little bit with embryonic development because it's very important that individuals understand how the ambiguous genitalia internally and externally can develop. It's also important to talk about gender and what we don't know about gender, and the fact that gender and sexuality are not necessarily one and the same. I'll talk briefly about nomenclature. There's been a fair amount of concern or pushback, as we say, from the term of DSD. Talk about infants, talk about examples of patients with DSDs using the nomenclature that was described in 2006, and then talk more about surgical and gender concerns. So for next slide, for early external genital development, it's important that all involved realize that from the undifferentiated structures of male and female genitalia develop, and you're familiar with this, but the male genitalia develop in the presence of testosterone, and in the absence of testosterone, female genitalia develop. Of course, dihydrotestosterone is involved there as well. But if development is somewhere between the two schemes on the lower part, one ends up, as you see on the next slide, with the classifications either as Prader staging or Quigley staging, ranging from normal female to normal male, or opposite that for the Quigley staging. This sometimes is very important, and we need to also realize, it's the same as with Tanner staging, that there's a gradual transition between stage 3 and stage 4. And so patients need to have their genitalia prescribed carefully. I think this photograph of a patient that I saw almost 50 years ago still points out the defects in the complete embryonic development, because you can see the V there to the point of the extent of the fusion of the labioscrotal folds. And then hopefully you can see a curved line partway to the glands, which is the opening of the urethra. That's the extent of the fusion of the urethra folds. And of course, that nipple on the glands is a blind ending nipple where the intended urethral opening would be. So that's the variation of external development that make up those portion of the DSD patients who have ambiguous genitalia. The next slide in relation to internal development is also a key, because once again, the presence of a functioning testis here secreting Müllerian inhibiting factor results in the male development that you see in red on the left of the development of the Wolffian ducts. And in the absence of inhibiting factor, the female development occurs, as you see in blue on the right. If the testis does not secrete malaria inhibiting hormone, or it's known by various terms, anti-malarian hormone, a 46XY individual with DSD who may have the development of the uterus. And the most recent confusion that I heard in a mishandled patient here in the United States was because the doctor taking care of this patient did not understand how XY patient could have a uterus. So the basics of embryology are important. But moving on to the next slide, the basics of human sexual differentiation is a broader realm than that. And we've just been talking about the physical development directed by genes and hormones that progresses in a predictable sequence, which we can say is relatively but not completely understood, is very different than psychosexual development. And that has been part of the problem with the care of patients with DSD, particularly those that required a assignment of being raised as a male or a female. And we will come back to this again and again, because in no individual can one absolutely predict gender identity development, even those without DSD. And then, of course, attention is being focused in changes in our society so much now on gender dysphoria and issues of transgender and transsexuals and the contribution of physical development on gender development is not known. We will come back to those again. A little bit more on the next slide about the classical breakdown of components of sexual identity. This gender identity that we were just talking about, the perception of a child or any individual as one himself as a male or a female, again, cannot be predicted. The gender role is in a fair part, certainly after early childhood, culturally defined and is controlled by the individual. And so an individual's gender behavior it may be part of rebellion and so forth, and makes that difficult in our society. And then the third component is sexual orientation, where the erotic focus is directed, which is separate. And considering treatment of DSD patients, our focus should be on gender identity and a child that is assigned female, hopefully developing a female gender identity, and the same for male. This is, as the next slide showed, this is not well understood. There's components of embryonic development, psychosocial, sexual factors, and social environment that lead to gender identity and adult sexuality, but that is not known. And that's, I think, depicted on the next slide that kind of tries to combine the development of the gonad, sexual determination, sexual differentiation, with examples of genes that are necessary for that physical development. But then on the bottom of the slide, you see the development of gender is very poorly understood. Moving then on to nomenclature and 2006, and because the next slide, the pushback that was fairly prevalent against the terms hermaphrodite or pseudo-hermaphrodite, implying something sexual or implying other things, this new nomenclature of disorders of sex development was devised, and you can see how the previous classification dropped those terms. And so instead of a male pseudohermaphrodite, we have 46XY DSD, etc. As you probably know, and on the next slide, the DSD, which avoided the term intersex, also was made much broader. And so you can see in the left-hand column that this included individuals that had gonadal development that did not present with ambiguous genitalia, such as Turner syndrome and Klinefelter syndrome. This classification and nomenclature is not perfect. There's been a lot of complaints about that, and but we need to use something as an umbrella term. And so using DSD, moving on to the third part in our outline concerning, next slide, the evaluation of DSD during infancy. Obviously, one needs to do that if there's genital ambiguity. Even if there isn't, if there's a family history of DSD, or if the genitalia appear to be the other sex than the karyotype, or as has already been discussed while we were trying to get the slide, the female phenotype with enlarged clitoris, fusion, hernia, and so forth. And the male phenotype, and just perineal hypospadias is here, and I agree that it's open to discussion whether the more mild forms of hypospadias should be assessed for DSD. We can come back and talk about that later. I think it's worth, yes, going on to the changing roles of gender assignment. And I tried to reduce this. So if you follow the bullet points, back before the 50s, it's generally considered that the gonads, as ovaries or testes, indicated the sex of the individual, and that gender ought to follow the sex of that individual. So if one had ovaries, they should develop a female gender identity. Then chromosomal sex was possible to determine once the karyotype came along after the Barr body, and that was used as a basis for sex assignment. And by the way, the underlined portion there, I think, is worth mentioning, because there still tends to be the perception of, if you've got a Y chromosome, you're a male. And our thinking needs to transition to the fact that even though we use this new nomenclature to begin our assessment of patients, it's the genes, not the chromosome, that determines the sex of the individual. So we should de-emphasize that, as well as we need to use a different approach than the one that became too popular during the late 60s for a couple of decades, that's been called the optimal gender approach, feeling that there are environmental determinants as well as prenatal determinants of gender identity, that this was flexible at birth and influenced by psychosocial factors. And of course, that was the whole basis of considering that if you were born as a boy without a penis or with a very small penis, the consideration could be reassigning as a female. And if you were raised as a female, you would grow up with a female gender identity. As you know, that turned out not to be true. And so we need to continue to be very cautious about gender identity. Moving on to the next slide. and back to the assessment of genital ambiguity, we talked about the initial approach should involve physical exam, karyotype, imaging of internal genitalia, primarily to see about uterine development and hormone levels. And I think based on the symmetry of the genital exam, as shown on the next slide, it gives us a key as to where to proceed. From this next slide as to testing. So if the genitalia are symmetrical and there are not palpable gonads, it's likely, not absolute, that this is an individual with 45XY DSD, and of course it's most likely because of how common adrenal hyperplasia is that this individual has adrenal hyperplasia, so one would do the laboratory testing to rule out adrenal hyperplasia. However, if the genitalia are asymmetrical in terms of the asymmetry of the labioscrotal folds or the scrotum, and if there's a palpable gonad, this individual is more likely to have a 46XY or a gonadal DSD, and so it's pertinent to look at the reproductive system, including in human B, and what we didn't mention before this talk is anti-Müllerian hormone, to see what we can tell about testicular function. So moving from that to the next slide and examples of 46XY DSD. And remember that this is based on the karyotype. Once a diagnosis is made, for example, of congenital adrenal hyperplasia or 21-hydroxylase deficiency, there is no reason to use the term DSD more. But it's hard. And so the term DSD allows one to consider the differential diagnosis of patients presenting that have an XX karyotype. And you can see the list here, it can be those individuals with gonadal developmental problems, including gonadal dysgenesis, XX gonadal dysgenesis. The ovotesticular DSD doesn't fit very well because their karyotype may range, but it fits into this category. You see the female androgen excess. There may be androgen excess in utero, as occurs in aromatase deficiency or the cytochrome P450 oxidoreductase deficiency. And then there are those general categories that need to be considered differently that are listed below, including cloacal exstrophy. At any rate, moving to the approach to the XY DSD on the next slide, at the consensus conference, there was, I'm trying to figure out why that says prior to 2015, and I think there were subsequent consensus conferences, but I think this is still referring, yes, to the 2005 consensus conference that was published in 2006, and the recommendation for gender assignment was that all 46XX individuals be raised at females because it was felt that they had the potential for fertility, they had the potential for sexual activity, and that their genital appearance may impact their gender development. And so there was a recommendation for surgery to make them look female. That's a point that's worth mentioning because it is not clear how much an individual's gender development is impacted by their own genitalia. And if they perceive their genitalia not to be male or female, if that causes them problems in terms of gender development. At any rate, the 2005 consensus recommended that all these individuals be assigned females, regardless of their extent of development. And so I want to insert here my concerns about those individuals that are born with fully virilized genitalia. And as you can see on the next slide, I think we need to revisit that approach because there's a very large number of individuals that were assigned male before the diagnosis of CAH. There are many more than 89 reported, but the early series all died with adrenal crisis. But of those 89 individuals that were assigned male, appearing at birth as the individual you see above with the genitalia of one of these individuals at age 7 shown below. Obviously, there's not testes in the scrotum, but otherwise, this is a normal male. And the outcome data of these individuals in terms of gender identity and sexual orientation, long-term relationships, and so forth, has been such that I think when we recognize an individual such as this with 46XX adrenal hyperplasia, we should consider a male assignment because there are more outcome data for those raised males and those with being born with Prader-5. So moving on ahead, we can talk about this more if you want. The gender assignment from the consensus assignment was that they should be assigned female because at that time it was felt that 95% developed a female gender identity. That percentage has, in the most recent report, is in the 80s, a stronger argument for my plea to consider raising this in individual as a male. Excuse me. At any rate, a female gender assignment is clear for individuals complete androgen insensitivity and those with an LH receptor defect. The consensus statement said 5-alpha reductase all ought to be raised as male because 70% identify as male. I would question that again as well because I in fact care for a patient with 5-alpha reductase deficiency who had minimal virilization and thus would not be expected to have major changes at the time of puberty to the clitoris or phallus. And so my plea is to individualize in each of these cases and not categorically say that we would assign all 17 hydroxysteroid dehydrogenase deficiency as male because half of them assigned female switch. You need to consider the factors that we'll come back to later in terms of gender identity. It continues to be the case, though, in my opinion, that those with ovotesticular DSD or mixed gonadal dysgenesis should be raised based upon the findings that we have. And if we can move ahead to the next slide, I think this is illustrates part of the points that I was making, moving to XY DSD individuals and the list of androgen synthesis or action defects that occur there, going from inability to secrete testosterone or dihydrotestosterone to the partial and complete androgen insensitivity, the LH receptor defects. And by the way, these are all patients that I have seen over the last 50 years. This slide in the lower figure is an individual that has an LH receptor defect. There are palpable testes there, but there's no other virilization. That individual, as well as this individual with the star mutation and unable to make any steroids, most of whom do not live past the neonatal period if they live that far. These individuals should be assigned as female. I don't think anybody would argue with that. But then moving on ahead, next slide. To look at the classifications of those under sex chromosome DSDs, again mentioning that Turner's and Klinefelters are in there, but they are different than the mixed gonadal dysgenesis, which is indeed the patient photo of the patient that you see on the left, where there is one good testes as far as can be told and a good sized phallus, and with that it would make sense to me to raise that individual as a male, although if there were not good gonads and not phallic development, one would need to deliberate. Ovotesticular DSD, and the two photos on the right are the individual with ovotesticular DSD, which of course, looking at it, looks like a male with an unfused scrotum. But the next slide, which shows the internal structures, also I think addresses the issue of which gender this individual be assigned, because you can see on one side, the upper figure, there's a uterus and an ovary attached to it with fallopian tubes. On the other side is a testis, which is a functional testis, and one cannot raise these individuals both ways. And the decision was made in this situation because the well-developed phallus and this testis, which was a functional testis, as shown in the lower photo, to raise this individual as a male. On the other hand, if that functional testis had not been there, it may well have made sense to raise this individual as a female, because there's a reasonably developed uterus and ovaries there. Okay, moving ahead with guidelines then, I've just said what is on the top portion of this slide in relation to ovotesticular DSD, and on the previous slide alluded to that for mixed gonadal dysgenesis. There's a major problem among the many patients that are assigned the diagnosis of androgen insensitivity, because a fair number of those are dissatisfied with their gender assignment. And also, many of these patients do not have genetically confirmed diagnosis of partial androgen insensitivity. This is a particular problem in terms of genetics here, because there are so many mutations of this gene that it's almost certain that they all have not yet been identified. So the lack of identifying a mutation does not mean the patient does not have androgen insensitivity. On the other hand, if you find a mutation that's consistent with partial androgen insensitivity, that confirms the diagnosis. I don't know how much we want to talk about cloacal atrophy, but there's conflicting outcome data in relation to that as well, with some individuals being well-adjusted, raised as females, some well-adjusted, raised as males. The gender assignment for 46XY, and this goes back to the optimal gender assignment criteria, even before the consensus conference, it was realized that a good number of these individuals were not developing a female gender identity. And so in this retrospective study, it showed even prior to the consensus conference in the last decade of the previous century that fewer of these individuals were being assigned female. As you can see, more assigned male, even though their penis was felt to be inadequate. There are reasons for that, and we will come back and talk about those, including the prenatal androgen. Moving ahead then, I think to the considerations for surgery and gender assignment, I've just shown you some pictures, some of which you've previously seen of patients, indicating that the considerations for genital surgery are not all the same. And the consideration to reduce the size of the clitoris may be very different than consideration of bringing the vagina down to the surface. What one does with micropenis is a different discussion. We've already alluded, and before I started, there was discussion about what to do about hypospadias, surgery and workup for DSD. There's a very difficult cloacal atrophy that we talked about that obviously requires some surgery. On the lower left panel, you know, if one has severe ambiguity, whether it's XX or XY, many, in fact, in my experience, most parents desire early surgery, even though there are those that advocate for not doing any surgery. If that early surgery does not irrevocably change the future potential, that is better, of course. And so if there's clitoral reduction, if the sensation is retained, etc. And then there are instances of both male and female differentiation, such as this center photo in the bottom, where you can see the male genitalia of this individual, but the uterus with actually testes attached when surgery was done. Next slide. And so, concerning surgery, historically, it was felt that surgery should be done as early as possible. The outcome data from feminizing genitoplasty are very difficult because we don't know how functional this is until after puberty. And because the feminizing genitoplasty techniques have improved dramatically over this period of time, we can't project the outcome as being as poor as it was for those patients that had genital surgery back decades ago. And so outcome data are limited, and also to accompany that outcome data, there's inadequate information concerning of psychological, family, and social support. And so this indeed is a dilemma. A little more details about a surgical, on the next slide, surgical consideration is the arguments that I hear from the surgeons that it's very important to have genital surgery exteriorizing the vagina in the example in the photo shown at the right here, where you see the vagina attaches to the urethra just below the bladder. At infancy, that can be brought down to the surface of the perineum, but as an adult, that distance is so much greater that I hear from most surgeons that this is a compelling reason to do this surgery young, even if one does not reduce the clitoris. There's been a tendency in clitoral reduction to do less and less surgery, and when that surgery is done to preserve the sensitivity, because as you see in this figure with the red dots, if you're not familiar with this figure, it shows that that's where the innervation is. And so if the surgery is done through an incision from the ventral side of the clitoris, retaining this neurovascular bundle, that sensation should be preserved to a degree. And the next slide shows some outcome data in relation to that, that actually looks better than that was before, because women with CAH have better clitoral sensitivity if this nerve sparing surgery was made. It's interesting that this report also said the ability to achieve an orgasm is not correlated with sensitivity, and also, interestingly, not different from controls. And the satisfaction with the sex lives of these individuals is not different from the controls, except for those that had Prader 5 at the beginning. And satisfaction was not correlated with ability to orgasm. And so this is some limited outcome data from the Swedish studies, but still insufficient. Next slide. Coming back to the shifts in recommendations, and I think I've pointed out this already, it's worth saying that even though patients with androgen insensitivity don't have genital ambiguity, and there's no question about what their assignment should be, many of them have significant distress issues, and they need counseling. And for these other two diagnoses, I would once again say that just because the majority grow up a given way, that one ought to individualize consideration and not absolutely categorically say that all of those need to be raised as males. I think the next slide brings us back to hypospadias, and this is another issue. Go ahead and click it again. I'm sorry. Because outcome studies, I've had that problem too. When I try to click, it's delayed. And so there are lots of post-surgical problems with patients with hypospadias, more so the more proximal the hypospadias is. And it's important to realize, and along with the consideration of micropenis, that a significant portion of individuals with hypospadias do not have sufficient phallic length to have penetrative intercourse. So controversies continue about surgical repair of hypospadias, whether or not we consider this a DST. And then the next slide that you just saw a glimpse of approaches the gender issues and reminds us again of the fact that we cannot say individuals were born gender neutral, even though we don't understand gender, and that environment has an impact, and there are certain genes expressed during fetal life that seem to relate to gender development. And the most important factor, which is a key factor in raising 46XY individuals who had functional testes during fetal life as male, is the fact that there is evidence that there's androgen exposure to the central nervous system that makes a difference in factors of development in relation to gender, and maybe predisposes that individual to be more likely to develop a male gender identity. Let's move on ahead then. And go on to the next slide, because I think that says the same thing as this, that the basis of gender would be what we would envision to be the most likely adult gender identity, but consider diagnosis, genital appearance, the probability of fertility, social pressures, what family dynamics and social circumstances. So it's important to give deference to psychosocial factors. And again, for emphasis on the next slide, the factor of androgen exposure during fetal life in the individuals that have functional testes, one that needs to take into account. Let's go on to the next slide. I've not mentioned multidisciplinary teams. Universally around the world, these have been a problem because there are issues of having skilled individuals with experience, particularly among that category of psychologists and so forth, even though it would be considered ideal to have a multidisciplinary team to decide things like gender assignment and surgery along with the parents, and always include the parents. And so, next slide. Changes began prior to 2006, a consensus with a shift away from male gender assignment for 46XY, and click that again with less surgery, I think. Click the advanced slide. I think there's more on the bottom of this slide. Yes, because at least in the United States, there is less surgery done for those with mild or moderate clitoromegaly. And another point to make here is that the individual with CAH is, when treated, suppressing the androgen excess at birth, will have a regression of the prominence of the clitoris over the next 6 months. And so one needs to wait at least that long. And so there's issues for ongoing consideration. Go ahead, and I'll finish up here quickly. Multidisciplinary care, we need to, when thinking of fertility, the assistance of assisted reproductive techniques makes a whole difference in terms of fertility. Standard of care is a term used in the United States, and there's threatening laws about restriction in relation to surgery and gender assignment. I think we need to stand for parents' rights. Move ahead. We're almost done. Next slide. Oh, I forgot the fact that we've alluded to that we're learning more and more from the genetics, but it's hard to know how to apply that genetic information that's developing so quickly. Next slide. We talked about the shifts in surgery. I think we've talked about all of that. I think everyone now would be very cautious to remove a micropenis, even though it is small. And this is partly based on the fact that we know there are individuals that choose a male gender identity and say that they choose that in spite of the fact that they have a micropenis. There's changes. Go ahead and click through those and says I've listed things that we've talked about in the changing on the left-hand side since the 2006, but things that we can't change. And one thing is if there's an underlying defect, we cannot fix it. We don't know what the underlying personality is, which we alluded to earlier today. And we know it's important to enhance the dignity and self-respect of the individual. And so the next to the last slide I've taken from Gary Warren, and I think this is very wise, that we need to remember that people with DSDs need, as anyone else, to find somebody that will love and value them, that they feel at home in their bodies, can have satisfactory sex relations when they want, be part of the community, and trust their caregivers. And so the last slide are take-home messages that I've already talked about. I am pleased to discuss anything, although I don't know all the answers from this whole presentation. Thank you.
Thank you, Professor Lee, for your extensive talk on DSD. Now, I would like the session to be open for panel discussion. So the panelist and the chair, I give the session over to Dr. Vijay Sarthi and Dr. Satish Kumar to go on with the panel discussion.
Prior to panel discussion, we can have few questions which is there in the chat box for Professor Lee.
Yes. So the first question comes from one of the audience is choice of glucocorticoids in simple virilizing CH with precocious puberty diagnosed at 6 years of life, presented as clitoromegaly and premature pubarchy.
And the question's about the choice of glucocorticoids. Is that right?
Yes.
Yes, sir.
Yes.
Yes. That's tough because one can argue that using the short-acting Cortef cortisol is most physiologic, but it's very difficult in terms of compliance. And so I use various glucocorticoids in various situations depending upon the family, going all the way to dexamethasone, which I know was discussed earlier today. One has to be very careful in titering the dose of dexamethasone. And when I use dexamethasone, I use an oral suspension and stress that parents need to shake this very carefully before giving it. But the goal is to adequately not over suppress the patient. And that requires frequent visits and adjustments of doses and requires compliant patients. And so I might try one thing, shift to another. If that's not working, back dose or change the dose if the patient it seems to be overtreated, because we do not want them to develop Cushing's findings and suppress their growth potential. So,
Dr. Amit, if I get an opportunity to continue that question, Dr. Lee, when do you consider mineralocorticoid replacement in CAH patients with simple virilizing form? Do you consider, if you consider, in which subgroup of simple virilizing CAH patients you consider mineralocorticoid replacement?
there are people that argue that you can use it in all of them. If I find that I need a larger than expected dose of glucocorticoids, I would add a mineralocorticoid because, and I think maybe we should go back to our, it maybe change our old classification of salt losing and not salt losing, because there's, there's a whole spectrum there, to the very severe salt losers, to those that may have a little bit of salt loss that never manifests itself. But if one believes the long-term data, particularly the data from Maria New and her people in New York City, there is an argument for trying a mineralocorticoid in many of these patients. Any of them that present at birth even. I guess I'd be more cautious with the one that's presenting later, who was born with completely normal genitalia at birth.
So the next question comes from one other participant. They ask, role of testosterone to DHT ratio. Role of testosterone to DHT ratio in diagnosis of 5-alpha reductase deficiency, especially in the setting where DHT assays are not that reliable. How do you go about with this? And when do you go for genetic testing for DSD? Is it a whole genome or a clinical exome or focus panels of gene based on clinical diagnosis?
Depending upon the availability and insurance coverage, if I suspected 5-alpha reductase, I would do the genetic testing then. I have found, and it's arguable about the T-DHT ratio, but I have found with patients that have 5-alpha reductase, that their DHT to testosterone comparative values are so dramatic that the DHT is so low that one doesn't even need a ratio to make that presumed diagnosis. Individuals have talked, I think, about a ratio of 1 to 20, and I because of the variation of assays, it's hard to, we should not rely just on a ratio. But, it's tough.
Sir, in continuation with the above question, many cases recently, even the genetic screening for DSD is not giving a convincing answer. So do you feel that is it really worth to do a genetic testing, or is just an academic exercise? What's your take, sir?
It seems like in many situations it's an academic exercise. What I'm hearing from the geneticists here in the United States is that the whole genome study is going to be almost as inexpensive because it's so automated. The whole genome study is going to be as not costing more than doing a battery of known mutations. So it sounds like that might be the future. And when it gets beyond the point of academia is hard to tell. So I would go back, if I feel confident of the diagnosis, I would treat the patient with the diagnosis without genetic testing. Of course, I should have said in relation to the whole genome testing, if there's a variation in the genome, one needs to have a geneticist, not a company that does genetic testing, but a geneticist to interpret whether that's a significant change or not. And so I agree, at this point in time, it's a very difficult, awkward area. And when we have positive, clear demonstration of the mutation that we know it confirms the diagnosis, that's great. But in most cases, we do not have that.
So moving on to the next question, we would like to know the experience of the availability of DHT preparation for local application in 5-alpha reductase deficiency and the results with that, sir.
That's a tough question too, because in the United States, it's not available. Even the compounding pharmacies that would produce it before will not produce it for a clinical indication. And also it's illegal for us to try to import that from Europe. So I would have to defer to someone from Europe to give us their experience, because that is available. There's DHT given the issue of giving it topically as well as injecting the DHT. I can say back in the past when DHT was available in injection form in the United States, I used that on a very few patients because that's the only ones I've seen, and that did not seem to help their genital development. So I can't answer that. Hopefully there's some Europeans that will answer it. And
sir, the next question is, sir, when should we consider a gender assignment surgery in the earliest, keeping in mind the infant's decision of sexual identity and to avoid litigation in future?
I guess we need to, if we're talking about gender assignment surgery, contrary to the gender assignment and genitalia at birth, is that what we're talking about when we're saying gender?
Yeah, so sir, they are asking gender assignment surgery at the earliest, keeping the mind of the infant's decision maybe in the future for sexual identity to avoid any litigation in future. So what's your take on that, sir?
It's that's very tough. It's very awkward, and it's very riskful, if that's a word. It certainly should not be done before a child is old enough to clearly express their gender. And you know, I feel, not in DSD, but in the transgender patients in the States, there are a lot of physicians that are doing irrevocable surgery for people in their teens when I'm certain that some of those individuals are going to regret that in the future because of their gender confusion and gender dysphoria. And so I would just say this all needs to be approached very much with caution, with informed consent of the family and the patients.
So moving on further, sir, how long to continue glucocorticoids in a non-salt losing CH in a boy after puberty? what are the concerns in the long run?
I would, in females with CAH, one should always continue glucocorticoids. And one can make a strong argument that in males, they also should continue glucocorticoids, even though it won't make a difference in their sexuality or their sexual function. It in fact might make a difference in their sperm production. And also there is a pseudotumor that develops that was known historically before glucocorticoids were available for treatment. Long-term lack of treatment results in a hypertrophy of the ACTH secreting cells in the pituitary gland that can develop considerable space occupation and impact on other anterior pituitary hormones. And of course, in males, there's the issue of the adrenal rests in the testis or along the spermatic cord, which would become increased in size. And so because it's an enzymatic defect and it's a persistent enzymatic defect, a lifetime treatment, one can argue for a lifetime treatment, but one certainly can shift to dexamethasone in most patients, and that works very well. Once one arrives at the dexamethasone dose, that dose should be adequate, but not too much for a long period of time unless the patient's health status or weight change.
So there are a few questions more. So a 4-month-old first of a twin 46XY DSD, 3 centimeter phallus, labioscrotal folds containing gonads bilaterally, symmetrical, no Wolffian structures and perineal hypospadias. Second twin is normal male. Both the twins have comparable levels of testosterone, DHT and androstenedione. Cortisol 17 OHP, LH and FSH limits are normal. So the LH, FSH, cortisol and 17 OHP are normal. They have been assigned as a male. So how do you want to proceed in this case?
I think I wouldn't change anything if I heard the whole. These are individuals that have testes.
Yes, sir.
I would not change the male assignment. Internal structures, did you mention those?
Yes, sir. So there are no Wolffian structures. There are bilateral gonads present, symmetrical, and perineal hypospadias is present.
Right. And so this is one of these, I would clearly continue the assignment as a gender assignment as male. It's one of these categories that we can explain the etiology at this point in time.
So moving on to the next question, should measurement of PRA and or PRC help in deciding whether mineralocorticoids should be added to glucocorticoids in CAH?
I would do those measurements, but if they were normal, I still might. I do that for baseline, so I would have a baseline, and obviously, if they were abnormal, use that to judge the satisfaction of the mineralocorticoid dose. If they were normal and I had difficulty suppressing otherwise, I still might add mineralocorticoid.
So, how to interpret AMH levels in the evaluation of DSD?
AMH levels are levels that, am I remembering correctly, they're levels that are high at birth and gradually taper down to the time of puberty. And so if they're going to be useful, they're going to be most useful at birth. And the presence of an AMH level is in the normal range at the time when they're elevated, I would say would be a confirmatory sign of future function.
So the next question is, sir, is there any role of higher dose testosterone in 46 undervirilized male with PAIS in infancy?
I don't think it will make a difference. A good full dose is going to stimulate the full genetic development, and higher doses than that aren't going to make a physiologic difference. They may cause some muscle hypertrophy and so forth, and problems in relation to excessive androgen therapy.
So what are the therapies to increase the penile length in PAIS?
I don't think there are any, sadly enough. So therapy can be used to see if there's growth at any age when one has this diagnosis, because that would be a positive thing to the parents and the child. But you know, there's really and nothing that is going to increase that penis size, either realistically, either medically or surgically. And so obviously it sounds awkward, but such a patient should be counseled that people have been able to find sexual satisfaction with a small penis using various other sexual activities. So.
Right. Thank you, Dr. Amat. If time permits, we would like to take some more questions, even for panelists. Dr. Abhay, this is for you. Being an Indian scenario, I think like the parents are will be very keen to know the sex of the baby as soon as the baby is born. But if the baby is born with an atypical genitalia, we would be in a dilemma to declare the sex. So, but in that scenario, how do we balance the urge from the parents to know the sex as early as possible, and our efforts to make an appropriate diagnosis and probably the most appropriate sex of rearing for the infant? Yeah. I would like to know the Indian context from you. Maybe then we can move on to Dr. Lee.
Yeah, thank you, Dr. Bijay. So the first thing is, any person coming with a abnormal genitalia, if it is 46XY, we'll try to search the gonads first. In the whether it is a labial, it is a perinous gonads in the it is palpable or not. If it is not palpable, then first thing we should go for a ultrasound to relocate the gonads, intra-abdominal gonads. Still, if you are not actually in a conclusion, you are conclusively finding a gonads, then you should go for either CT scan or MRI to locate that. Once you are locating a testis, that means you should, from the beginning, you can firmly tell the patient that the sex of rearing could be as a male. And of course, in vis-a-vis telling that, we have to do some tests, additional hormonal tests, because we know the most common cause is almost the congenital adrenal hyperplasia. If it is 46XY, then in that case, probably only 3-4 things like 3-beta-HSD, again 17 alpha hydroxylase or 17-20-lase, all those things come. So if you want from that point of view to tell whether it is CH or not, if patient is having how much virilization will be there in future, looking at these things, you can do a battery of tests. And from that battery of test, you can tell if patient is having these abnormalities, then patient can be diagnosed as CH, can be given some medications from the beginning, and then subsequently you can plan any sort of rearing. Otherwise, from the beginning, if you are palpating a gonad or if you are locating the testes, you can tell the sex of rearing could be the male.
Right. Dr. Lee, you would like to take that?
Was he answering your previous question to me?
Yes. So like this question, same question,
Yes.
like for
And
example,
so
we have
yes. And so I heard him saying that one needs to do a very careful initial exam, especially in relation to testes, and so learn as much as you can from physical exam, and also what testing that can be done promptly, such as an MRI, and report that to the parents. I think underlying all of this, it's very important to review to the parents at least a little bit of embryology so they can understand how such a thing can happen, and that they don't think it's something they've done wrong or some curse on them because their child has genital ambiguity. And so if people understand that the clitoris and the penis come from the same structure and it depends on the hormone environment, they can understand how a clitoris can be overgrown or clitoris undergrown, and the same thing in relation to the labia and the scrotum and that sort of thing. So I think to start out with giving the parents at least an attempt so they can understand what happens, and then tell them that there's tests we can do, and we will share with them what we learn from those tests, which will tell us what should be done for their child and what the sex of rearing should be. I think full disclosure, that's something that I didn't talk about much in the talk, but full disclosure is very important, at least in the United States, and I think everywhere, so the parents understand what's going on, that hopefully there would not be stigma in relation to that, and that hopefully that would help them understand how they can care for their child so they can have a healthy, well-adjusted life. So,
right. Thank you, Dr. Lee. And I would like to take up another question, like to Dr. Shaila. So, ma'am, like Dr. Lee told that AMH would tell something about the function of testes, but does it help to maybe reach at a diagnosis in a group of patients with 46XY DSD?
Does it help to
reach at the diagnosis in a given set of patients with 46XY DSD? Does AMH could be an useful parameter to distinguish the patients to reach exactly whether it's a 5-alpha reductase or it's a PIS or it is a testosterone synthetic defect? Can we reach to that level with the help of AMH, especially when you don't have a clear answer on the imaging?
So I
don't get that question.
I'm missing a little something about.
Right. So I'll come back with the question. The question is, the serum AMH level, especially in the infants, when we're not sure about the diagnosis in a XY karyotype infant, would the AMH level help us to distinguish the causes of 46XY DSD?
Okay, I understand now. Not necessarily more, I don't think. I don't think that could help you with an etiologic diagnosis. That could help, because there's so much, even within etiologic diagnosis, there's so much variation in terms of the function of the testes. And this would tell you something about the function of the testes.
Thank you, Dr. Lee. Shaila ma'am, and I think like I would like to know from you regarding this question. So like we talked so much about the surgeries, but one important surgery in patients with 46XY DST is gonadectomy. So when do you consider gonadectomy, and what are the factors which will determine the timing of gonadectomy in 46XY DSD? Dr. Shaila.
Yeah, the timing of gonadectomy is important because if they are streak ovaries, then the risk of gonadoblastoma is more. So there are criteria where we say they are high risk, intermediate risk, or low risk surgeries, especially for gonadectomy. So if the high risk surgery where or high risk category where you have dysgenetic gonads, so and also anywhere where there is a Y cell line. So if the Y cell line in gonadal karyotype where we have again TSPY mutations, and also wherever there is gonadal dysgenesis, 15 to 50% of high risk is there. Whereas when you compare the dysgenetic with the synthesis or the disorders, it is less risky. So dysgenetic is more common, gonadобластoma. So the next one, the intermediate would be the Y cell line in Turner syndrome or in 17 beta HSD, or if you have any partial androgen insensitivity with scrotal, so the risk would be more. So you would advise them to regularly monitor the size of the testis in the inguinal region. Whereas low risk, where you wouldn't advise gonadectomy, would be in the scrotal one. Even if they are streak, you would wait for some time, and also in the combined complete androgen insensitivity syndrome, and also in over-testicular DST, you may wait rather than rushing to do the gonadectomy in the fear of gonadобластoma. So basically, wherever there is a streak gonads, Y cell line, there is a fear. Whereas, and you see complete androgen insensitivity, you wouldn't do it because you want the same androgens to induce the secondary sexual characters. So you would delay, even though there is the karyotype and the gonads and the sex of rearing are different.
So I would like to come back to Dr. Lee for a specific question. For example, we have a partially dysgenetic gonad and we decide to continue to preserve it. So, but how intensively I can manage it to diagnose the underlying malignancies early? What are the parameters we can use to monitor for early diagnosis of malignancy in an at-risk gonad?
This is a dysgenetic gonad. Is it palpable?
It's a palpable one, but it's a partially dysgenetic.
Right.
For example, MGD, let's say.
Right. I think if it's palpable, by the way, the previous discussion about the risk was excellent, and I agree with it very much. With the mixed gonadal dysgenesis, as long as the patient is aware that there's some risk and that the gonad is palpable, and if there's any question about palpation, that some ultrasound or other studies be done, that ought to be addressed at least once a year, more often in the younger patient. But yes, I think it's reasonable to, well, it's a continuing shift comparing the risk and the advantage of having the partially functional gonad intact. And I think it's worth the risk to leave that, except for in those situations that we know that there's a very high risk. By the way, there's some more recent publications from Europe that delineate those risks very well. Maritime Cools is a co-author on several of those, and so it's worth all of our keeping up with that literature as time progresses.
Yeah.
The place where there is concern or there's disagreement that in the United States, more and more of the CAIS patients that have retained their gonads want to retain their gonads on into adult life. And I think it's their choice, as long as they realize there's some risk, and that risk is going to gradually increase the older they get. But that's a dialogue for discussion anyways.
Yeah, thank you, Dr. Lee. To continue further, yes, sir. Dr. Sadish, please take over.
Yeah. Sir, actually, I have one question for you. It's nearly 15 years since the consensus statement for intersex disorders were issued. Do you think there can be any further improvement on whatever has been published? Is it, what do you think are the drawbacks in the existing consensus statement and it can be improved upon?
Well, one of them that I alluded to was the nomenclature, because there's considerable argument against the term disorders. There needs to be input more than there was at that consensus statement. There needs to be input in relation to advocacy groups, support groups, and parent groups. But there is a big issue there that they don't want the terminology to imply that they have an abnormal condition. And they want to use the word variation and those sorts of terms. And if we use the word variation, we need to talk about whether it's normal variation or pathologic variation. And so I think there's room for improvement, hopefully, in the communications about these disorders, and hopefully in these parents and patients not feeling a stigma because they have an abnormality. There's certainly room for improvement in the other areas. Genetically, in terms of diagnosis, I think things may be dramatically changed in the future, to the point that for some conditions, it's the genetic diagnosis. If one can do a genetic diagnosis, it will save considerable testing on our part. There's the increases in relation to the possibility of fertility. And so I think probably in all realms, things will improve. I don't know about understanding of gender identity, whether we're ever going to understand what causes gender development enough so we can be sure that the assignment as a male and female at birth is appropriate. In the meantime, we need the parents and everybody needs to understand we're doing the best we can, and if it turns out that the patient has the opposite gender identity, we need to make sure that that's true, but deal with that when it happens. It's a tough situation. So.
Thank you, sir.
Very difficult question.
I think I would like to take one last question, as we are actually probably running out short of time. And of course, Dr. Lee already spoke a bit about these legal issues, but these legal issues are going to be country specific, and in fact in India they're also going to be region specific nowadays. So I may request Dr. Uma to throw some light on the specific legal issues in India, especially regarding the surgeries of DSD.
Yeah, this is actually this sort of problems we may be facing more in the coming years, as previously, because the question of, the parents, this even in India now, the parents deciding for the children that is going to go. And as children grow up and develop their own gender identity, they may want something and they may rebel against a decision which was taken earlier on. So in those conditions which are, say, likely to change the gender identity at the time of puberty, like 5-alpha reductase or 17-beta HSD, or maybe partial androgen insensitivity. In these cases, if we are assigning a female gender, and because parents are often very worried about the genitalia, they want to go for an early genital surgery because it causes a lot of distress to them. So that, I think, should be explained to the parents, that there may be a radical change at the time of puberty, and mutilating surgeries maybe should be avoided till the child is able to take a decision for himself or herself.
Thank you, ma'am. Just extending the same question to you, like, is there any role for GnRH analog therapy, especially when baby, like child is around 12-year, 13-year, entering into puberty, but he's not, able to decide what sex he should continue with. So as we're doing for gender dysphoria, can we use GnRH therapy in children with or adolescents with DSD as well?
That certainly could be used depending on the age of the patient, but it certainly could. And I would assume that the gender identity problems are, if they're not settled in early infancy, the time that they're going to be a question is during early adolescence, early puberty, and to delay that so irrevocable surgical changes, you can avoid irrevocable surgical changes, that's a very positive thing. So I agree with deferring surgery as much as possible, including for clitoromegaly in many situations. I don't think it's appropriate to, or I don't think it's ethical for the mandate to be said that absolutely there can be no surgery, because we don't know the outcome of that. We don't know if the individual, the comparison of the outcome of the best possible surgery versus no surgery. And of course, that all depends on what the gender turns out to be. But I think it's unethical to mandate no surgery whatsoever, although we all need to be very cautious about surgery, genitalia as well as gonadectomy that we talked about, because they were both irrevocable. You can't change them. So if GnRH analog would help, then it should be used. So.
Yeah, thank you so much, Dr. Lee.
There's a last question from sir. How commonly do you encounter non-classical CH? Is it true that we are missing or overlooking in our practice? And what's your take on stimulated 17-OHP? About the gray zone of 17-OHP, that's the stimulated 17-OHP, sometimes is in gray zone. So should the genetics be done in such cases where the 17-OHP is in gray zone?
Okay. There are a fair number of non-classical patients out there, and I don't know, I have the impression, at least in the different racial ethnic groups in the United, is that the Hispanic may have a greater portion of those non-classical patients, but I don't think we know. Again, the only way we can find out is to try to look for it And one would look for it, as I assume has been applied with a baseline of it, a 17-hydroxyprogesterone, and a stimulated level of 17-hydroxyprogesterone. And depending upon how much virilization is and how high the androgens are, I wouldn't hesitate, if it looks like they have elevated levels, to suppress them, or if their ACTH stimulation test results are equivocal, to do genetic testing, because of course heterozygote patients may have ACTH stimulation tests that are equivocal as well. And so one would need to sort those out. So again, I'd be careful about treating. If it's clear antigens that are elevated, they ought to be treated. One ought to be careful not to over-treat, however, because so many of those patients are put on glucocorticoids and end up becoming obese, and that causes other problems. So.
Thank you. So the last question for the session, I know we have extended time, sir. We have taken a lot of time. So the quick question is, any role of estrogen EDCs, that is EDCs,
endocrine disruptors,
causing DSDs, and do we have any clue to which condition is it most likely?
EDCs, you're talking about birth. What?
Endocrine disruptors, sir.
Oh, okay. No, I can't tell you. I can't answer that. I can't say there's not a role. In an earlier session, we talked about that somewhat. And
yeah, may I request Dr. Shaila to address this question? Any role for EDCs in etiopathogens of DSD? Shaila, ma'am?
I think yesterday Dr. Stefano was talking a lot about the endocrine disruptors. We see that these endocrine disruptors can cause, especially in the testicular dysgenesis. Basically, they have more role in the testicular dysgenesis syndrome. And in our own practice, I think in India, I don't know about US or Europe or any other places, we have seen when there is some of the cosmetic things which have got either bisphenol or phthalates, they have come with high 17-OHP or clitoromegaly in children. So which have been diagnosed as DSDs, but then careful evaluation, follow up, that we have ruled out these EDC consumptions, and then we have stopped the treatment. So I think a very good history, clinical picture, genetic test, all these things will help in ruling out the role of EDCs in a true DSDs.
Ma'am, is it the prenatal exposure you're talking about, or it's the postnatal exposure, ma'am?
More than the prenatal exposure, we have seen in our children postnatal exposures, because lot of our the lotions, powders, and in the maternal, actually perfumes, these all have been contaminated with bisphenols and phthalates. So I think it is very important, and many a times we do ask the patients to get all the medicines, not the lotions, creams they are using, and we have found these EDCs in them. So I think we have to be really extra careful before we label them as DSDs.
Right. I think you say it's more of a DSD mimics than true DSDs. Thank you so much, ma'am. If there are no more questions, any questions on the panelists to Dr. Lee? Would any panelist would like to ask any questions to Dr. Lee? Right. I think it's
only one question.
Oh, yes,
Mr. Lee coming to India?
Oh, I'd love to come. I would rather be there right now. When it's safe to come, I would love to, assuming I'm mentally and physically able. So thank you very much. Thank you.
Thank you,
Okay,
sir.
thank you, sir.
With this, I would like to thank Dr. Sadish, my co-chair, and also all the panelists. And I would like to hand over to the organizing committee. Thank you so much.
Thank you.
Thank you. Thank you, Professor Lee. Thank you, chairpersons and panelists, for the extensive discussion on disorders of sex development. I would like to hand over the further program to Dr. Rakesh Sai. Thank you, Dr. Rakesh Sai and Dr. Srinagesh, for giving me this opportunity to be a rapporteur in this session of DSD. Thank you so much.
Thanks. Thank you, Professor Lee. Thank you to the panelists, Dr. Shaila, Dr. Uma Saikia, Dr. Dr. Sadish and Dr. Vijay Sarthi and Dr. for being here, and also Dr. Amit Goyal for conducting this session wonderfully. I thank you all for this wonderful session. We will move on to the next part of the program, which is announcing the results of the posters and the oral presentations that were done. I would request Dr. Sethi to announce the winners of the oral papers.
Thank you, Rakesh. The screen is with you. The results are with you. How to click the buttons. I do not have the control. So yes, congratulations, Dr. Priyadarshini, for achieving the bronze medal for the oral paper presentation, Clinical Dimensions in Neonates, Normative Data. Congratulations, you have won the third prize. Dr. Vaibhav Pathak for achieving for obtaining silver medal in oral presentation on insulin resistance in type 1 and correlation with metabolic parameters. And the gold medal goes to Dr. Sandeep Kumar for the paper on the single center spectrum on neonatal hypoglycemia. Congratulations to everybody. And now we come to the poster presentation results. We again have three winners.
I would like to request Dr. Hari to announce these. Dr. Hari. Sir, please, otherwise, please go ahead and.
Okay, so to Dr. Shoaib Kaisar for achieving the third prize for the atypical presentation of a 46XY DST case report. Congratulations. Then congratulations, Dr. Abhishek Prakash for obtaining silver medal in poster presentation for a rare case of panhypopituitarism with persistent craniopharyngioma. Then the first prize goes to Dr. Anusha for her presentation on differentiating 11-beta hydroxydifferentiate from primary glucocorticoid resistance syndrome. So congratulations, everybody. And congratulations to every participant for having submitted their papers. It's not the ones who win that are important, but the participation in a race is more important, as happens in sports. Thank you very much. And sorry for having taken over from Hari because he was not, he just left present, I guess.
I would like to request Dr. Hari to say a few words. He has coordinated the entire, evaluating the entire all the posters and the oral presentations that we received. He has coordinated all of them, and he has taken quick to collate all the results and announce the and prepare the results. So I would like to say a few words to the participants.
Yeah, the quality of presentations were very good. Actually, the only drawback was there were less number of original studies, but the workup of all the case reports were par excellent. Actually, I mean, most of the case reports were included the genetic analysis and every possible step in the diagnostic algorithm was done. So, and most of the residents were confident in the presentation, except a couple of ones who exceeded their time. But I mean, as Bipin sir has rightly said, it is actually there's very narrow gap between the winners and actually the persons who didn't come onto this stage. I'm sure you will get better opportunities in the future endocrine meetings. Just keep submitting the abstracts and you will get to reach the podium very soon.
Thank you, Professor and Dr. Hari Kumar for your efforts, and thank you for the kind words to the participants. I would now like to request Dr. Sarita Bajaj, who has also joined us, to give a few concluding remarks.
Could you please start my video? Okay.
Yeah, to introduce Dr. Sarita Bajaj, she's the director and professor
I
and head
think we can skip all that.
of MLM Medical, and she's been president of the Endocrine Society of India, and she's well known to everybody.
Thank you. Thank you, Rakesh. Of course, Endo Update 2020, which is organized by Osmania Medical College, Hyderabad, and dedicated to pediatric endocrinology. Well, what can I say? I think I can candidly say that pediatric endocrinology has come of age. As a specialized branch, endocrinology began almost 5 decades ago. The Endocrine Society of India was established in 1970, but compared to internal medicine, the development of subspecialties in pediatrics has tended to lag behind. Even though interestingly, there is mention of possible endocrine conditions and interventions which are listed in the ancient texts of India. Precocious puberty is described in the case of Mandhata, who was fed by milk from Lord Indra, and he experienced an accelerated growth. Within 12 days, he looked like a 12-year-old boy with a height of 13 cubits. So pediatric endocrinology has evolved as a subspecialty during the early 20th century. Pediatricians interested in specialization, they went abroad for training, and on their return, they worked hard to carve a niche for themselves in teaching institutions or multi-speciality private hospitals, often looking after pediatric problems while pursuing their respective speciality. So APs, that is the Asia Pacific Pediatric Endocrine Society, which included India, was mooted by pediatric endocrinologists in 1997. So the first national conference was held in 1986 when there were about 300 delegates, and the second, that was an international one, in 1989. They were both held in Mumbai. And with growing interests in the field of pediatrics, IAP was formed, and then the Pediatric and Adolescent Endocrinology chapter of IAP with 50 initial members was established in 87. The Pediatric and Adolescent Endocrinology chapter of IAP was established, like I said, in 87, but the legal name, that is the ISPAE, Indian Society for Pediatric and Adolescent Endocrinology, was adapted in 2007. So during these conferences, it is conventional to have a 2.5-day of endocrine residential training program. So currently, if I'm not wrong, there are about 150 pediatric endocrinologists, and the number is grossly inadequate. Think of Israel with a population of about 9 million, and they have as many pediatric endocrinologists. So anyway, now we have pediatric endocrinology fellowships of 1 to 2 years duration across several cities, even in Lucknow in Uttar Pradesh, and that is adding force to the specialty. Childhood and adolescent age group up to 18 years constitutes up to 46% of our population. And though endocrine disorders in children individually may be uncommon, in comparison to communicable disease, given the large population, absolute numbers are likely to be high. So amongst the pediatric referrals, we have short stature, thyroid disorders, obesity, DSD, early and late puberty, type 1 and type 2 diabetes in children as well, PCOS, metabolic syndrome are emerging public health problems, and thinking of small for gestational age, which is also a considerable proportion of newborns, up to 1/4 of them. This is assuming a large public health dimension because of future metabolic problems. So as with most medical disciplines, pediatric endocrinology involves a lot of teamwork, interaction with adult endocrinologists, pediatric surgeons, neonatologists, gynecologists, geneticists, community counselors, psychologists, social workers, family physicians, radiologists, pathologists, and trained nursing personnel. With Professor Rakesh Sahai as the organizing chair, Professor Bipin Sethi as the scientific chair, Professor K. Neelavani, the organizing co-chair, and Sri Nagesh as the coordinator, with advisors like Dr. K.D. Modi, Vijay Shekhar Reddy, Dr. Prasun Dev, Dr. Raman Bodula, Dr. Pri Srinivas Rao, and Dr. R. Santosh, Dr. R.N. Mehrotra. This was a scientific extravaganza, as was expected. Like Nagesh has just sent a message that it is a dream come true to have organized such a big pediatric endocrinology update. So endocrinology update 2020 went beyond that. The session on growth lessons from 60 years follow-up of patients with Laron syndrome was by no less than a legend, Professor Zvi Laron. Another luminary, Dr. George Chiprusos, spoke on a syndrome which is christened by his name, that is glucocorticoid resistance, diabetes in the young, insulin and glucagon therapies, prediction and prevention of type 1 diabetes, hyperinsulinism in the neonate, correlating molecular and genetic aspects, children with fracture, monogenic obesity, disorders of puberty, DSD, endocrine disruptors. They were a real treat to listen to. The virtual poster tour, oral and poster presentations were very impressive. Thank you and congratulations to the extraordinary team for organizing this impressive update on pediatric endocrinology. The interaction and panel discussions were outstanding. Please keep up the momentum. Yes, there are always miles to go, but every step taken so far has been in the right direction. Thank you. Thank you very much. And of course, thank you to USV for their constant support. Thank you very much.
Yes, Nagesh.
Thanks a lot for the opportunity, sir. As ma'am put it just now, it has always been not just my dream. Right from the time I joined as a postgraduate in 2009, Rakesh sir and I always we used to see a lot of cases of pediatric endocrinology in Usmania. And it was always our dream to do a pediatric endocrine meeting. In fact, a lot of people might be surprised to know that almost 30 to 40% of all people who do a DM in endocrinology come from a pediatrics background, MD pediatrics. In fact, when I was doing my DM, my senior, my junior, and I, all three were pediatricians. So, unfortunately, what has happened is ESI has tended to focus more on adult endocrinology, and we have kind of neglected pediatric endocrinology. Other societies have taken up the onus in pediatric endocrinology, and later on, as I started, I passed out and I started practicing. Rakesh sir, Kalra sir, and I, we always used to discuss this thing that one day we should do a pediatric endocrine meeting. And it is time that Endocrine Society also took up the stewardship and the leadership in pediatric endocrinology also. Finally, with such a meeting, it has become our dream has to a great extent come true. And the only thing I can request all my colleagues and my friends is we have superb faculty even in India in Endocrine Society in pediatric endocrinology. The panelists, the chairpersons of the last 2 days have been a superb faculty who have been no less when compared to the international faculty. We got a huge pool of potential pediatric endocrinologists in Endocrine Society. It's now time that we, the seniors, and also the aspiring students step up to the plate. And finally, we have to release pediatric endocrinology from the neglect it has suffered all these days and take it up as a priority project for all of us. This is the only appeal I can do to you. We are going to have a national live update next year. And I'm sure with the cooperation of seniors like Sarita ma'am and a lot of other luminaries in the Endocrine Society, we are going to go with greater strength and greater force towards our destiny in pediatric endocrinology. Thanks a lot for the encouragement, ma'am.
Thank you, Dr. Nagesh. Now I would like to request Dr. Neelavani to give a vote of propose a vote of thanks as we're coming to the end of this meeting.
Thank you, and good evening, everyone. We all have enjoyed Endo Update 2020 virtually, a great 2 days academic feast on pediatric endocrinology, and we had wonderful deliberations and very insightful and very useful discussions on various aspects of pediatric endocrinology from all our esteemed and eminent international and the national faculty who are the best in their respective areas. And on behalf of Organizing Committee Endo Update 2020, Department of Endocrinology, Usmania Medical College, Hyderabad, and Telangana Endocrine Society, I would like to, in the sense, we wish to express our gratitude. First of all, our heartfelt thanks to all our esteemed and eminent international faculty, Professor Laron from Israel, Professor Francisco Chiarelli from Italy, Professor Stefano Cianfarani from Rome, Professor Khalid Hussein from Qatar, Professor Linda A. Dimiglio from Philadelphia, US, and Professor George P. Krausis from Greece, and Professor Peter Lee from Pennsylvania, US, and our esteemed and eminent national faculty for sharing their great expertise and very insightful and useful thoughts with all of us. A big thank you to all the international and national faculty. And again, a big thank you to all our rapporteurs who are our young endocrinologists from our country for their effective and well-coordinated effort in conducting the sessions very smoothly and successfully. And again, a special thanks to Dr. Hari and Dr. R. Santosh for coordinating the poster as well as oral presentations effectively in coordination with the judges. And our sincere gratitude to USV Pharma for their great and constant support. And finally, again, a big thank you to all our participants and all the people who are involved to support us technically, and all the people who are involved either directly or indirectly in making this event a very grand success. Finally, in the sense, I cannot stop myself in appreciating the great efforts put in by Professor Rakesh and Dr. Sri Nagesh in conceptualization and execution of this event with the guidance from our senior faculty and other members of our Endocrine Society Telangana. So really, in the sense, a great appreciation from my side for both of these, Rakesh and Sri Nagesh. And thank you each and everyone, and stay safe. Thank you.
Mute, unmute, Rakesh, unmute. Rakesh, yeah.
Thank you, Neeravani, for your kind words of proposing the vote of thanks and mentioning everybody who has contributed to this meeting. I thank everyone, and I would like to close the meeting. Thank you all.
Good night. Good night.
Thank you. Good night.
Good night, Nagesh. Yes, we.